Good morning, sir. Good morning, ma'am.
Hello,
sir, are the cities? Hello, Michael.
Hi. Somehow my even if I turn on my video, my face is not showing up on camera. Sorry.
Now you can try again.
Okay.
It's fine. Bhavesh, sir, are our series ready? CVs ready?
Hello, good morning.
Hi, ma'am. Good morning.
Hello, how are you?
I'm good, thank you. Dr. Siddiqui, good morning.
Hello, good morning from Pakistan.
Welcome. Good morning from Bangalore, India.
How are you, ma'am?
Very good. And how are you?
Fine, fine.
Looking forward to your talk.
Definitely, definitely.
Very few people are doing virtual immersion in our part of the world. So
Pakistan is the same situation.
you're doing something. Yeah, nice.
Bhavesh, sir, can we have slides? Yeah. So after 5 minutes, we should start.
Hello, good morning, Sonal.
Good morning, sir.
So all set?
I think so.
At least today the starting troubles are not there.
Yeah. So we are much better today.
The computers have got used to the thing now.
Okay, good.
Two more minutes to start, I think. So we can wait for more time, ma'am, till other volunteers, other participants join.
Your call. You see how it goes because we can't see. It's whatever. I mean, we'll wait for a couple of not more than 3-4 minutes, I think. Huh?
Okay,
Then
ma'am.
delay the whole program afterwards.
Yes, ma'am. Sure.
How many
We are ready then.
participants have joined? I see a figure of 11 here.
So we start.
I think so.
Good morning, all. Welcome to AOCNR 2021. And here we are having exciting session on dementia rehabilitation. We have a very excellent, wonderful, enlightening chair, Dr. Suvarna Alari, and esteemed faculty who would be taking us through a lot of understanding of current aspects of dementia. I call upon Dr. Surya sir to just give opening remarks, please.
I hope he is not muted.
Dr. Surya? Sir, can you give me opening remarks?
Yeah, I think today's session is quite interesting.
Deepak sir, yeah.
Yeah, and so we'll be having a symposium on dementia, on symposium on disability assessment and certification. Then we'll have a guest lecture, then symposium on neuromuscular disorders. And I would welcome all the guest speakers today and the delegates. And I will hand over the mic to our coordinator, Dr. Sonal, to go ahead with the proceedings.
Okay, sir, thank you. So we have a chair coordinator of session disability dementia. This is Dr. Professor Alladi Suvarna. She's professor of Department of Neurology, a well-known cognitive neurologist of India with a pioneering work in dementia rehabilitation from a Deccan ARDSI clinic, memory clinic. She has a fellowship from cognitive neurology in Cambridge under John Hodges. She has more than 100 publications in brain, neurology, stroke to her credits. She's a principal investigator for many esteemed projects. She has many honors and awards to her credits. She has a more special interest in aphasiology, dementia, and stroke rehabilitation. Ma'am, I welcome you. Please go ahead.
Thank you, Sonal, for the kind introduction. And I'd like to thank Dr. Nirmal Surya, Dr. Deepak, and organizers of AOCNR for organizing this symposium on dementia. And I'd also like to thank all the esteemed speakers who have come from different countries together to share our knowledge about how we manage dementia, similarities, dissimilarities, and so much to learn from each other. So it's indeed my privilege to provide a very brief overview about dementia care. And here goes. So can you see my slides?
Yes, ma'am.
So I think what we have learned over the last few decades is that from dementia not being known in India in 1980s or in low middle income countries in the 1980s, except for an occasional case, now we know that the numbers of people with dementia are the highest in our countries, and they're going up rapidly. Although this phenomenon is happening globally, the trends in the Western and or more developed world is that the prevalence is actually stabilizing or sometimes even coming down. So we have this situation where we are in a position where we have understood that while the burden of dementia is very high, there have been breakthroughs in our understanding, and there is some hope now that we can actually make a difference in preventing dementia, in managing them much better to slow down progression. And over the last 2 decades, and most of the work has come from different countries, that we have built evidence that actually prevention and care makes a difference. So this evidence has now been consolidated, and we are again in a hopeful position where we can actually implement all that we have learned to help the rising population of people with dementia. So from a position of extreme nihilism, we are all very hopeful. But what we know is that the solutions are not conventional, they are not unidimensional, and we cannot have one approach for all say societies and all situations, or even within a society for different people. So we know that dementia is multifactorial pathophysiology. It's not just amyloid or tau, there's vascular, there is TDP43, there is so many other pathologies, so many other etiologies. Clinically also, it's not just memory loss. There is such a range of behavioral and cognitive symptoms that can occur. Understanding dementia requires an interdisciplinary approach. It's not just either the neurologist or psychiatrist or speech therapist that will understand the disease in its whole. It's collaborate. And most importantly, management has to be interdisciplinary. And unless we all come together, research evidence is not going to be produced, which is meaningful to people. So therefore, it is collaborative in research. So this is our understanding over the last 2 decades or so. Care of dementia is and should always be person-centered. It has to be the person with dementia is at the center of everything that we do, as we speak about it, as we devise methods to help people with dementia. I think this is one thing that we all have to hold in our minds while we develop strategies. And then it is multidisciplinary. So while there is a role, significant role for each of these components, whether it is medical, diagnosis, pharmacological, biological, and rehabilitation, role for long-term care services. And then prevention is such an important part, because every time a person with dementia comes to us, the son or daughter asks us, is there something we can do to prevent it in ourselves? And then the most important thing is policy that will really impact the person with dementia. So our journey started in 2006 when there was a first lady. She was an artist, an English professor, our inspiration, who developed frontotemporal dementia, and we were seeing her. And at that time, there was very little evidence that anything would really make a difference. And we started talking to her. We realized that it was more a problem of expression. And then as we started talking to her and doing speech therapy, a lady who had not spoken for about 5 to 6 months, suddenly when we said Raat, that is night, she would say Din, that is day. She would complete sentences. She would, when you give her a stimulus, she would respond. And then the hare and tortoise story, when we said Khargosh aage aage, that means when the tortoise is going ahead and then the rabbit is staying behind. So slow and steady wins the race, she said. So it was a revelation for us. She started painting, she started singing. So we realized that we could actually make a difference for a person with dementia if we really understood the disease and if we cared enough. But what we also know now is that it cannot be done by a single person. It requires a whole society, community to actually reduce the problems that a person with dementia or their family have. And I think this is where advocacy and working together, like this meeting here, where Dr. Nirmal Sulia consistently has multidisciplinary programs. This is rare. And I think this is something that we really need for any neurological disorder. So this was the caregiver support organization that we formed to provide care. And this has happened in many, many places, cities, many countries, and advocacy has played a very important role in providing care of people with dementia. So if you want to provide care with dementia, if there are neurologists or anybody, it has to be done in a multidisciplinary manner. And as neurologists, when we look at for us, this is we go to the American Academy of Neurology guidelines for care of dementia. And then you can see that in addition to pharmacotherapy, there is a significant role for educational interventions and for rehabilitation and requiring cooperation among professionals. Therefore, when we talk about how do we provide care for a person with dementia, it's important to know the range of problems they may have that we have to provide care for: loss of memory, difficulty in planning, not able to initiate activities, not able to understand what is told to them, and They can't do complex activities, constantly disoriented to time or place, cannot express even basic simple needs in advanced stages, problems in performing the simplest of activities like brushing your teeth or holding a cup, poor coordination, and then behavioral disturbances, a lot of mood fluctuations, agitation, disinhibition. So there are several problems that we need to provide care for in dementia. And my slides are not moving. Why is that? Right. Science has really helped us understand how to provide care. We have moved from the concept of disability to ability. We know that the brain has tremendous capacity for neuroplasticity, and the brain can reorganize itself with help. And there is evidence that cognitive interventions delay progression of dementia. And a lot of care now is being driven by an understanding of brain behavior relationships and mechanisms of injury, how they react with disease and recovery due to neuroplasticity. And the rationale for one of the most important components of dementia care, which is functional rehabilitation, is that people with dementia can retain their ability to learn, hold on to information and skills despite their memory difficulties, and certain forms of memory or cognition are preserved, and therefore interventions aim to build on areas of relative strength and focus on residual cognitive abilities, and therefore help them use their retained functions to improve. And in those areas that do not improve, we have to compensate by the environment, from external aids and support. And the principles, therefore, are an individualized approach. Not one person with dementia is like the other. They come with their memories, their experiences, their habits, their disease processes, their environment, the kind of support they have. So therefore, which socioeconomic status they're in, which country they're in, what kind of support system is there for people with dementia. And therefore, we need an individualized approach. The aim is to reduce functional disability. We have to involve families, cannot work in isolation, and we need to develop personally relevant goals, and they have to be implemented in real world settings to make a difference. And we have to use a combination of optimizing and compensation. And as I mentioned, understanding the person for what they are, valuing them, and then caring for them, treating them as individuals, find out what were their hobbies. Was he somebody who loved gardening? Was it somebody who used to sing? Was it somebody who used to enjoy reading or listening to or writing stories? So you have to really know what kind of person they are to develop those rehabilitation strategies in a positive social environment, place ourselves in the shoes of the person with dementia, look at the world from their perspective. And this approach has shown reductions in caregiver burden and reduction in problems, as well as improvement in cognition. Some of the examples are reminiscence therapy. This is a memory box where you have what the person can remember of their past, which will stimulate their minds and kind of retain and retrain their brains to perform better. And this can be very deeply satisfying. And this we found also reduced caregiver burden. So these are some of the examples that one can actually implement in people with dementia, which are very simple, which don't cost much, which just require little time to be spent. Speech therapy is very important for the loss of language in dementia because communication deficits are disabling, and speech and language therapists play an important role for individuals with dementia. And the aims are to reduce demands on impaired cognitive systems, provide stimuli that evoke positive facts, memory, action, and emotion, focus on strengths, as I mentioned, focus on stimulable linguistic cognitive processes to maintain or slow cognitive decline. So these are some of the cognitive communication aids, how we even talk to a person instead of asking him, what have you been doing? What did you have for dinner? To say, did you have this or that for the dinner? And then you can have simple communication books. You can have more fancy technology devices for helping a person communicate when they have dementia. So this is a model that has been developed by, I'm speaking on behalf of many people that I have learned from. Dr. Urvashi Shah, some of her information from her slides will be there. Priya Thomas, the psychiatric social worker, speech therapist, Darshini. So I'm speaking, and caregiver. So this is something that our psychiatric social worker, Priya Thomas, had kind of sensitized me to, which I think makes so much sense, that as the disease illness changes, so do the caregiver responses. In the beginning, it's the implications of misdiagnosis and inappropriate treatment that delays intervention and produces a lot of safety risks. Then there is a kind of socioeconomic burden on the family, preventable crisis, people may get lost. And then the emotions of the caregiver in response to these crises, problems again in the family, leading to higher and higher levels of caregiver stress and social isolation of the person with dementia and the family. So this is something we have to be aware of when each time the person comes to us for a follow-up. We have to see at what stage the person is in, at what stage the caregiver is in, and therefore the focus is on caregivers, family caregivers, especially in countries like India, where families still are the cornerstone of management. So we have to provide basic information on dementia to the person, family, what it means to an individual, train them and empower them with skills to manage the person with dementia, support them with psychological counseling to mitigate distress, and enable referrals to accessible and affordable resources for enhancing care. So therefore, dementia care requires continuous ongoing support, and that's why it makes it so challenging and also interesting for us. We want to be meaningful to our patients. So every time a person walks in, he has a new problem to solve. It keeps us engaged, but we just have to ask them how they are, and they will tell you, and you will realize that you need to provide solutions each follow-up. And as I mentioned, and then finally, do all persons with dementia respond to this in the same way? No, there is this concept of cognitive reserve. Some people are a little more resilient to the disease process than others. And therefore, the improvement levels that you see for the same level of disease, for the same level of input may vary. And this is because of the inherent resilience of the brain to deal with disease that could come from higher levels of education, from a person who's already engaged with socially engaging activities, physical exercise, being able to speak two languages. So all of these things actually impact a person's response to rehabilitation and care. And this is something that we need to keep in mind. We need to develop evidence that care processes work. Otherwise, we will not be able to influence other practitioners. And cognitive stimulation therapy, which is coming in, there is evidence from cognitive stimulation therapy, even in the Indian context, that it actually may help to engage a person with complex social, leisure, physical activities and delay the progression of dementia. And therefore, this is as part of an international project called STRIDE. We are looking at what interventions for dementia work in low middle income countries. And therefore, we hope that we will be able to influence people to implement them. Long-term care, I know these are concepts that are very strong in countries like Japan and Europe, where people from the very beginning invest in long-term care, understanding that the older we get, the more need for care. And therefore, this is a concept that we need to start talking about in India as well, and many other countries in Asia, where we understand that as the disease advances, there will be a need for advanced care. And this is currently happening in families with a lot of burden. Therefore, we need to provide insurance schemes, government support, social security for providing long-term care. And therefore, I would like to end with the World Health Organization Global Action Plan for Dementia. There are 7 action areas, and we need to link policy to individual care. So unless there is change from the policy level, it will really go a long way in helping an individual patient with dementia. And with this, I'd like to conclude by saying that there is emerging evidence that dementia care is multidisciplinary in nature, person-centered, has a potential to increase the duration of independence and reduce healthcare costs. I'd like to thank so many people that work together to make this understanding possible, our patients, funding agencies, NIMHANS for providing us a framework where we can do this kind of work. Thank you very much.
Yeah, thank you, Dr. Suvarna. I think you are chairing this session, so you go ahead with introducing the other speakers. The slides will come on the introductory slide will be put on the screen.
Sure.
Bhavesh, kindly introduce, put the slide of the next speaker.
Do you see my slide?
So, yeah. Yes, we do.
Yeah.
All right. So it's a pleasure to introduce Maiko Sakamoto from Japan, who is going to tell us about, who's a neuropsychologist. She is going to tell us about how we evaluate dementia and rehabilitate. And both of these areas are of very much interest to all of us because they have a significant cross-cultural perspective. And we were very excited to listen to what, and Japan is one of the countries, I have many friends there. It's one of the countries that is very advanced in elderly care, understanding older people, and dealing with dementia. So we look forward to your talk. So please go ahead. Thank you.
Thank you so much for such a kind introduction, and I'm very honored to be part of this presentation as well as discussion in dementia care. Thank you very much. Today, I'm going to talk about dementia evaluation and rehabilitation in Japan, what we are doing here, how we are dealing with dementia. I'm going to go over 4 topics today. First of all, overview of dementia in Japan and dementia evaluation in Japan, and rehabilitation for Japanese dementia patients and family members. And lastly, I'm going to talk about challenges for dementia care in Japan in the future. So as you all know that we have one of the longest average lifespan. So Japanese women, their average lifespan is 87.45 and Japanese men is 81.41. And these numbers are 5 years longer than 30 years ago. So what caused this? So maybe due to improvements in medical technology and cares, and also too, we ourselves, we increase awareness about health. So, we used to say you're old, you don't need to do anything, but then many elderly people I see in gym exercising a lot. And also too, we try to eat healthy food. These are good news. However, on the other hand, we are facing a super aging society. So dementia is one of the serious issues that we have in Japan. So in 2020, 6 million people living with dementia, but this number is going to go up. So it is expected that by 2025, 7 million elders are going to be diagnosed with dementia. So this number means that out of 5 elders who are over 65 is going to be diagnosed with dementia, and they have to live with dementia, which is kind of scary. When we talk about dementia, there is only not just one, but subtypes. So we have to pay attention to that. So until 1990s, we believe that in Japan, the dementia patients are more vascular dementia than Alzheimer's disease, but this number has been changed. Maybe due to nutrition, we eat a lot of salty food and cause vascular diseases. But then again, because of our awareness of what we eat, how exercise. So maybe the number has been changed. So based on the data from Minister of Health and Labor and Welfare from 2019, dementia patients, out of dementia patients, 68% of the people are diagnosed with Alzheimer's disease and 20% vascular dementia, 4% Lewy body dementia, and 1% is diagnosed with FTD. So number has been changed, and also it's become more consistent with Western research data. So now what we are facing in Japan is called Roro Kaigo in Japanese. So this means that older people, actually they have to look after very old people. So in this slide, in this picture, a husband is taking care of his wife, but not only between spouses, but also to their own children are becoming older and becoming over 65. So one occasion that I have seen in my clinic is that actually there are 2 patients with dementia, Alzheimer's diseases, and that's mom and daughter. So mom was 95 and daughter was 65, something like that. But they both were diagnosed with AD, and they are now living in the same nursing home, being taken care of. So we are facing that even older people have to take care of older spouses or parents. And actually, even those like sons and daughters, they need their own medical care, which is very serious. Now I'm going to switch to dementia evaluation in Japan. So as other countries, we use a multidisciplinary approach to evaluate dementia. So me as a neuropsychologist, I conduct a neuropsychological test, IADL tests. We use imaging and physical checkups. So in terms of neuropsychological tests, in Japan, oftentimes we use screen tools first. So mini mental state examination, Hasegawa Dementia Scale Revised, which is very similar to MMSE. And nowadays we switch to Montreal Cognitive Assessment, MoCA. As you all know though, these are screen tools, therefore they have very low sensitivity. So unless the patients show kind of more severe dementia, we may not be able to pick up them score-wise. And also these screen tools cannot localize cerebral lesions or differentiate subtypes. So oftentimes we add more tests such as FAB, trail making test, clock drawing test, animal naming test, and geriatric depression scales in order to differentiate subtypes. However, it is worthwhile to note here that these many neuropsych testing in Japan lack norms developed based on Japanese individuals. And even if there are norms, oftentimes they are developed with very, very small sample sizes. So when we conduct neuropsychological tests and looking at the result, we really have to be careful how to interpret these results. Nowadays, in both clinical settings and research settings, we started using more and more ADAS-Cog and R-bands because these are more complicated, more overall. They have variety of tests within, and also they have good norms developed based on Japanese individuals. In terms of ADL and IADL tests, it is ideal to ask the patients to do everyday activities in front of examiners, but unfortunately, we lack examiners, but also to time and space. Therefore, actually asking patients to do IDL activities in front of examiners is very challenging. Instead, what we do is just conduct questionnaires such as Lawton-Brody, ADL and IADL scale, functional status questionnaire, and clinical dementia ratings. However, as you know, that these are questionnaires, therefore they involve more subjective opinions. What's more, due to our Japanese culture, for example, the sons and daughters who brought their parents, they feel they should not talk about negative things about their parents. So such that, she used to do this, but now she can't do it, or she's very forgetful, or she almost, started a fire, something like that. Maybe this is out of respect to their parents, but also I have to admit the fact that in our culture, we have stigma against psychological problems, mental disorders, and neurocognitive disorders. And also the other thing that I was very surprised when I moved back from America to Japan, that some old male patients actually they told me that they never did house chores. So this is part of our culture that, their wives and their homestay moms, so wives took care of everything. So they did laundry, they did, shopping, cooking, even preparing clothes for their husbands. So it is very, very challenging, difficult for me to compare pre-dementia, so baseline, and current IDL functions. And some of you may feel, what about work? You can ask how they worked when they're younger, but by the time they come to our clinics, then they are retired several decades ago. So even this talk, asking about that, like current situations and 20 years ago, is not really helpful. So it is very hard to compare between baseline and current situations. The other thing is that even if those grown children recognize their parents' cognitive decline, they tend not to take the parents to memory clinics if the parents say, no, leave me alone, I'm fine, don't talk about that, I'm fine. So again, maybe this is out of respect. So what I see at clinic often is that those patients have already developed dementia. So I see the clear decline in neuropsychological or IDL functions, which is very sad. I wish they have come much earlier. So in Japan, I have to say that we have difficulty for early diagnosis and intervention. In terms of rehabilitation for Japanese dementia patients and family, we found that having personal goals is very important amongst elderly people. And there are actually research papers stating that even having personal goals amongst elderly people, they prevent MCI or dementia. So even amongst dementia patients, we try to develop tools to be able to help the patients to develop their personal goals. So I just want to introduce one cool application, which is called Aid for Decision Making in Occupation Choice, so ADOC. So this is an iPad application invented to help patients develop their personal goals. And this application have 95 questions, but those questions come with illustrations, so very, very easy to understand, even people with dementia. And by using these pictures, explore what they want, what they wish. And in order to use this application, the patient has to have score of 7 or greater on MMSE. And as you know, 7 points is pretty low. So even moderately or severely demented patients, they can actually use this application. Of course, we always have trained therapists helping the patients and walk through this application. What we do is we try to prioritize the goals based on importance and urgency. For example, if the patient has severe BPSD problem, and we talk with patient and their family members and try to see which goals are more important or priority amongst all other goals. And we try to clarify and set goals by using 5W and 1H. So when, where, who, what, why, and how. This is very important because setting up very concrete goals are very easy to manage. So I believe that assessing relationships between cognition, IADL, and BPSD routinely is very important. Not only just the beginning of rehab, but also to routinely, like every 3 months or 6 months, we assess these relationships because they are very intertwined. They related very deeply. So I am showing the picture right here. This is ADOC, and there is an English version too. You have to pay for that, but it's not that expensive. We have other approaches and techniques for dementia rehab. So already Dr. Aladi mentioned, but we also use a life review and reminiscence, which is developed by Dr. Butler in 1963. So when we think about Japanese elders, they are usually survivors of World War II, and they have painful experiences. They lost everything. They have loved ones die during World War II, but also too, on the other hand, the current Japanese society was built on their hard work and their effort. So they also have happy memories. So me personally, when I do luminescence sessions with patients, I try to be careful how I word, but this session is very helpful because they help the patients reduce confusion and anxiety, and also they seem to really enjoy the sessions. And also too, as newer technique, I want to introduce two. One is cognitive stimulation therapy, and the other one is cognitive training. So CST is what we do is throw the patient's favorite activities such as calligraphy or listen to music, singing songs, and all that. These activities actually stimulate multiple cognitive domains using 5 senses: listening, smelling, looking at the informations. So again, the patient seems to really enjoy the sessions. And the other one is CT. So we work on targeted neuropsychological domains such as memory, attention, executive function, and so forth. What we use more concretely is that we use Sudoku and puzzles, but also we use Kumon. Kumon is actually sample but repeated calculations that some of you might know. But these activities really help the patients to really stimulate their brain. Other than that, we use different techniques like music therapy, animal therapy, light exercise, nutrition therapy, and so forth. We use any techniques and tools if it's available and research papers show effectiveness. So when I think about these therapies and different techniques, there are keywords. So these techniques and approaches seems to reduce anxiety and irritations amongst patients, but also to help them relax and reminiscence to enjoy their own lives. Lastly, I want to touch a little bit about challenges for dementia care in Japan. So as I mentioned earlier, we have aging society, but at the same time, we have a decrease in birth rate. So we are facing financial and elderly care crisis. So what's important? Of course, the elderly's well-being and being able to live by themselves independently is very important. So in terms of prevention, we invite elderlies to different activities such as mahjong, shogi, dance, swimming, and so forth for prevention for dementia and frail. And these activities most of them free to participate, and also we provide free transportations because many elders in Japan, they don't have car, they don't have driver's license, they return to police. And so, we try to provide free transportation, which is very important. Also sometimes we have games and tournaments so that the participants really enjoy small gifts or small rewards by participating in those games. And research papers, including my paper, we are able to show that the participants or elders, they significantly lower their depression, significantly improve their cognitive functions, and reduce hospital visits and so forth. So, we see a lot of positive results from these activities. I just want to show you some pictures of mahjong class that we do in Saga City. So up here, so there's a teacher, he's teaching mahjong rules to participants. So they have to learn rules at first. And after each session, they go and sit down at the table with 3 other participants and they enjoy playing the mahjong games. And also I want to introduce our Orange Care plans proposed by our government. So because we are facing the super aging society, the government proposed these plans such that developing plans for prevention, treatment, and rehabilitation for dementia, creating safe living environment for overall elders, and training dementia supporters and care managers. But as you know, these 3 points, the first 3 points, they seems to require times. We need time to train people, train professionals. So while we are doing this, what can we do? We try to come up with some ideas that we can do in society, local level. So now we are developing local support teams and opening dementia cares to provide more useful information and psychological support for patients and their families. And actually, so far in Japan, over 8,000 dementia cafes. And I just want to introduce one picture. This was from newspaper in 2019. So actually, this lady in orange apron, she's 94 years old, and she is a patient with dementia, and she's taking orders from visitors. And as you can see, this little girl next to her, she's a local kid that she's actually helping the patient to take orders. So the patients also feel that they are part of society and contributing to something to the society. So what we try to do here in Japan is that we as a society, we can protect and care the patients with dementia. So as we all know that in June 2021, a new AD medication was granted by FDA, which is great news. However, I have to say that the medication is still expensive and it's unclear about side effects, what kind of side effects they will have. And we don't know a long run influence. So I believe that our societies will continue to cope with dementia. So what's very important to take care of patients and their families? So dementia rehabilitation is so essential and important, and we have to provide good quality support to not only patients and families. And also Dr. Aladi mentioned earlier that the patients and family members have to be there at the center of the treatment. And we all as a multidisciplinary professionals that we support them. And also to educating society as a whole on dementia is so crucial. Again, we still have stigma against neurological disorders and mental illnesses, and we really have to get rid of that stigma in order to provide better care and understanding for dementia. Thank you so much for your attention.
I welcome Dr. Ganguly. Dr. Ganguly would be chairing session ahead. Good morning, sir.
Hello, good morning. Am I hearing?
Yes, sir.
Good morning.
Thank you, Marco. It was great talk.
Thank you.
Good morning, everyone. A big thank you to the organizing committee to bestow such a big honor on me to be a chairperson for the symposium today. The third speaker of the day is Dr. Furkan Ahmed Siddiqui, speaking on immersive virtual reality of memory. What is the way forward? I welcome Dr. Furkan Ahmed Siddiqui.
Hello and good morning, everyone. Thank you so much, Dr. Nirmal and all the AOCNR team for inviting me for this keynote. I would like to play my recorded presentation here, please.
Mansi, can you please share the slides? Mansi, is recorded link slides are ready?
Yes.
Yeah, please share. Thank you.
Hello, everyone. Is there any issue playing my presentation?
So we are just playing it.
Mansi, the slides. Okay. Yeah, just a minute, sir. We are just sharing your recording link. Thank you.
Good morning, ladies and gentlemen, my dear colleagues. Greetings from Pakistan. I am Professor Dr. Furqan MS Siddiqui, Dean, Faculty of Rehabilitation Sciences, Foundation University, Islamabad, Pakistan. Today, my keynote topic is Immersive Virtual Reality for Memory Rehabilitation. Is it the way forward? The key terms. Firstly, we will discuss about virtual reality. Almost all of us are very much familiar with the term virtual reality. During the current decades, this technique is very much popular for its beneficial effect, especially in stroke rehabilitation. Virtual reality, digitally rendered complex 3D representation of the virtual world, enabling interaction with computing environment and associated with the feeling of being present in the virtual environment. It refers to a computer-generated simulation in which a person can interact within an artificial three-dimensional environment using electronic devices such as special goggles with a screen or gloves fitted with sensors. In this simulated artificial environment, the user is able to have a realistic feeling experience. Whereas in comparison to virtual reality, augmented reality is different. In that augmented reality enhances the real world as it exists with graphical overlays and does not create a fully immersive experience. The distinction between virtual reality and augmented reality come down to the devices they require and the experience itself. Augmented reality uses a real-world setting while virtual reality is completely virtual. It requires a headset device, but AR can be accessed with a smartphone. Augmented reality or AR enhances both the virtual and real world, while virtual reality only enhances a fictional reality. So we are talking about the effects of virtual reality and memory rehabilitation. Firstly, we have to discuss the dementia, the loss of memory. As my fellow colleagues already shed a good amount of light on dementia, here I briefly define the dementia: a syndrome due to the disease of the brain, usually of a chronic or progressive nature, in which there is disturbance of multiple higher cortical functions, including memory, thinking, orientation, comprehension, calculation, learning capability, language, and judgment. Whereas the memory rehabilitation, a part of cognitive rehabilitation, is a therapeutic activity that may play a role in the recovery of memory functions or in enabling the individual to adapt to the problems. Memory rehabilitation is a standard part of rehabilitation in many settings. Now, what is immersive virtual reality? Is a presentation of an artificial environment that replaces users' real-world surroundings. The goal of immersive virtual reality is to completely immerse the user inside the computer-generated world, giving the impression to the user that he/she has stepped inside the synthetic world. Consequently, the user turns his or her head. The displayed graphics can reflect the changing viewpoint. Basically, this is the ability of the system to support sensory-motor contingencies using head-mounted displays. Unlike fully immersive virtual reality, non-immersive virtual reality transmits the same image for both user eyes. Therefore, users perceive this image only in two dimensions, height and width, while fully immersive virtual reality technology provides a digital image perceived in three dimensions that include height, width, and depth. Virtual reality used in both diagnostic and therapy of cognitive deficits. It involves open environment training with multiple integrated stimulus. Mimic real-world environments to observe and adjust patient's behavior in ecologically valid situations, which leads to cognitive loading. Memory impairments. Memory impairments are reported in various heterogeneous mental and neurological disorders, such as Alzheimer's disease, schizophrenia, depression, bipolar disorder, Parkinson's disease, and due to the effects of some viruses like HIV, and it may be corona, and some studies are reported the post-COVID memory loss as well. Dementia, as we all know, the symptoms that occur when there is decline in brain functions. Broadly, it is divided into two types: neurodegenerative dementias and non-neurodegenerative dementias. Neurodegenerative dementias are maybe due to Alzheimer's disease, dementia with Lewy bodies, vascular dementia, frontotemporal lobar degeneration, and Parkinson's disease. Whereas non-neurodegenerative dementias are due to vitamin deficiencies, for example, vitamin B12, thiamine. It may be due to hypothyroidism, normal pressure hydrocephalus, chronic alcohol abuse, chemotherapy-related cognitive dysfunction, infections, for example, human immunodeficiency viruses, intracranial masses, for example, subdural hematomas, brain tumors, traumatic brain injury, psychiatric illness like depression and anxiety. Cognitive training and rehabilitation. Cognitive training represents the process of repeated cognitive exercises and interventions aimed at the enhancement of cognitive functions based on neuroplasticity principles. The term cognitive rehabilitation or remeditation is used in the clinical population to describe training aimed at the restoration of impaired cognitive functions. Memory rehabilitation and computerized cognitive training. A large part of current studies investigates the efficacy of computerized cognitive training, which enables a precise and repetitive presentation of the stimuli and typically applies elementary tasks focusing on one cognitive domain. Recent meta-analysis focusing on the efficacy of computer-assisted rehabilitation show a small to moderate effect on memory functions, confirming comparable efficacy to the paper-pencil approach. Memory rehabilitation and cognitive training in a virtual environment. Regarding complex 3D virtual environments, grant reviews summarize studies focusing on the cognitive rehabilitation in traumatic brain injury, post-stroke patients, and multiple sclerosis, showing improvement not only in balance and upper extremity functions, but also in cognitive functions. Memory rehabilitation and cognitive training in a virtual environment. Here we are going to take help from some evidences from literature. Recent reviews support the application of virtual environment also in cognitive rehabilitation in healthy and pathological aging. Lackout et al. Points out that the rehabilitation results stay preliminary and provide data about feasibility, but not enough data about efficacy. The benefit of virtual environment in comparison to the traditional motor or cognitive interventions was associated with a more positive attitude and increased motivation towards training. Now some evidences for immersion and virtual reality. Transfer of training. Immersive experience in cognitive training can facilitate the transfer of learned abilities to real-world situations, real-life situations, and challenges in virtual reality while maintaining control over presented stimuli, which leads to ecological validity of cognitive rehabilitation. Now, what about the activities of daily living practice? Virtual simulations of activities of daily living can better predict real-life functioning than standard neuropsychological measures. Immersion and memory performance. Basically, as you are seeing in the pictures, immersion with head-mounted displays in picture A, and the interaction, special controllers or hand trackers, has both advantages as well as disadvantages. Advantages of immersive VR over non-immersive VR. Virtual environment. More realistic virtual environments enable training of real-life situations in a safe, controlled environment. We achieve partially in non-immersive and yes, fully in immersive. Investigate the neural correlates of task-related behavior and neuroplasticity changes as an effect of the therapy. Yes, in non-immersive, and we achieve partially in immersive. Interaction with virtual environment. Realistic and spontaneous interaction. Yes, we achieve fully in immersive and no in non-immersive. Now the main important points: stimuli control. Combination of the maximal control over the stimuli and realistic environment. We achieve partially in non-immersive and fully in immersive. Engaging multiple sensory channels, making the experience more realistic. We achieve partially in non-immersive and yes, fully in immersive. Incorporating number, form, or combination of stimuli, which would not be possible in the real world. Yes, partially in non-immersive, and yes, fully in immersive. Manipulation with the level of presence. Yes, fully in immersive, and no in non-immersive. Immersive virtual reality in memory rehabilitation. Is it the way forward? We are going towards the end of our presentation and conclusion. Again, some evidences from literature. Little is known about benefits over the less expensive desktop application with low immersion level. Potential of immersive virtual environment has been pointed out by several studies and also in the meta-analysis. Limited studies comparing the efficacy of immersive and non-immersive virtual environment approaches in cognitive or memory rehabilitation. Immersive virtual environment applied in memory assessment leads to poorer performance that seems to be the result of the increased cognitive load. Additional effect of the complex virtual reality environments in memory rehabilitation in comparison to the standard approaches. It gives us to think. Immersive virtual reality can increase participants' motivation towards repetitive tasks, which are damn necessary for memory rehabilitation. as it was previously linked to increased enjoyment. There is no data to confirm this, and future studies are needed to address this issue. Concerning the extremely limited number of studies that directly compare non-immersive and immersive virtual environment in memory training, it is not possible to draw any conclusion that would benefit one approach over the other. So, we have come across the conclusion. Although immersive virtual reality is very effective for memory or cognitive rehabilitation, as per the theoretical evidences, but still we have to find out the conclusion. Still, we have to find out the final decision for its effects. Though virtual reality approach challenges cognitive factors and improves memory, even though there are some theoretical advantages of immersive virtual environment over non-immersive technology, there is not enough evidence yet to draw any conclusion. So we need to have more meta-analysis and randomized controlled trials to finally draw the conclusion whether immersive virtual reality is effective for memory rehabilitation or not. Thank you so much and goodbye.
You are muted, sir.
Thank you.
Yeah,
Thank you, Professor Siddiqui, for your excellent presentations. And now we request our last speaker of the seminar, this session, that is the Vidya Shenoy is a challenge from a caregiver perspective, which is the most important part in this cognitive rehabilitations and dementia rehabilitations.
Can I have a
Now I
CV slide,
request-
Mansi?
No, I'm doing it live from here. Thank you, Sonal. Thank you, Dr.
Thank you.
Ganguly, for introducing me. Thank you, AOCNR and IFNR, for having me on this in the symposium with stalwarts and professionals, which I've enjoyed learning from, whom I've enjoyed learning from. I'll share the PPT. Can you give me the one? I'll just. Okay. Is it visually available?
Yes, ma'am. Professor
Okay.
Ganguly, could you please introduce the chair? She has
Or-
shared a slide.
He's on mute.
Hello, am I hearing now?
Yes,
Yes,
Yeah.
you're audible.
Mr. Vidya Shenoy is the Secretary General of Alzheimer's and Related Disorders Society of India, an integrative therapist and dementia care specialist, honorary secretary, ARDSI Mumbai chapter, member of Maharashtra State Mental Health Authority, and she is the founder Sriti in Mumbai with ISO. Yeah, with this is the established a volunteer group, Purple Citizen Brigade, to the cause of the dementia. and trainer and accessors for dementia care. Committed to cause of well-being and health care factors of aging populations, spread awareness of dementia and sensitized and to remove social stigma, create a dementia-friendly society, inclusion for adults and children with special needs. Published a children's storybook, Remember Those Who Cannot Remember, co-authored and published on aging dementia, integrative therapies and senior citizen and elder abuse, presented and conducted workshop at many national and international conferences. Thank you, ma'am. I'm proud of introducing you. And obviously, you are now your speech, the challenges from a caregiver perspective will be helpful for everybody, everyone here. And please start your speech. Okay, thank you.
Thank you, Doctor. I normally, we always are grateful to the divine when our work is done. I believe in starting with gratitude and most importantly, turning myself outside in to the divine, thanking my teachers in my educational and professional pursuits, my yoga, Shri Ambika Yog Kutir, that groomed me as a fine yoga professional. And this, of course, has helped me to see life in a better way and live life with discipline and enjoy the good quality of life. I'm grateful to the senior citizens, the special needs children, adults living with dementia, their families, caregivers, who completely trust me to hone my skills in the bargain while trying these, out of the box therapies sometimes. And I have to make special mention of my family with dementia, my extended family, so in Smruti Vishram, who have actually given me the world on a platter. And I'm so very grateful to them. They have enjoyed being at the center and we are enjoying it as a family. And we are very privileged to be, certified with the ISO recognition, the quality certificate. Of course, grateful to the professionals and researchers in various fields who silently continue to inspire, encourage, support me in my, trip in education and dementia, and eternal gratitude to each of them from whom I learn every single day. Today, I'm talking of caregivers' perspective of challenges in dementia. To me personally, I feel that caregiving is beyond disease. It's actually, as Vivian Fraser said, caregiving is a constant learning experience, and who better than I who can actually back him up for his view and expression. Caring is actually building relationships one to another. I think caregivers are unseen angels in disguise. We never look out for them, but we always see something is working right the way we want it to. Sometimes it doesn't work the way we want it to. But then on hindsight, we know why and the best thing happened. Who are these? They say, I do care. In the days of today, we find a lot of people saying, I don't care. Who cares? But I think caregivers are the ones who are ready to help anyone. So they say, I do care. So let's go to see who is a caregiver. It could be a mother, a father, a grandparent, a neighbor, a friend, a relative, anyone who is actually caring for you. And I think every single person around us is caring, much as animals, much as plants. They're giving so much back to us. We might be watering the plant, but they give us flowers, they give us an aroma. They're now even therapeutic. And of course, there is a family caregiver and a chosen, a hired caregiver who eventually becomes chosen family, who's in the caregiving process, one with them. So what do we expect a caregiver to be? They should be understanding. The list is endless, actually. They should be understanding. They should be compassionate, empathetic, sensitive, patient, and also loving. But we are always expert. It's something like I want some more like an Oliver Twist. We also want the caregiver to be multitasking, have good communication skills, And there are other soft skills that include sound decision making in emergencies, taking the right decision at a critical moment, and having a positive attitude to help the person living with dementia, to find solutions, the best possible for the family member with dementia or the person they're caring for. Also, they must have ethics, they must be professional, and the most important thing is having great interpersonal skills. Now, this is what we want from them. Let's hear the dementia caregiver story. All they have to handle is challenging behaviors. We've seen a lot of people, persons with dementia, saying the same thing over and over again, like, I've not eaten food, I've not eaten food. And they go on blabbering away. What does it do? To a normal person, it's extreme frustration, anger, agitation. And of course, we are no saints. It somehow expresses itself in caregiving. Often we find people in the later stages, hitting the caregiver, kicking, screaming, abusing, and also being derisive of the person caring for them. They have insomnia, they have sundowning tendencies. So what happens is the whole impact comes on the caregiver. We also see that the person with dementia has loss of bladder control, they are incontinent, they have delusions, hallucinations, they have poor hygiene, they are quite obstinate, they're big children, quite obstinate. They won't cooperate, they want to have their way. If not, they say the highway. They also have physical problems of swallowing, but at the same time, they also start spitting, throwing around food, messing up just for troubling the person. But the family caregiver's challenge is totally different. What happens is that a family member more often than not is taken for granted, especially a caregiver. Also, there are people who don't do the care part and they're ordering them around. Oh, you should have done this, I would have done this. Instead of supporting that family member who's caring, they are giving the Sermon on the Mount. After all, who feels the onus? It's the person who's a caregiver, and they're doing it out of guilt, a sacrifice they feel. They're dealing with all the activities of daily living, which is a very big challenge. In the bargain, they don't even think about themselves, their own health. And if they're unwell, they put it under the carpet. They don't even share it with other family members for concern that maybe the person who's living with dementia might have a problem. So what happens is their personal health and self-care goes on the back burner. The most important thing, I think, is to see a parent who has actually reared you as a child to go through the role reversal situation where their children, where the daughter becomes a mother, the son becomes a father. And I think it's a very difficult issue to handle, to see an elder who has been very active socially and within the family to suddenly change and become very quiet or very, very hyper. So they're also very sensitive. Caring has a lot of pressure. So I think the whole attitude, there is a psychosocial effect on them, and they become very emotional if you tell them something. Whether it's a corrective measure, the tone in which you talk is important. And I think other family members definitely take them for granted. And, how to ask, for help. What will he do? What will she think? So these are the things that go against the family caregiver because they don't ask for help. Then what is the problem of the hired caregiver? It's different from the family caregiver. Employers feel that they pay the caregiver. If you pay, treat them like, dirt. Don't care about what the caregiving is all about. Don't think about them. We are paying the money, treat them the way you want to. Also, there are times when, things are misplaced. So the first suspect becomes the caregiver, then it's a servant or any visitor that comes. They're also accused of crime or theft, which I think is very sad because they are actually giving a lot of themselves up to do the job of a caregiver. We have had people who've made sexual advances to the caregiver, and just not the person living with dementia. It's, also the family member who thinks that, oh, this person's looking after my father or elder, and I'm paying the money. I can treat the person like, whatever you call, and, treat them badly. Also, we've had in later stages, a person living with dementia taking off clothes, pinching or making lewd gestures. Now, this is, their functioning is kind of pardonable because the brain has lost control over behavior. Also, they have to tolerate, the caregivers who are hired have to be tolerant about the abuse and, mistreatment, because they need the job. They are from the below the poverty line areas. So actually, we divide the problems of the caregiver into psychological, which is stress related, financial, because they need the money, physical, because, we just advise people not to have one caregiver for the full day. It's very, very challenging. And the quality of work comes down. So we suggest have two that go in shifts, they need a break. And so physical exhaustion is a lot important too. Mental, they become so depressed, sometimes because they need the job, they're going to do it. And there have been people who have had suicidal tendencies. Long hours of work sort of disconnect them from society, because their world is the person they are caring for, whether they are hired or family caregivers. There have been many cases where the caregiver has stayed single, and unfortunately, when the family member has moved on, they are at bay, and it's too late for them to decide to do anything, because the average span could be anything from 5 to 20 years post-diagnosis. So we think that self-care that is very, very low, no medical checkups, no me time, all have effects on the caregiver. What is the price of caregiving? Apart from being, having a strong weight to carry of the caregiving, or even being tied up from normal life, they have stress, isolation, depression, lost opportunities, no me time, ignoring personal health, mind and body balance is what they give up for. They're sleep deprived, they have lack of family and social support, and no time for their own care. I mean, most of the caregivers are ladies. And I think which lady doesn't like to look good? But they don't have time for this, because there's a total burnout, and they say, who the hell cares? It doesn't matter. But when it comes to the person to be looked after, they say, I do care. So our advice to caregivers at support group meetings is stay calm and positive. It's very easier said than done. But the next thing we do is we tell them try and prevent situations. So over a period of time, you can analyze what is the source of that behavior, that violent behavior, or, the depressive behavior, whatever. So, one needs to keep a track of how the person living with dementia is behaving. We offer a better environment. I think an environment, everybody likes to have a nice, calm, peaceful, and a pleasant environment, whether it's with people or with the actual environment of the home. Communicate better. They can't take long sentences. Like as the earlier speaker said, you have to make it short, you have to give it in bits and pieces so they can digest that question one at a time. Give them a lesser choice, either this or that. Also, we have to have a patient-centric care. That means person-centered, where he or she is the final decision maker to help you decide what they need. You go with their flow, not they with yours, because they have their own mood swings. Understand why they behave, why they do. Begin with self-care, so that is the most important thing. Ask for help. There's no shame, there's no embarrassment to ask for help. All of us need help. All of us need each other. Being a yoga professional and a passionate practitioner, I think yoga is something that calms a person. It gives you the energy, it creates a body-mind balance that allows you to do what is right in the right pace, and it lets you enjoy what you do. Listen to music. I think music is therapeutic not only for persons affected with dementia, but also the caregiver and the family members. Find support groups to share, care, and learn. So I think it's important that caregivers meet regularly. They have their time with others where they can share their experiences and learn from others' experiences. The pandemic has changed our lives. So in this special time, just as family members need one another, I think caregivers also need our cooperation. Let us share the responsibility. Assistive aids and technology is a help. See what is applicable according to the stage of dementia the family member is in. Ensure that the legal documents are in place. There are a lot of cases where there are medical legal cases, there are legal cases, or, I think the first thing is when they are aware, each person who has been, diagnosed with early dementia or has MCI, I think they should do all these documentations, whether it's illegal, the bank, investments, they should do that. Take the responsibility, share the responsibility so they have a break time. We all need a break time, breakfast, lunch, dinner, post evening, or, activities, sports. I think they also need their own kind of break time. Sit with them, talk to them, find out what their problems are, make them comfortable to be one of you and you of them. So once they start speaking, you will be able to hear their challenges and try to sort out as much as you can. Yeah. And then we have to give them support wherever it's required, holistic rehabilitation if it's necessary. Also see that they probably need some, psychological tests once in a while. Help them plan their future, because once the person with, dementia moves on, they are at, loose end. They don't know what to do because they don't have insurance coverage. They don't have any other benefits. They don't have medical insurance either. So remember that we are mutually interdependent. Therefore, there's a need to take steps to realign not only our lives, but also that of the caregivers, make them inclusive so they are happy. They know that they can depend on you. They have somebody else to share their life or their problems. Let them make friends in the, support groups where they'll be able to understand the care, dementia care much better, respect and support them, acknowledge their efforts. I think it's very important to be grateful, to acknowledge people's efforts. If they've made something wrong, don't look down on them, deride them, because we are not doing the job, they are doing the job, and they deserve much more than what they give us. So, I feel a caregiver's role, though it's challenging, brings untold joys of bonding, a sense of accomplishment and contentment, knowing that eventually it's worth it after all. For the caregiver and the cared have left indelible imprints on the hearts of each other. And you can see the yellow, the purple is the color of dementia, the heart, red, and both the pieces have gone across to each other's heart. So obviously they have left indelible impressions. So, our thing is, remember those who cannot remember, but I add on, don't forget their caregivers too, because they are important. Thank you so much. And I look forward to the questions or the discussions, and also share our Smriti Vishwam experiences. Thank you so much.
Thank you, Dr. Vidya. I think Dr. Ganguly, you can open the session for discussions. You got about 10 minutes.
One thing I want to mention that common people, they are habituated with the term rehabilitation. That means after the physical injuries, after the rehabilitation, there will be a good improvement. Even after the physical injuries, after the proper rehabilitation, the patient may be normal. Cognitive rehabilitation, I think it should be that it does not set to improve cognition, but use a goal-oriented approach to facilitate improved management of functional disability. Otherwise, all the speakers, they have covered excellently, lucidly in the rehabilitation part of the dementia, which is the most difficult, hidden and unique in the sense that there is a different mode of presentation in an individual. It is the already Dr. Aladi, Professor Aladi have mentioned that it is the individualized, even in individual in mild cognitive, the approach is and moderate, this approach is separate. So it has covered, excellently covered by all our four speakers. I just explain if there is any questions or any opinion, then obviously that will be welcome because we have had science probably.
I think I can see one question here. I think it is for Maiko, Dr. Maiko.
Yep.
It is the Shailaja Jaiwan. She is asking, do you have preventive program for dementia?
Prevention program, you said? Program?
Yeah, any preventive program to prevent dementia?
Great. Thank you so much for such a wonderful question. So yeah, even on my presentation slides, what we do is, once the dementia started, we can't rewind the time. Therefore, one of the biggest approach that we as a nation, but also to locally, is doing, like, try to prevent dementia and try to pick up people who started showing any small decline in their cognitions and everyday life. So like I said, we invite all healthy elderly people to different type of activities. And again, we provide transportation, free participation. Sometimes we provide juice, food, and so forth. And they, one of the biggest issues that we are having is that, a couple elderly people, they were living together, but one person passed away. Therefore, they become so lonely and they stopped going out. So even try to, help them to come out from the house. It's also very important for prevention of depression. So yeah, by encouraging them to participate in different type of activities, I think that's really greatly helping to prevent dementia. But at the same time, like us going to local city halls, and actually we provide neuropsych testing for them. So when we see any sign of MCI or early stage of dementia, we also encourage the person to go to clinics. So that's what we are trying.
Okay, thank you. I think our time is up, and we'll come to the conclusion of this session. I thank Dr. Ganguly for chairing, and all the speakers, Dr. Suvarna, Dr. Maiko, Dr. Siddiqui, and Dr. Shenoy, for giving excellent talk on a topic. I think some days everybody is going to face this problem in future. So thank you very much, and we'll go to the next session. I think.
Thank you. Thank you all.
Yeah.
Actually, just to share with you all our experience, there was a conference in Japan a few years ago, and I was privileged to hold a yoga workshop in one of the dementia cafes. And we were expecting something like 40 people maximum, and the mats were arranged. We had over 100 people come for that session, and we had to have a repeat session. So I think it's going to help if we start early, and hopefully, the medicines that are questionable at the moment will be effective, and there'll be nobody needing, therapy for dementia, neuro rehab, but we could probably do risk reduction or aging actively, so that's the fervent prayer, healthy active aging.
Yeah.
Thank you.
Okay.
Sir, can I say a line, sir? Can I say
Yeah.
a comment, sir? Yeah.
Just
Sir,
the
I am
one,
Dr.
because we have to go to the next speaker.
Yes, yes, sir.
Yeah.
I am Dr. Anuradha Pai, professor in occupational therapy at Sion Hospital. This is regarding Dr. Vidya Shenoy's talk. It was an excellent talk. In fact,
I think you are muted.
You're muted.
had adopted a son, and now this man was 80-year-old, and there were no proper adaptation papers made, and this son is now 60-year-old, and the man has gone into dementia, and to sign the papers he did not have the cognitive ability, and they had come to me, and I tried helping them, but taking signatures without informing the patient was not legal. So if this part was done earlier, means they had adopted when he was a child, but it was just a brother's son, so they did not make any legal papers for that. And now they were having family problems. So legal matters regarding aging are very important.
Yeah.
Thank you, sir. Yeah.
Well taken. I think Bhavesh, can you or Mansi, can you show the CV of the next session speaker, Dr. Rao?
Thank you very much.
Hello, Dr. Mansi. Yeah. We'll go on to the next session, that is a symposium on disability assessment and certification, which is an important topic. We'll have Dr. KVS Rao talking on this issue. He is Director, Department of Empowerment of Persons and Disabilities of Ministry of Justice and Empowerment, Government of India. He is a senior government official. Over 20 years experience in human rights, health and disabilities, a specialization in policy and planning. His work at this department has spanned effective programs for promotion and protection of rights of persons with disabilities, inclusion and empowerment. Mr. Rao has contributed extensively to frame a new legislation in 2016 that includes the broad principles endorsed in the United Nations Convention of the Rights of Persons with Disabilities, and assisted in creating a web-based national database. I think I welcome you, Dr. Rao, to go ahead with your lecture on law and policy on disability in India. I think you are the ideal person for this topic. Thank you.
Yeah, thank you very much. Am I audible?
And you will be chairing this session. So next talk, you will be introducing the speakers and continuing the session.
Thank you very much, Dr. Deepak.
Yeah.
Yeah, welcome you all. I hope I'm audible.
Yeah, you are audible. You can start sharing your screen.
Yeah, can I, my PPT, can it be run?
Yeah, you can share your, you're given recorded?
Yes, yes, I have, yeah, that's right. Yeah, I would like to speak on the law and policy on disability in India, because India, we are taking the disability very seriously. We have national as well as international commitments. Yeah, next slide, please. Yeah, can we go to the next slide? Yeah, I would be focusing on what is the disability population in the country, what are the constitutional provisions where the responsibility is placed on the central and state governments and also civil society, what are the main laws that we have in the disability sector, and the Rights of Persons with Disability Act, which is the present law of the land which we are supposed to implement, and what is the policy that the government is implementing, and also what is the certain schemes, important initiatives that the government of India has taken recently. Next, please. As far as the disability population is concerned, Yeah, we have 2.68 crore Indians as per the census 2011, which constitutes about 2.21% of population. The maximum is the locomotor disability, which is 54 crores, and followed by visual disability, 50 lakhs. In fact, hearing disability is 51 lakhs and visual is 50 lakhs. Then followed by multiple disabilities, 21 lakhs, speech disability, 20 lakhs, mental retardation, which we now call intellectual disability, 15 lakhs, followed by mental illness, 7 lakhs. So this is the population that we have. We are waiting for the latest census 2021, which we depend only on the census data as far as the disability figures are concerned. And we are expecting that the number may increase not only because of the increase in population, but also I would like to tell you in subsequent slides that we've increased the number of disabilities which are recognized by Government of India. Next slide. Yeah, as far as the constitutional provisions, we have the Indian Constitution. In that which was framed in 1950 itself, the Article 41 talked about disablement, that the government, the state, that is the nation, shall have the responsibility to take care of the persons with disabilities within the limits of its economic capacity. Yeah, next slide. Yeah, as far as the other parts of the Constitution, the list 2, which talk about the state, is the provisional government. The Constitution lays a serious responsibility on the state governments. This disability is mainly the state subject, and the central government supplements the efforts of the state government. Then we have the panchayat at the grassroots levels. Even they have been given the mandate to ensure the welfare of handicapped and mentally retarded. Even the municipalities, the local bodies, also have been given the same responsibility of taking care of the handicapped and the mentally retarded. Even though now we are not using the word handicap or even mentally retarded, basically it means the persons who have physical and mental disabilities. Next slide, please. Yeah, as far as the laws are concerned at the national level, in fact, in the disability sector, there are no laws at the state level. It is at the national level that we have legislated from time to time to ensure that our national international commitments, wherever United Nations or at any other forum, wherever we are given our commitment, we try to convert that into a national law so that it is implemented across the country. The first is the Rights of Persons with Disabilities Act 2016, which I said has been legislated recently, which is the law of the land, which has replaced the earlier law of 1995 Persons with Disabilities Act. So it is a great improvement on the previous law. Now the next law talks about the Rehabilitation Council of India Act 1992. It takes care of the governing of the rehabilitation courses, the quality and the curriculum of the programs, and also regulation of rehabilitation professionals. What should be the quality even after they get the license? We have the continuing rehabilitation education so that the quality of the persons with the rehabilitated persons is taken care of. Then the third law we have, most of you are aware, is the National Trust for Welfare of Persons with Autism, Cerebral Palsy, Mental Retardation, and Multiple Disabilities Act 1999. In fact, the 1995 Act did not deal with autism, persons with autism and multiple disabilities, though it talked about cerebral palsy and multiple retardation. In fact, these 4 categories, which are considered as those with intellectual and developmental disabilities, they have serious concerns compared to those persons who have only physical or sensory disabilities. So therefore, this law was brought into force to give focus attention to their specific problems so that the daily living activities are taken care of. And also wherever there's a need for guardianship, because the parents or the relatives are little worried as to what would happen to these people once they are no more. So there the issue of guardianship is taken care of in this law, where we have the local level committees at the district level, mainly headed by the district collector, where it becomes easy for the families to get the guardianship. Next slide. Yeah, as I said, the present law, the 2016 Rights of Persons with Disability Act 2016 is a rights-based act. It is no more welfare-based. Welfare-based is where we have a choice to do something, but here, if it is a right-based, the responsibility will lie on the government and states and civil society to ensure that their rights are well promoted and protected. This law is fully based on the UN Convention of the Rights of Persons with Disabilities principles. I would like to read the main principles of this, which is the basis of our new law. Respect for inherent dignity, individual autonomy, including the freedom to make one's own choices and independence of persons, full and effective participation and inclusion in society, respect for difference and acceptance of persons with disabilities as part of human diversity and humanity, equality of opportunity, accessibility, equality between men and women, respect for the evolving capacities of children with disabilities, and the respect for right of children with disabilities to preserve their identities. Next slide, please. Yeah, the 95 Act dealt with only 5 disabilities which are there, I mentioned in the first column: the locomotor disability, blindness, low vision, hearing impairment, leprosy cure, intellectual disability, which was earlier called mental retardation, and mental illness. Now, in the new law, we have continued all the 7 disabilities, and we added new disabilities, which I would like to read: muscular dystrophy, dwarfism, cerebral palsy, acid attack victims, speech and language disability, specific learning disability, autism spectrum disorder, chronic neurological conditions which the conference is presently deliberating upon, the multiple sclerosis, Parkinson's disease, hemophilia, thalassemia, sickle cell disease, which are the 3 blood disorders, and multiple disabilities. The central government has been mandated by the parliament to include any more disabilities from time to time. I would like to say that this conference is really, really very important from the point of view of my department, because we have today the neurologists, the physiotherapists and occupational therapists, hearing and speech therapists, orthotics, prosthetics, PMR experts. In fact, all these professionals are really required to handle all the 21 disabilities which have been mentioned here. And I'm sure that the deliberations of this conference will be very useful, and I would like to compliment the conference for having a multidisciplinary approach to handle the issues relating to persons with disabilities. Next slide, please. As far as the rights of persons with disabilities is concerned, the main focus is the issue of equality and non-discrimination. So far, the persons of disabilities have been facing the discrimination and prejudices in the society. The main purpose of this act to ensure that they do not face discrimination, they have a life which has to be as good as other persons. So the government is supposed to take measures to ensure persons with disabilities enjoy the right to equality, life with dignity and respect for his integrity, equally with others. This is what equally with others is the emphasis which I am trying to add. Therefore, it is a responsibility for all of us to see how we can bring persons with disabilities to the level of persons without disabilities, so they do not face any barriers. Government is also mandated to take measures, special measures, to ensure that women and children with disabilities enjoy their rights again equally with others. And they also have a right to live in the community. Their protection from being subject to torture, cruelty, inhuman, and other behavior. The protection of PWDs also, they have to be protected from being subjected to all forms of abuse, violence, and exploitation. The Act clearly mentions the responsibility of the executive magistrate and also the police officials to handle the complaints of persons with disabilities. Next slide, please. Further, the law is so comprehensive, it also anticipates what kind of problems the persons with disabilities would face during disaster situations like we have the COVID pandemic. In fact, in the beginning, at the early stages of the pandemic, the central government issued guidelines to the state governments and also the central government ministries, stating that the persons with disabilities have to be well protected and their safety, and also take all precautions that they do not face any problems due to a COVID pandemic. The National Disaster Management Authority, the State Disaster Management Authority, and also the District Disaster Management Authority have been alerted to take care of the needs of persons with disabilities. Similarly, the rights of children also need to be protected. Then the issue of reproductive and family planning of persons with disabilities is also to be taken care of. The Election Commission also should take care of the polling stations to be made accessible. Similarly, we have the persons with disabilities need to take care. We have to protect the legal capacity on an equal basis so that they take care of their financial matters, even if when it comes to the property, any kind of transactions, that they have equality as far as the legal capacity is concerned. Similarly, the limited guardianship, again here, as the speaker in the previous sessions have said, that the guardian have to respect the person with disability. Here, earlier it was that the guardian could take any decision at his level, but here when it comes to legal guardianship, it means that the consultation with the person with disability is mandatory, so that a decision is taken which is totally in consonance with the opinion of the person with a disability. Now, yeah, I think kindly may I request the mic be muted. Yeah, the last issue which I would like to focus on is the state government is to issue disability certificate which is valid across the country, that is as per the law. I would like to say that earlier people who used to have problems getting a certificate from a state, and when they have to go to the next state, there used to be problems. This law says that any disability certificate issued by the local authorities is valid across the country. In fact, here the responsibility lies with the state governments, especially our medical professionals, where they have to ensure that the disability certificate issued timely. In fact, our law says that we should ensure it is given in a month's time, and also the assessment has to be correct, and also ensure that the experts are available. In many cases, there's a shortage of experts like clinical psychologists or even a psychiatrist. So the state government has to ensure that at least from the neighboring district or from a nearby medical college, that the professionals are made available, because the disability certificate is a passport to avail various benefits of the state as well as the central government. Next slide, please. Yeah, the law also talks about inclusive education. So that is why I think when we come to the professionals, the rehabilitation professionals, it is our bounden duty to ensure that it is not only to ensure that the daily living activities are taken care of, but we have to ensure that the person is also capable of going to the normal schools and also working in the normal workplaces. That is where I think our challenge lies. The Act also guarantees the free education for children with disabilities up to the age of 18. Then 5% reservation is there for students with benchmark disabilities in the higher education institutions, which also includes persons with locomotor as well as the neurological disorders. Even the skill development is available for persons with disabilities. The various schemes are there. Then also the law guarantees that the social security, health, rehabilitation, sport, culture, recreation, and all research and development, all these have to be ensured for persons with disabilities, just as they lead a life normally like others. And also, I would like to point out that the government also is implementing 4% reservation in government jobs for persons with disabilities across the country and also in various states. Next slide, please. Yeah, flowing from various laws that we have in the country, the national policy, which we have in fact notified in 2006, it recognizes that persons with disabilities are valuable human resource. They are not to be neglected. They can perform as much as a person without disability. If suitable opportunities are given, persons with disabilities can contribute to socio-economic development of the country and can also lead an independent life. In fact, this policy was framed in 2006. We are trying to update and see what other new components we can add in the policy. So it is under review. Next slide. So the existing policy focus on prevention of disability. I think that is where the professionals who are here with us can help this disability sector to see how we can prevent or even reduce or even eliminate wherever disability is possible, wherever there is science and technology for that. Rehabilitation of strategies that we are trying to follow is the physical rehabilitation through counseling and rehabilitation, development of rehabilitation professionals, promoting education of persons with disabilities, economic rehabilitation of persons with disabilities, which includes employment and also self-employment, special focus on women and children, as I've said earlier, and the creation of barrier-free environment, built up infrastructure and transportation. And we also added the website recently. So these are the steps that the government is taking. Yeah, next slide. The national policy is also focusing on streamlining disability certification. Earlier, the person of disability has to visit several times to the district medical authority to get a certificate. Here, we have now started an online web-based national database, which is we call unique disability ID project. So as per that, the person can apply online, and he would also get the date and time to visit the medical authority. And after assessment, he would also get the disability certificate online. And in fact, now it has been made mandatory that the certificate has to be given online from 1st of June this year. Then enhancing social security is also the priority. Promoting NGOs, we are providing financial assistance for various projects across the country. Then collection of data on persons with disabilities. The unique disability ID project, which I've said, it will give real time data, and also the census 2021 will also add to the data that we on the persons with disabilities. Promoting research and also sports, recreation, cultural life of persons with disabilities is also the focus of our department. Yeah, next slide. As far as I would like to bring to the notice of the conference that recently we have set up what is called the early intervention centers in our national institutes and the composite regional centers at 14 places, because we thought that the screening the child, especially 0 to 6 years, is the time when the brain develops almost fully. That is the time where we have to focus on the child, and probably that will ensure physical, sensory, and cognitive development. That is, before we thought we write to the state governments, we ourselves in our own institutions, we would have it so that they can be replicated across the country. And we are trying to set up 14 more such centers. And the services include rehabilitation therapies provided which will include physical therapy, occupational therapy, communications and language development, and emotional development, which is again the focus of this conference. The parents and peer counseling is what we are trying to focus in the early intervention centers, so that we can train the parents in how to handle the children with disabilities when they go back home. Yeah, next slide.
1 minute, sir.
Yeah. So the other important focus is the community-based development, where we are trying to create a community-based worker which will work alongside the ASHA and Anganwadi workers. It's a 6-month course. So that will really fill the gap at the grassroots level. Thank you very much.
Thank you, sir. The end. You can go ahead with introducing the other speakers of the symposium as the chairman. And I request Bhavesh to project the CV of the next speaker, Dr. Rajendra Sharma. Mansi, are you there? Yeah.
Yeah, it's my pleasure to introduce Dr. Rajendra Sharma, Professor and Consultant PMR, ABVMS, and Dr. RML Hospital, New Delhi, formerly Medical Superintendent VVMC and Safdarjung Hospital, Director PMR Mumbai, Professor and Head PMR at Safdarjung Hospital, Professor and Head PMR ABVMS, Dr. RML Hospital, Education, SMS Medical College, University of Rajasthan, Jaipur, 35 years of experience in PMR as clinician, teacher, researcher, and administrator, served as an expert on various committees of ICMR, RCI, Planning Commission, Ministry of Health and Family Affairs, and has been awarded Scroll of Honor by President AIM PMR 1991, WG Ramarao Travel Fellowship 91-92, EIPMR Gold Medal of Best Paper 1995, and AIPMR Dadachi Award for Technological Development Advancement 1996, DMA President's Appreciation Award 2007, DMA Distinguished Services Award 2018, National Gaurav Award 2019, published various articles in national and international journals, contributed as an author for various books in rehabilitation, field of interest, spinal cord injury rehabilitation, balance rehabilitation, and musculoskeletal disorders rehabilitation. I welcome Dr. Rajendra Sharma. Kindly take the floor.
Thank you, sir. Babu. Ajay? Screen share. So greetings from Delhi. The topic given to me is disability assessment as per guidelines. And I am very fortunate to be speaking in a session where KVS Rao, who is director in Department of Disability Affairs, is chairing. He was the man instrumental in getting this new law passed, as well as he was the key person who coordinated all the effort in development of new disability guidelines, which were notified in 2018. So we'll start with why it is important to assess disability. Section 56 in RPWD Act mandates us to quantify benchmark disability. We need to prioritize resource allocation because there is huge number as our population is very large. So we have to identify benchmark disability, then to identify persons with high support needs, to give graded benefit and opportunity for participation, because our government is providing many affirmative actions to facilitate the well-being of disabled people. As far as legal and cases are concerned, we need to decide compensation, which is granted as per the disability assessment, quantification of disability. And also over a period of time with this UDID data collection, we will be eventually understand the functional ability of each individual based on the biological and environmental factors. What have been Indian practices and rules? RPWD Act has been in detail considered by KVS Rao Sahab. And as has been said that United Nations Convention of Rights of Persons was the focus to make this new law. And Ministry of Social Justice and Empowerment, Department of Disability Affairs notified disability assessment guidelines on 4th January 2018. And it is mandated under Section 56 of Rights of Persons with Disability Act 2016. As has been informed by him, the specified disabilities are locomotor disability, blindness and low vision, deaf and hard of hearing and speech language disability, intellectual disability, and specific learning disabilities, mental illness, chronic neurological conditions, hemophilia, thalassemia, sickle cell disease, and multiple disabilities. In the interest of time, I will confine myself to the locomotor disability, chronic neurological disorders disability, cerebral palsy, muscular dystrophy, and spinal cord injury only. So locomotor disability is inability to execute distinctive activities associated with movement of self and objects due to impairment of musculoskeletal or nervous system or both. So I have highlighted the sections A, which is permanent physical impairment of extremities. This is important because these guidelines or these principles are used for disability assessment in neurological conditions caused by lower motor neuron releases. Similarly, locomotor disability due to chronic neurological condition is another important aspect which I will cover. The spinal cord injuries is another area of interest to this group of attendees. Cerebral palsy affected persons with disabilities again is very important. And then we will talk about muscular dystrophy, where more or less is according to the provisions of Section A, that is permanent physical impairment of extremities. Coming to a brief review of guidelines, if you look at LMN lesions or extremities disability assessment, the upper limb is divided into two components, that is arm component, and the disability is quantified by range of motion assessment, muscle strength assessment, and there are coordinated activities, and then we use a combining formula of A plus B 90 minus A divided by A. Hand component has sensation, which is 30% weightage, strength in form of pinch strength and grip strength, 20 and 10, prehension in form of opposition, hook grasp, pinch grasp, cylindrical grasp, and spherical grasps. They are added directly. Additional weightage of up to 10% can be given for presence of deformity, pain, loss of sensation, complications, dominant hand, and shortening can also be quantified. As I have told, that to combine various values, we need to use a combining formula for telescoping the values so that total PPI never exceeds 100% in any circumstance. Similarly, for lower extremities, LMN lesion, and for lower extremity evaluation, mobility component is 90%, range of motion 90%, muscle strength is 90%. Range of motion for lower extremity, if we look at hip, knee, and ankle joint, has been changed. Earlier, it was 30% for each joint. Now it has been decided to keep 35% for hip, 35% for knee, and 20% for ankle, because it is considered that the stability of hip and knee is more important. Similarly, muscle strength is quantified in percentage, and then it can be multiplied by 0.30 to quantify the amount of disability. The stability component is based on functional and coordinated activities. There are 9 activities which carry 10 marks each, and then all these 3 components are then to be telescoped and combined by using formula A plus B 90 minus A divided by 90. Like upper limb, for lower limb also additional weightage can be given for deformity, pain, loss of sensation, other complications, and shortening Total percentage of PPI, again, we cannot exceed 100 in any circumstance. Coming to locomotor section E, that is locomotor disability due to chronic neurological conditions. This mostly deals with upper motor neuron lesions, and it is assessment of its clinical manifestation, which is important. Many conditions like stroke, Parkinson's, and multiple sclerosis can be covered under this. Dominant upper extremity is given added weightage of 10%. Loss of sensation can be given 10%. Extent of sensory deficit is also quantified. Bladder disability due to neurogenic involvement can be quantified in 4 categories and awarded disability percentage, which we'll see later. Ataxia is again quantified in mild, moderate, severe categories, and total disability again cannot exceed above 100%. Coming to stroke, for a stroke evaluation or disability assessment, the modified Rankin scale is used for measuring the degree of disability or dependence in activities of daily life. For those who have suffered a stroke or other causes of neurological disability, as I have mentioned, stroke, Parkinson's disease, and multiple sclerosis, we can use modified Rankin scale to quantify disability. This is how modified Rankin scale works. The grading is from 0, that is no symptoms, to death, that is 6, and grade 1 is no significant disability, able to carry out all usual activities despite some symptoms. The disability quantification is less than 40% in this case. Level 2 is slight disability, able to look after own affairs without assistance, but unable to carry out all previous activities, can be quantified at between 40 to 50%. Level 3 is moderate disability, which requires some help, but able to walk unassisted, can be quantified between 51 to 60%. Level 4 is moderate severe disability, unable to attend to own bodily needs without assistance, and unable to walk unassisted, can be quantified from 61% to 80%. Severe disability, incontinence, bedridden, nursing attention require more than 80%. So this is how we can use modified Rankin scale classification to quantify disability assessment, especially in stroke, Parkinson's disease, and multiple sclerosis. I was talking about bladder disability. Bladder disability due to neurologic involvement can be mild, which is hesitancy and frequency. Disability percentage of 25% can be granted. Moderate, where there is precipitancy, 50% disability weightage is granted. Severe, occasional but recurrent incontinence, 75% weightage is granted. Very severe, when there is retention or total incontinence, 100% disability weightage can be granted. Coming to other neurological disability, that is ataxia. I told you that mild, moderate, and severe categories are there. Mild is when it is detected on examination. There are no visually apparent symptoms. The disability weightage granted is less than 40%. In moderate, when it is visible, 40 to 60%, and when it is severe, incapacitating in functions, more than 60% disability weightage can be granted. Sensory deficit can also be granted some disability weightage. If there is anesthesia, up to 10% for each lip can be granted at disability percentage. Hypoesthesia, depending upon percentage of loss of sensation. Paresthesia, up to 30%, depending upon the involvement. Hands and feet sensory loss, depending upon percentage of loss of sensation. So this is how we can account for sensory deficit in various conditions as well as individually. Coming to another important section, that is section F, about spinal cord injuries quantification. The individuals with the spinal cord injury shall be categorized into one of 4 main diagnostic categories for the purpose of disability evaluation. Tetraplegia, or more specifically bilateral severe loss of upper extremity function plus the presence of paraplegia, can be granted up to 90%. Paraplegia up to 75%. Quadra equina syndrome without bladder or bowel dysfunction up to 40%. Quadra equine-like syndrome with bowel and bladder impairment such as lumbosacral plexus up to 60%. Spinal cord injury, additional weightage in spinal cord injury can be granted for presence of significant neuropathic pain, spinal deformity, spasticity, contracture, heterotopic ossification, pressure ulcers, depending on severity and added on to permanent physical impairment. Total disability in any case will not exceed 100%, and terms like paraparesis, quadriparesis should be avoided. Coming to section I, that talks about cerebral palsy affected persons. Cerebral palsy, as you all know, is a non-progressive neurological condition caused by damage to one or more specific areas of brain and affects movements and muscle coordination. There are two scales, functional scales, one for upper extremity function, one for lower extremity function, which is used. Gross motor functioning classification system, ER version, is used for quantification of lower extremity function. Manual ability classification system, that is MAX, is used for upper extremity functions. Other system impairment added by using combining formula. This is GMFCS scoring, which is self-initiated movement with emphasis on sitting, transfer, and mobility. It is 5-level scale. Level 1 is when walks without limitation. Disability is less than 40%. Level 2 is when walks with limitation. Disability is quantified from 40 to 50%. Level 3 is walks using a handheld mobility device. Disability is 51 to 60%. Level 4 is when self-mobility and limitations may use powered mobility, 61 to 79%. Transported by manual wheelchair, level 5 can be scored 80% or more. Coming to max, level 1A is when handles objects easily and successfully. Disability weightage is 20%. Level 2 is when the child handles most objects but with somewhat reduced quality and or speed of achievement, 30%. Level 3 handles objects with difficulty, needs help to prepare and or modify activities, 40%. Level 4 when handles a limited selection of easily managed objects in adaptive situation, 55%. And if the child does not handle objects and has severely limited ability to perform even simple actions, 70% weightage is granted.
2 minutes remaining.
Okay. Other disabilities assessed separately are visual impairment, hearing impairment, speech impairment, which can be added directly. And disability is certified in relation to whole body. Coming to muscular dystrophy, it is assessed as like a lower motor neuron lesion to account for weakness, contractures, scoliosis, cardiac or pulmonary involvement. Multiple sclerosis and inflammatory nervous system, demyelinating cells in brain and spinal cord to communicate with each other. Similarly, Parkinson's disease is a progressive degenerative disorder which leads to rigidity, slow, increased movement, affecting middle-aged and elderly people. Coming to chronic neurological condition, here the disability is multidimensional, involving manifestation in musculoskeletal system as well as psychosocial behavior. Musculoskeletal system is assessed as per the guidelines in section E, whereas psychosocial disability is assessed by using ideas, and we may need to, in some certain instances, also look at intellectual disability, and they can all be assessed individually and combined by using formula. So ideas is Indian Disability Evaluation and Assessment Scale to quantify psychosocial functioning, used for assessment of disability related to mental illness. The areas looked are self-care, interpersonal activities, communication and understanding. And the disability grading is from 0 to 5, from no, mild, moderate, severe, profound. And these scores in each area are added to come at a total score. Then some weightage is also given for duration of illness, which is if it is less than 2 years, a score of 1 can be added, 2 to 5 years, score of 2, 6 to 10 years, add 3, more than 10 years, add 4. So this is how global disability is arrived. And if global disability is 0, then no percentage, 1 to 6, by disability less than 40%, 7 to 13 moderate disability, 40 to 70, 14 to 19 severe disability, 71 to 99% quantification. If there is score is 20, then profound disability that quantifies for 100% disability. So this was in brief about the principles of assessment of disability as per guideline. But there are many challenges to implement it. There are large number of conditions. So you need large number of professionals. The method has also been changed. There is low awareness about these methods. Agreement, consensus in certain cases, especially in academic discussion, this goes on in various clinical groups or professional groups regarding various guidelines. There is definite need of orientation and training to train more and more people to quantify disability so that we are able to reach our target as has been emphasized in the policy for disability, and maximum number of people are able to get benefit. And I think this program which is happening, this conference is one of such program only. And then there are limited resources for training and all. I think with this I will end. Thank you all for kind listening.
Yeah, thank you, Dr. Rao. There is a change in program. Dr. Nirmal Surya's talk will be taken now as Dr. Sanjay Wadhwa is not there. So you can ask Mr. Bhavesh to put the introductory slide for Dr. Surya.
Yeah, first of all, I would like to thank Dr. Sharma for a very fine presentation. And I'm sure that the awareness has to be really increased at the district level so that they are the people who give the disability certificates, and we expect that they should be more objective. And the 40% disability is something, assessment is very important so that only deserving get and non-deserving are not given, because a lot of benefits of the government is there, central and state government. So we depend on you for the success of this new law. Yeah. Yeah, it's my pleasure to introduce Dr. Nirmal Surya. He is presently working in Bombay Hospital and Medical Research Center, Mumbai, Saifi Hospital, Mumbai, Northcote Police Hospital, Nagpada, Mumbai. Professional experience, Chairman, Surya Neuro Center, Mumbai, Founder, Trustee and Chairman, Epilepsy Foundation of India, Founder, President, AOCNR, Indian Federation of Neuro Rehabilitation from 2012 onwards. President-elect AIN, Indian Academy of Neurology, Treasurer, NATI, Neuroscience Academy, Telecare, and Artificial Intelligence. Welcome, Dr. Nirmal Surya, and also congratulations for organizing such a very important conference. It's going on very well, and everyone is appreciating. Please take the floor.
Thank you, Professor Rao and Anupam Gupta. I'm indeed thankful to both of you, and I will request three of you to take over Sanjay Wadhwa's session on disability in time left after my talk. So may I request that Hitav to kindly share my presentation, because I think I'm also into the other hall. So I recorded my talk. Thank you. Good morning, friends. I'm going to speak about neurological disability, challenges faced by the neurologist and by the patient in India. So let's move to the disability, which is a health condition and with a personal and environment factor giving rise to disability. And there can be various kind of disability. What we are looking at is lack of ability to perform an activity in a manner or within the range considered normal for human beings. And there are impairment, disability, and handicap. And there can be many types of disability like locomotor, hearing, speech, visual, and the mental. The neurodisability is a group of congenital or acquired long-term conditions that are attributed to impairment of the brain or the neuromuscular system and create functional limitation. There may be a specific diagnosis may be identified, or condition may vary over a time, occur alone or in combination, including a broad range of severity and complexity. And the impact may include difficulty with movement, cognition, hearing and vision, communication, emotion and behavior. So people with disability have either one of the following: born with the condition, or demonstrates a condition early in the life like autism, bipolar disorder, or acquired disability through the injury like spinal cord injury, TBI, or develop a disability later stage like age-related dementia, etc. So you have impact of neurological disorder, and which is a public health channel. As you all know that 1 billion people worldwide suffer from neurological disorder, and that 6.8 million people die annually from this disorder. And I'm going to just quickly go through various neurological disorder which are prevalent in world, and these are the characteristics of the neurological disorder which causes a huge morbidity because they are chronicity, progressive degeneration, limited therapeutic option, and lack of specific treatment for many diseases like the neuron disease. And let's just briefly see the magnitude of neurological burden and related disability, and which is a global scenario, is about 4.2% account world over. It is WHO who and World Bank who suggested that more than 1 billion people in the world experience disability. There is an increase to 6.29 in 2005 and estimated to increase to 6.77% by 2030. And anticipated total mortality due to neurological disorder is 12.2% in 2030. I'm sure my previous speaker also must have stressed upon, and these are some of the daily which is projected from 2005 to 2030. And you can see that neurological disorders are the one which is going to be major problems. And again, among them, the cerebrovascular disorder, Alzheimer's, and epilepsy are going to be major in the disability. And among the after others are like Japanese encephalitis, MS, etc. So you can see that large number of neurological disorder, but Alzheimer's, epilepsy, Parkinson's disease, they're the one which are causing the issues. We, in 2016, Government of India published the Person with Disability Act, and which has section 1 of the Extraordinary Gazette of India by the Ministry of Justice, and the Parliament received assent of President on 28 December 2016, and this bill, which was passed by Lok Sabha, disability has been defined based an evolving and dynamic concept in this bill, and there are 21 disability being included in right of person with disability from. And you can see that these are the total various disabilities included, and neurological disorders are there, most of them. So what are the challenges a neurologist is going to face? The challenges is in assessment and certification of neurological disability, which is number one. So because this is dynamic nature of illness, course of neurological illness could be non-progressive, progressive, episodic, remitting, relaxing, particularly in MS. Hence, it becomes difficult to quantify the disability percentage cross-sectionally. And usually in a particular illness, symptoms vary across a population and also within some population across time. Then multi-dimensional system involvement. So neurological illness affects multi-dimensional systems such as consciousness, motor, sensory, cognitive, affect language, behavior, gait, and balance. Hence, assessing all the above impairment and quantifying them into a percentage are very difficult task. There is not a single instrument to access all the disability together. Then there is invisible impairments like pain, neuralgia, migraine, aphasia, memory loss, loss of sensation, cognitive impairment, bladder bowel incontinence, sexual dysfunction, and so forth cannot be seen. And certain signs and symptoms of neurological illness are often difficult to quantify. Then dominant versus non-dominant. So depending on the involvement of dominant versus non-dominant group, manifestation of illness and disability can vary. Then the treatment and interventions. So availability of timely treatment, continuation of treatment, rehabilitation can limit the disability. Non-availability of treatment lack of insight, or refusing to take treatment for certification can pose a great challenge. Like an acute stroke, if thrombolysis is done, the disability can substantially be reduced as compared to the person who has not returned. And then there is a improvement, recovery, there is illness in which spontaneous remission or recovery may occur, like in certain MS also can recover spontaneously. And then there are non-availability of investigation. There are certain neurological illness are diagnosed by ruling out other causes, and therefore there is not a definite investigation to prove that. And lastly, stigma, illness such as epilepsy continue to have stigma. So these are some of the issues which are challenging. So then there is a temporary versus permanent disability certificate. So neurological illness can be fluctuating, episodic, waxing, waning course of neurological illness. I already mentioned. So what to do? Assessment should be done minimum 6 months after the onset of disease for the sake of disability certification and benefit. I'm sure these will all have been discussed. The Gazette notification allowed flexibility for issuing temporary disability certificate, and in case of ambiguous presentation or not on regular optimum treatment or the disease in process of evaluation, it is always advisable to give a temporary disability certification and ask for recertification after certain months. So about, say, suppose disability certification in Parkinson's disease plays a vital role when acquiring certain benefit and facilitate that are offered by both the central as well as state government. So eligible criteria for a disability certification is individual must be an Indian, there has to be a written diagnosis by a neurologist, doctor's prescription, CT or MRI, and most of the time CT MRI may be normal in Parkinson's disease. So detailed explanation about disability obtained from the doctor. And to issue a disability certificate, the individual must be assessed to have a minimum 40% degree of disability. And the problem is the assessment is done by the neurologist only at the government hospital, where there are very few neurologists, with most of the neurologists again are practicing in the private. Then there is a severity of illness versus severity of disability, which has to be understood, because severity of illness is clinical construct, whereas severity of disability is legal construct. So illness can be defined as degree of organ system derangement in any given patient, and is generally assessed using a variety of demographic, clinical, physiological, and laboratory variable. And severity of illness on a particular specific scale may be 100%. Person may not be severely disabled. Similarly, the severity of disability is not interpretation of the diagnosis disease per se, but the measurement of clinical manifestation. So interaction between person with impairment and attitudinal and environment barrier that hinder their full and effective participation in society on an equal basis with the disability. So these are some of the challenges. You may have a large lesion, but patient may still have just a minimum disability like headache or epilepsy. On the other hand, you have a small infarct in the internal capsule and patient may have a severe disability, just to give you an example. Then there are challenges in the certification of learning disability. I'm just giving an example, like suggested Niemann's battery for SLD assessment is not a comprehensive for all ages and language. And Niemann's battery is standardized for 7th grade, standard only approximately till 14 years of age. How one will assess SLD in age range of say 14 to 18 years will become challenging. And then the big lacuna needs to be addressed at the earliest to determine the severity of SLD disability. And as per the notification, the diagnosis of SLD require a team involving a pediatrician, clinical or rehab psychologist, but no mention of psychiatrists in the assessment and certification. And however, in real life, most of these cases are seen by the psychiatrists or clinical psychologists. So these are some of the challenges, as I mentioned. Then SLD certification will be done for children aged 8 years and above only. The children will have to undergo a repeat certification at age of 14 years and the age of 18 years. And certification issued at 18 years will be valid lifelong. So validation of SLD certification at the age of 18 raises serious questions, such as if child does not get access to one of the mentioned professional for an assessment of SLD at age of 18 years, what will happen? Why are the adult above 80 suffering from SLD deprived for this facility, and how to assess SLD in adult? So these are some of the challenges. There are other issues. Different criteria present for the assessment of disability and impairment. the present assessment format of carrying out a neuropsychological assessment in neurological conditions is absent. The integral part of the assessment of chronic neurological condition is neuropsychological assessment. To ascertain disability is missing, although other aspects have been covered, including physical, verbal, visual, and which is very critical. So interdisciplinary collaboration took an initiative for formatting a committee in, say, July 2013 named as ISTAN, and that is an Indian standard track of assessing neurological disability, and which has stage 1 ascertaining the physical disability of the patient, stage 2 ascertaining the neurological disability, stage 3 ascertain of neuropsychological disability, including the malingering, and this is published in Neurology India, and which would be very useful guidelines for the us to accept. Specific condition with specific need. The need of people with disability, disabling neurological condition. The static condition may become medically stable after a period of sudden onset, but the needs of person changes over time. And these conditions, including say spinal cord injury, stroke, and acquired brain injury. And some of these need of people with disability, neurological condition may be summarized as follows: prompt referral to an appropriate specialist for diagnosis and treatment with provisional of information about the relevant support organization at time of diagnosis, and service needed to be designed to respond quickly, appropriately to change in the need of an individual and their progress of their condition or the life circumstances. So these are the specific needs. Then neurologists need to have specific condition with specific need. So like need of people with non-physical disability, disabling neurological conditions, so need for access to specialized service for diagnosis, rehabilitation, long-term management of these conditions, and then need for frequent specialist review to take advantage of new treatment and the approaches, as many newer treatments are coming. And then there are needs of people with disabling neurological condition where cognitive decline is a major feature, like a clear diagnosis should be made as soon as possible to reduce the period of anxiety for person and their family. Diagnosis should be communicated sensitively in an appropriate setting and with the information provided on the condition. Availability of specialist team around these conditions to the range of healthcare staff in different settings to make sure that these individuals are appropriately identified and responsive. So the future role for neurologists are: clinical neurologists in the healthcare system of the future should have a multifaceted role. In many situations, the neurologist may function as a consultant and as a principal physician for patients with primary nervous system disorder, including PD, MS, Alzheimer's, epilepsy, cerebrovascular disorder, movement disorder, and neuromuscular disorder. And to be successful, future residency training programs should include joint certification opportunity in both neurology and general medicine, and training program for clinical investigator should be expanded. And despite its threat to the specialist, managed care should also provide opportunity for new alliances among neurologists, other specialists, and primary care physicians that will improve both patient care efficiency and cost effectiveness. Then there are challenges faced by the patient, and what are they? They are access to health, access to transport, communication barrier, and poor implementation of policies and the scheme. I'll come one by one. So access to healthcare is majority of neurologists are based in big city, and therefore they are not available to them. Fellowship and subspecialty training after neurological residency are not available at many places, leading to scarcity of trained pediatric neurologists, neurocardiologists, neuroanesthetists, etc., etc. So primary care centers do not have adequate drug and treatment of chronic disorder like PED, Wilson disease, MS, and which may lead to treatment failure and poor compliance. Treatment of MS mainly revolves around steroid in those remote area. Now maybe DMDs are available of neurologists, and treatment modality like IV immunoglobulins, plasmapheresis, IV thrombolysis, epilepsy surgery are rarely used due to very high cost and unavailability. Then there is a communication barrier experienced by people who have disability that affecting hearing, speaking, reading, writing, or understanding, and who use different way to communicate than people who do not have this disability. And use of technical language, long sentences, and word with many syllables may be significant barrier to understanding of people with cognitive impairment. So, and then access to transport. Transport barriers are due to lack of adequate transportation that interfere with person's ability to be independent and to a functioning society, which is much more common in developing world. The physically handicapped person faces a great deal of uncertainty because of their restricted movement or limitation or the loss of locomotor abilities. There are hundreds of activities which a person performs from the moment he wakes up in the morning till he goes to the bed in the night, and the activity comprising everything entertained in human relationships is important. So poor implementation of policies by the government, which has been implemented overall in the society, are frequently related to lack of awareness or enforcement of existing law and regulation. External icon that require programs and activity be accessible to people with disability, and therefore denying qualified individual with disability the opportunity to participate in or benefit from federally funded program, service or other benefit, then denying individual with disability access to program, service, benefit or opportunity to participate as a result of physical barrier, and denying reasonable accommodation to qualified individuals so they can perform the essential function of the job or wherever they have applied or to have been hired to perform. Then there are challenges ahead for developing countries with limited resources, economic burden, and lack of trained neurologists. Among the NCDs, neurological disorders have been recognized to lead to significant mortality, morbidity, disability, and socioeconomic loss. So we have so many challenges now. The major challenges include understanding the concept of disability and acceptance of CBR as a valid intervention. Hospital-based rehab services will lead to mystification of knowledge with social isolation and low efficacy of services which will benefit fewer disabled patients. And poor planning and management of CBR with lack of intersectoral coordination lead to poor functioning of the service to disabled. Non-availability of evidence-based facts, lack of coordination between government and NGO, the absence of a coherent community-level strategy, limited competence and capacity of decentralizing services, limited models of good practice are the other lacuna in the system. And the disability should be considered as an important issue by the government so that this important public health problem can be tackled in the community. And I'm sure Government of India is taking it very, very seriously. And the services should cover all types of disabled who need rehabilitation. And they should be the part of the mainstream development in the community, not in the sideline. The children with multiple or severe disability who might require extensive additional support may access education through the use of innovation method best suited to their context. Collaboration with the employment and labor sector is essential to ensure that both youth and adults with disability have access to training and work opportunity of community level. Monitoring and evaluation in the service delivery should be strengthened and information dissemination should be done. Research with respect to service fund allocation, cost effectiveness, manpower training, and technical aids of disabled people should be strengthened. One of the biggest challenges is providing rehabilitation services to persons with disability living in rural area and small town, and which is really challenging. So what to keep in mind? It is ethically and legally to keep all information confidential, both to respect patients and privacy and autonomy. For healthcare delivery to be effective, patient must feel comfortable in disclosing private information to professionals without fear of social economic repercussion, embarrassment, or the stigma. Only the government hospital and requisite facility at the district level and above can issue the disability certificate, which needs to be expanded. A record of the issue of certification should be retained by the hospital. Who are intentionally insult or intimidate person with disability or sexually exploited women or child with disability shall be imprisoned between 6 months to 5 years or as per the law. These are the take on the PWD Act 2016, which I'm not going to discuss, already must have discussed. So to conclude, research is essential for increasing public understanding about disability, issuing, informing disability policy and program, and efficiently allocating resources to all the neurologists. Some of the important areas of research can be quality of life and well-being of people with disability, where to mainstream and specific services and what works for overcoming them in different contexts, accessibility and university program appropriate for the low-income country, and neurologists must be sensitized so that they can take participation actively in the disability certification and help the patient whom they are treating. Thank you very much for your patience here. Thank you. Have a nice day.
Sir is busy with some other meeting. So sir said to just take the questions later on. Sir will just finish that and comes. Dr. Surya sir.
Yeah, now is there any speaker now?
No, sir.
No.
Now we can have a panel discussion, sir.
Yeah, so I think Dr. Rajendra Sharma is with us, and also I think Anupam is there to handle questions on behalf of Dr. Nirmal and Surya, and I also can take some questions. We can start discussion, but one thing I would say about Dr. Nirmal Surya, it has been a very clear and comprehensive presentation. The challenges that you have raised are very, very important. The issues regarding assessment of SLD and also neurological disorders are very important. Some changes can be made. First of all, I would like to thank the AIMS, Subjang and RML for helping us to prepare the guidelines. If any revision is required, the suggestion that Dr. Nirmal Surya has made, probably a representation can come an expert from an expert like him, or even from the conference. Definitely the government will look into the issues and will be ready to make any changes in the existing guidelines so that the assessment can be improved. So now let us see if there are any questions to the panelists.
At present, there are no questions available.
So can I ask?
Yeah.
Good morning. Sir, I'm Dr. Anuradha Pai, Occupational Therapy from Sion Hospital. I would like to ask Dr. Rao or Dr. Shastri, whoever is available. See, we are doing disability evaluation for patients suffering from mental health diseases. And as per the ideas, we get a range of disability, that is either less than 40%, 40 to 70, or more than 70. So when you write a certificate, is it okay if you write a range of percentage, or you should have a final single number?
Yeah,
it should be a single number.
Yeah, that's right. I agree with you, because in most of the government schemes, when it is implemented, they see the disability certificate whether 40% is there. Suppose you make a range between 30 and 40, then it will be very confusing for the people who are implementing at the grassroots level in various departments, whether they should take it as 40%, or because when you put a range of 30 to 40, it can be even 35. So therefore, compared to other figures, the 40 is something very important, because most of the benefits are given to people who are having 40 and above.
Sir, my question was regarding ideas, that is for mental health disability. You have, they give you calculation in ranges, that is for 40 to 70%. And the points which are given are 7 to 13 will get 40 to 70%. So can we, I mean, suppose the patient scores 8, then can we give it as 45 or 50? And if he is scoring 12 or 13, can we give him 70?
That's right. That's correct. That's correct.
Can you?
You will have to define your own grading system, and you see, mention it in your records.
Okay.
That should be mentioned in your records.
Okay, okay. Thank you, sir. Because many a times psychiatrists keep on asking, why are you giving a range? You should give a single number. And
as a clinician, it is under your purview. If you are able to justify in writing what you are giving, you have to give a proper single number, not the range.
Okay. Thank you, sir.
I think another thing is commonsensical. If you are facing a patient who is having a progressive disorder, then probably you can increase the range, because you know the patient is going to worsen with time. So there probably you can be more generous, as say in the cases of degenerative disorders, as against a case of stroke where you believe there is only one way, either this patient is going to recover or partially recover or not recover at all. So you can be more stringent, whatever is the status after 6 months. So stick to that number. don't give it. But say in muscular dystrophies, patient is having Parkinson, we know patient is secondary progressive multiple sclerosis. So you can be a little bit more generous because you know the patient is, and then you can of course give like patient needs to be reviewed after say 2 years or 5 years because we know the patient is going to worsen. So I think those kind of approaches would help us. But as Rajan Sharma sir told, you have to come with a specific number. It can't be a range.
Thank you, sir.
Yeah, even though I'm a panelist, I would like to probably get some information from Dr. Rajendra Sharma. How do we handle the capacity building at the district level? Because the RML, Safdarjung and AIIMS premier institutions, there's no problem for the general public who are nearby Delhi. But when it comes to the district level, how these three institutions can help in capacity building, educating the officers, the doctors, professionals at the district level in all disciplines. It can be pediatrics.
I think we can say design a project or some program wherein training in batches is imparted. It can be either way. You see, the faculty visits to districts, collect a few clinicians who are engaged from adjacent district, or it can be organized in Delhi. See, creating awareness and giving them training, that's the only way. Number second would be challenge, because now the disability guidelines, you need a neurologist, a psychiatrist. Availability of that kind of person, even in cities, it is difficult to get. In big cities, it is even in government setups, it is difficult to get a clinical psychologist, a speech and language pathologist.
Exactly.
These are the challenges. I don't know, so many training institutes are there where these people are they are all disappearing to America.
And adding to that problem, the guys must have interest. The clinicians, I am talking about my NIMHANS National Institute experience, the clinicians have no interest in doing assessment. They would like to refer it either to their residents or to the social workers or referring to the neurorehabilitation department, simply because they believe you are the board members. Clinicians believe they have more important things to do, like seeing the patients, diagnosing the patients, and this takes low priority. And this is out of Rajan Sharma boss can also confirm, in a multi-specialty hospital, that is another big problem. So the moment patient demands for a disability certificate, refer to so-and-so department for needful. And that
how to correct this?
I think we have to be stringent. It is part and parcel of their work and job and doing in the institute. If the patient is reporting to a neurologist or psychiatrist, not so much with psychiatrists, but a neurologist, neurosurgeons, they have to do it. If they are working in a government institute, whether it's a tertiary, secondary, or CHC, PHC level, whoever, it's part of their job to do the disability assessment and issue the certificates. So that is another big problem which we face in NIMHANS. So I'm pretty sure it is there in all other state institutes also.
Dr. Sharma, is it possible for training through videos and online?
It is possible. It is possible.
And also, like assessment, can it be like telemedicine? Can we have a tele assessment getting done through medical colleges and other departments if a district is having some problem of the shortage of medical personnel?
I think we should think and create such facilities.
Yeah, it can be done.
It should be done rather.
Latest assessment,
with
clinical
so much happening with telemedicine, telerehabilitation. This can also be a possibility.
I think can I say something?
Yeah.
Yeah, Dr. Palandi. I think it should be a local hospital policy that the treating clinician under whom the patient is admitted, he should be the person certifying the disability. If they have doubt, they can get it verified from the PT department, if at all it is there, because these departments are not there everywhere. So I think it should be mentioned in the law itself that the treating physician or clinician, whoever it is, should be responsible for giving the disability certificate. And everybody must be trained how to give the disability certificate. I think that is a basic requirement. Otherwise, I know what you are saying, because patients are made to run here and there to get disability certificates.
But here, if a person is admitted in a private hospital, so does the certificate to be issued by a private hospital?
No, they can't issue it.
That is supposed to be certified by the nearest government hospital.
And there are certain issues like we face in NIMHANS. We using the NIMHANS neuropsych assessment battery for cognitive deficits. The certificates have been issued for the sake of benefit of patients. We issue it. And a lot of times when our psychologists go for evidence in the court, the judges refuse. The moment they come to know that you are not MBBS doctor, you are not from modern medicine, they refuse to take their evidence as expert opinion. So there is another lacuna. So you have issues. So they would be asking, you should be expert, but at the same time, in the eyes of the law, in the eyes of judge, you should be qualified. And their qualification is if you're non-medical persons, they may reject your expert opinion. Sometimes it is accepted, other times it is not.
Sir, can I comment on this?
Sure.
In this new, I'm Dr. Shailaja Jaivan from LTMNC, Professor in Therapy. In our new gazette, it is mentioned that the clinical psychologists, occupational therapists, they all are qualified to give a certificate. So this point can be raised in a court when it is said that you should be a MBBS doctor also. That is just one suggestion. And one more question I wanted to ask Dr. Rajiv Sharma, that if the patient has come to us for SLD and a patient also has a other locomotor disability, like some of the patients are bilateral, like only lower extremity mobility deficit. So can we combine both these disabilities and give the certificate?
Become then multiple disability.
Okay, so we can give that together because
yes,
issue with in our hospital is that is
you
signed.
can give a
SLD
certificate of
by,
multiple disability mentioning both the disabilities and percentage.
Okay, sir. Thank you so much.
Earlier there was some formula, no, for multiple disabilities. Where
It's there, sir.
Still there.
Yeah.
Same formula.
Yeah, same formula is there.
So that the total should not exceed 100.
That is there for everything.
Yeah.
All
Yeah,
disability
it is there,
assessment, it cannot exceed 100%.
Yes, but in our hospital we have a division. Psychiatrists sign SLD certification. So for
that is
this,
for
then I may have to ask. Yeah.
Local government has to decide who is going to issue certificate. That is mandated as per law.
Yeah, I want to inform on this point to the participants that the state governments have been given the power to notify who should be the medical authority. So generally, every state is making the medical superintendent of the district hospital or civil surgeon as the head of the team or medical authority. Among them, they have various teams of depending on which disability has to be handled. So in any case, any changes have to be made, whether even include private doctors or even to include the other hospitals outside the district. It is for the state government to make changes in their notification. Only then it is possible. So some suggestions can be made by the experts from time to time to different districts or states. They can make changes depending on the need if they have any shortage of professionals.
Also, I want to bring to your notice one thing. You must be remembering that earlier, to simplify disability certification, certain obvious disabilities were allowed to be certified by single doctors even at PSC level. I think this time we have done away with that system.
That's right. That has been done.
Remember that we prepared some guidelines for obvious and
that's right.
Disabilities which can be certified by a PSC doctor.
Correct. Blindness and locomotor. So it has been dispensed with.
I think now only the district hospital can certify. That is the rule, That is in Maharashtra.
Panel of doctors.
Yeah, there are 3 people signature required on that.
Yeah.
And that too, they have made area wise, means the district, if you have got a ration card of that district, those people can take in that district. That is something which they have made. So
because they see the domicile. That is why.
Yes, domicile.
Otherwise, somebody who gets less percentage of disability, he may try to get disability from the neighboring district.
Correct.
So, a different disability. So that is why they limit it only to that particular disability where the person is staying.
Yeah.
No other question, I think. Yeah.
Actually, if they have some problem at the as you said, there are no neurologists and experts in other district hospitals, then they refer to the main nearby medical college where all these facilities are available to certify.
Yes, yes. It is the medical superintendent or civil surgeon heading that hospital can take a decision to get views that too from any government agency, even outside the district.
Yeah. I think we are come to the end, so I think we can close this session because we have to go for the next session on invited guests lecture now.
Yeah, I think I should thank all the speakers, very enlightening. I'm sure it has been very useful for the participants. And I also congratulate the conference for including this subject as part of your conference. So thank you very much.
Sir, we would like your support, and certainly we would like more number of neurologists to be trained. So please guide us how the government can join along with IFNR and Indian Academy of Neurology to train the neurologists across the country for certification of disability, as well as can give you certain thing that even the neurologists, as you know, that still in government area only people can certify. So how best we can train them that they can be eligible to certify more number of disability.
Yeah, in your absence, I made a point that a representation can come from you as an expert or as a recommendation from the conference to the ministry on the issues of making any changes relating to assessment and also how to make it more effective. So we will definitely look into your recommendations.
Excellent, sir. Thank you. I will revert to you after the conference with all the detail about this session and recommendation.
Sure,
thank you, and thank you for sparing so much of time and be part of it.
Thank you.
Thank you.
Thank you, Anupam, and thank you, Rajendra Sharma ji. Thank you. So, Palandi Sahab, can you invite the next session speaker, Dr.
Dr.
Shantala and Katpal ji, and Dr. Michael Todd's talk is recorded, so it has to just be there.
Okay. I think Bhavesh, you please put the slide of Dr. Khatpal for me.
So
to
Bhavesh may
introduce
not have the slide of Dr. Khatpal. I will introduce Dr. J.S. Khatpal, is senior most neurologist from MP and very, very dear colleague with a special interest on the music. He himself has been associated with music therapy for last 20 years, and he has always been part of our session in IFNR. Shantala Hegde is a well-known scholar, neuropsychologist from Niemens, who has been a trained musician and has done tremendous work in music therapy and cognition therapy. Recently, she held a conference on the music therapy for cognition. So I welcome both the chairperson and chairperson kindly introduce Professor Michael Todd. Shantala is knows Michael Todd for years, and she could very well introduce.
If you want me to introduce, I didn't get that part. Should I? Or see, so Katpal sir would.
So you can introduce.
Oh, okay. Namaste to all. It's indeed an honor, and thank you, Nirmal sir, as always, to be making me part of this family of the rehabilitation team. We are really honored to have Professor Michael Todd. He's a musician himself, and after his immense training in music and as a professional musician, he went on to do his training in medical science and neuroscience. Today he's the director of the Music and Health Science Research, the MAHRC, and Music and Health Sciences graduate programs in University of Toronto. He is also the Canada Research Chair Tier 1 awardee, and he is also the director of the Neurological Music Therapy Institute, which he carries out along with his wife, who is also a trained music therapist and a musician. And he is one of the leaders in the area of bringing neuroscience perspective to music therapy research and rehabilitation and application of it in the field. So we are really honored to have Professor Michael Todd's lecture in this program. And personally, as Nirmal sir said, until the video comes on the screen, I thought I was one of the students of Michael Todd. I got training.
Bhavesh,
under him.
kindly play the video of Dr. Michael Todd, please. Carry on, Santla, carry.
So, Professor Michael Todd, his academy conducts many training programs across the world for youngsters. So the whole movement is to make music therapy more scientific-based, evidence-based work. And more and more number of interested researchers, young scientists should come forward in our country and take this field forward. I think having this program in a platform like this is really an honor, I would say. An acknowledgement of that perspective.
Hello, how are you?
Namaste, Katpal sir.
How's everything? All good?
Haan, sir. Haan, sir. Good.
Nirmal Bhaiya, Ram Ram. Dr. Palande, how are you?
Fine, fine.
Is there any problem,
Nice to see you.
Bhavesh? Then Hitav can do it if you are not able to find the talk. Okay.
See, no words. Can I speak for a minute? Yeah.
Bhave sir, can you pause once? Katpal sir wants to speak, sir.
No, it's okay. Yeah. See, I was just telling one sentence that no injections, no bitter pills, no hard work, straight listen to nice music and get treated. And you will get good results. This is one of the new things today, which everybody should know about it. Try to listen, try to popularize it so that more and more patients can benefit through this. We can carry on with the lecture.
Oh, Nirmal sir.
Voice is not there, Bhavesh.
Bhave sir, if you can just unshare, I can share it from my side, sir.
Become a more and more important topic over the last 15 to 20 years because the research has shown that music as a brain language can have an enormous impact on the rehabilitation of the brain and the neurodevelopment of the human brain. So my talk will be on advances in clinical music neuroscience research, extending and affirming clinical applications for neurologic music therapy. I'm a professor in the Faculty of Music, and I also have a cross appointment in the Faculty of Medicine in neuroscience. So just a quick look at the idea of what are we talking about when we're talking about music. Music is most certainly a biologically hardwired language of the human brain. The flutes that you see here are 45,000 years old, and they're in a fairly elaborate fashion produced bone or ivory with boreholes that are in equidistant, so you can actually play even modern scales on them. So we're not talking about music as a pure artistic luxury, an aesthetic embellishment of our life. We're talking about music as the most complex auditory language the human brain has constructed. So the research that I've been doing and many of my colleagues, we call clinical music neuroscience. And we are investigating translations of brain processes in music perception, music cognition, and music production to improve brain health, brain rehabilitation, and neurodevelopment. And these translations into non-musical applications constitute the basis of neurologic music therapy, which is the clinical branch, what the clinicians do. So what is neurologic music therapy? As the next question. It's an evidence-based profession using music-based interventions in sensory motor, speech language, and cognitive affective rehabilitation. It's endorsed as an evidence-based model of neurorehabilitation by actually the WFNR. Currently 5,000 clinicians in 60 plus countries are certified. Most of them are music therapists who have specialized in neurologic music therapy, but we also have a large number of non-music therapists, physiotherapists, speech therapists, psychologists, who within their standard of practice using music-based interventions and have gone through the international certification training, which the Academy of Neurologic Music Therapy offers 6 to 8 times a year. And they're mostly virtual in the last year, but they will also be going back online live. So if you want to find out more about this, the website is right there, www.nmtacademy.co. So neurologic music therapy, one of the most prevalent techniques for gait training, RS, rhythmic auditory stimulation, is actually in the official US Canadian stroke care guidelines. Similar efforts are underway in the United Kingdom. And so we are seeing a very interesting development here in terms of NMT becoming firmly anchored into the neurorehabilitation healthcare system. Music-based interventions were unknown 25 years ago, and now they are a core part of brain rehabilitation. Okay, quick look at some of the functional music processing in the brain, which underlie the whole process, why music actually can become a rehabilitation modality. So for instance, let's look at the arcuate fasciculus here for a moment. It's a critical pathway connecting auditory areas to language areas, like Broca's area, executive areas in prefrontal cortex, and also synapsing with motor areas in the premotor cortex and the primary motor cortex. So sound, structured sound, is transported, distributed into the brain in different areas in the brain. And this is one of the bases, for instance, why in stroke during Broca's aphasia, these people affected by Broca's aphasia can still sing words, and we can retrain the functional speech areas through music. This is also one reason here in the connection between the motor area in the auditory area, why people with movement disorders respond extremely well to rhythmic stimulation to walk much, much better. And we have published many, many papers on that. We have found in research, especially with Parkinson disease, which we've done quite a bit very intensively in the last 4 or 5 years, that we have actually, we see indicators of brain plasticity in cerebellar motor networks that improve mobility in Parkinson's disease when we use music-based gait training and mobility training with persons with Parkinson's disease. This is the continuation of what we're showing here. And even upper extremity work, which we published a couple of years ago, this persons with Parkinson's disease, we see increased functional connectivity in the beta and gamma band coherence between the auditory and the motor cortex. That's schematic. So everything in blue is after 3 weeks of training, enhanced signal waveform signal synchrony. And here we see it in the actual signal pre-NMT in A, pre-NMT in the motor cortex B, and then, sorry, we see at post the increased signal coherence between the motor and auditory areas. So it is very clear, this is actually an MEG study. It is very great evidence that NMT-based, music-based training of the upper extremities, mapping functional movements, reaching movements, reach a variety of arm and hand and finger movements, mapping on musical instruments, percussion and keyboard instruments, induce brain plasticity, leading to higher functional performance, but also changing the brain, the underlying brain measures. This is a recent study that is a sequence of studies actually looking at dopamine imaging, which is the University of Toronto where I work, is one of the few places where we can actually do this neurotransmitter imaging. And we're looking at the effect of music-based cueing of hand movements versus self-paced rhythmic hand movements. And we're seeing actually a reduction in dopamine uptake when people use music, which means potentially a reduction of a reliance on a dysfunctional system. The dopaminergic system in Parkinson's disease, as you all know, is dysfunctional. This is a very recent work that we're doing, which has not been published yet, but it's very, very interesting. So I wanted to show this to you. We are doing, during deep brain stimulation implantation, we can actually do intracellular recordings using self-paced rhythmic movements versus music-cued rhythmic movements. And the self-paced intracellular recordings in the GPI, globus pallidus internalis, you see it's a very sort of static, tonic response that is not focused around the actual movement of the hand, the rhythmic movement on the hand. When we use music-based rhythmic cueing, then that intracellular response measured through the EEG, intracellular EEG recordings, changes completely and becomes phasic and centered and focused around the hand performance, and the actual timing of the movement also becomes better. So this is the underlying intracellular response that leads to, is associated with a more stable hand movement, rhythmic hand movement. So we are doing quite a bit of that kind of research right now, looking at mechanisms, neural mechanisms that are underlying the tremendous clinical benefits that we see in music-based interventions in neurologic music therapy. This is a study that we recently completed, and it's under review. We already published one part of it, the other part is under review, where we look at music-based periodic arm training in chronic stroke. And these are the data after 3 weeks from the Fugelmeyer test, and they show in all 3 conditions, there were a variety of training conditions that also were associated with some with motor imagery. So the music-based intervention models showed significant increases in chronic stroke, in upper extremity movement. Again, the training was based on using keyboard and percussion instruments and also digital tablet surfaces to map function movements onto them. This is the Wolf motor function test, and this is the Fugelmeyer. Going a little bit into cognition here. This is a paper that we published in Neurorehabilitation actually this year. And it shows that in traumatic brain injury, in chronic stages of traumatic brain injury, cognitive attention training, music-based attention training showed significant improvements in the trail making B test over attention process training, which is a big standard neuropsych training. So musical attention control training showed significant improvements here, whereas the attention process training showed no differences pre and post. So music is a modality that can be used, as I said before, in sensory motor, in cognition, and in speech language very, very effectively. This is a study we published in Alzheimer's Dementia. That's more of a translational practical journal, where we looked at a music-based music listening program together with a community symphony, professional symphony. So these the persons with Alzheimer's disease and their spouses went to concerts over a season, and we then measured their outcomes, and they actually showed significant differences in several of neuropsych assessments, like the Digispan and the I-bands and other tests. Following up on this, we just completed a fMRI-based study with Alzheimer's disease, where we looked at the networks that are associated with long-term musical memories, which are often still preserved in Alzheimer's disease, whereas other memory networks are basically not functional anymore. And they're often, these musical networks, musical memories are often associated with autobiographical information. So we can sort of almost see at least momentary cognitive boost. And this is a study we published last year, Alzheimer's disease and associated disorders 2020. And what you see here clearly is that the music that I'm listening to in the scanner that I've known for 25 plus years, that's the red network, and it is a widely distributed network, bilateral. With prefrontal areas engaged, but also subcortical areas, basal ganglia, cerebellum, and some of these areas are clearly not are spared from the disease process. So we have, for the first time, evidence why music-based interventions can actually facilitate improvements, at least momentary access to more functional cognitive processes in Alzheimer's disease. The blue network is music that they heard new music that we composed, and they heard an hour before they went into the brain scanner. And then they heard it again 1 hour later. So this is a 60-minute music memory network. And you can see this is mostly just an auditory sensory network, which will not survive very long. After 3 weeks of listening, we found actually something quite astonishing. We found in the MoCA significant improvements in the memory subtest of the MoCA. And we also are investigating currently increased functional connectivity in between certain networks, inferior frontal gyrus, right thalamus, and also middle cingulate and right prefrontal cortex. We are currently investigating that and have a paper on that under review. A quick look at developmental processes, music-based interventions for autism. This is a study by Grace Lay, published in Brain 2012, shows very interesting that when children with autism listen to the speech of their parents, their speech networks are actually fairly silent, whereas when they listen to the parents singing words to them, the speech areas actually become quite functional and active. So this is very interesting, which requires further research. Similar findings were found by Megha Sharda in Montreal and her group. Frontotemporal connectivity is preserved during sung but not spoken word listening across the autism spectrum. So this is a brief view on neurologic music therapy and music neuroscience research in the developmental stages. To conclude briefly, our lab, the Music and Health Science Research Collaboratory at the University of Toronto, my postdocs, students, research coordinator, Veronica Wong, our PhD students, Bing Li, Nicole Richard, Chantal Whitehouse, Anna Kaprasis, Tara, Henakwa Chamara, Maria Pranzic, Stephanie Levine, Lauren Cole, Jessica Teach, Melissa Tan, my postdocs, Yuko Kojimori, and Tristan Loria. And here, the main collaborators, we have a very widely distributed network of collaboration at the University of Toronto to do clinical music neuroscience research and translational research into neurologic music therapy. And with that, I thank you very much for your attention, and I wish you a wonderful conference, and I hope that I will be in touch with many of you in the future times. Thank you.
Thank you very much, Dr. Michael Todd. I hope you gave a wonderful review of what is being done these days in the neurological music therapy. It included patients with traumatic brain injury, with Parkinsonism, with stroke, and also developmental therapy for autistic children. If anybody has any questions, I don't know whether it's the Dr. Michael Todd is available for any question or something.
No, he's not. But if any questions there, we'll send him the email. But
so it was a wonderful lecture. There's no doubt about that. And I think it was a very similar lecture to what we heard him last time also during our World Conference. And there are now lot of things which are going on in the music therapy. And especially now we don't even talk only about music therapy and what is happening, whether the patient is smiling, doing this, that. Now we do fMRIs and PET scans and things of that kind and record in the brain as to what is happening there. So anything else, Dr. Nirmal Surya?
everybody from hall, this hall to join hall 1 for the presidential oration. This hall will be in function after post-lunch 2 o'clock. I request all of you to kindly join hall 1, please.
For the lunch?
No, for the presidential oration.
Yes, yes, sure.
Lunch is after that.
Yeah.
Lunch at your home. in your cozy environment.
पर आपका नाम ले लेंगे आज लंच खाते में.
We'll भेज देना.
Okay.
Thank you so much, sir. It was a wonderful talk. Yeah.
Dr. Nice seeing you.
क्या आजकल?
Dr. Hegde, nice talking to you. Nice seeing you.
Yes, sir. Thank you, Deepak, sir. Bye.
Thank you. Thank you.
Bye-bye.
On AOCNR, I thank chair session and I thank all the speakers of this session. Thank you so much, ma'am. We can go ahead.
We have to go to hall 1.
Yes. Please join for the presidential oration before the lunch. It's pre-lunch session. We request you to come to hall 1.
We have to leave this hall, no?
Yes, sir. This is
Leave-
hall 4. So we'll.
You have to leave this meeting also, no?
Yes, sir.
Okay.
Thank you so much, Dr. Katpal.
Thank you. Thank you, dear. Thank you. Nice. Bye-bye.
Bye.
Dr. Palande,
Thank you,
bye-bye.
ma'am. Thank you so
Thank you
much.
for coming.
Nice talking to you after a long time, really.
Yes.
Good. Just 5 minutes के लिए hall 1 लगा.
कई सारे हैं.
अच्छा, ये तो 8 से spelling अलग बता रही है.
क्यों EIGST?
3 ही देखो. EIGST आएगा.
हाँ.
तो 3 ही देखो.
Good morning, friends. I'm going to speak about
Bhavesh, can you hear me?
Yes, sir.
Mansi. No, I am in which hall now?
What is the name of name?
I am supposed to be in hall 4.
Hall 4, yes.
Is this hall 4?
Yes, yes, sir.
Okay, then it's okay. Because here you can't make out where you are. Sonal, you are there, no?
Yes, sir. Hello. Good afternoon.
Yeah, I think is it 2 o'clock?
Yes, sir. Is chair ready?
I think we should start.
Yeah.
Hello, ma'am. Good afternoon.
Good afternoon.
Yes.
Good afternoon. Am I going to start?
Yeah.
Bhavesh, sir, can we have CV slide and the details of session?
CV of I think Sita Jayalakshmi is there.
Yes, sir.
Dr.
I'm there.
Bhavana Sharma is there. I think he should put up the.
I am there, Dr. Sita. I'm
Sita,
there.
ma'am. Hi.
Hi. I am
Sita,
there.
yeah.
Yes.
Bhavesh, put the chairperson's CV.
Chairperson CV.
That is Sita Jayalakshmi and Bhavana Sharma.
Yeah, maybe we can start the session.
Yeah, I think Sonal,
Yes,
you
sir.
can
They will
introduce
just-
both of them briefly.
Yes, sir. They will just share the slides.
I don't know.
Dr. Bhavna, Dr. Sita.
Yeah, should I
Mansi,
start?
the slides.
I think
Mansi, the slides.
Well, it doesn't matter. I think
Sonal,
we are
you
getting
just
late and I should start the
introduce
session.
briefly.
Yes, yes.
Yeah, that's very important.
Welcome all to the
I'll
session.
introduce myself.
Okay, ma'am. So I welcome Dr.
Good
Sita
afternoon.
Jayalakshmi, renowned epileptologist and very active neurorehabilitation professional and very supportive of IFNR endeavors. I welcome Dr. Bhavna Sharma to chair this session. Over to you, ma'am.
Yeah, good afternoon, everyone. My sincere thanks to Dr. Surya for the opportunity given to me. This session is basically on neuromuscular disorders, and we have 4 eminent speakers, 3 from India and 1 from Malaysia. I first invite speaker Dr. Hussain, who is from Malaysia, and I'll just read out her CV. CV slide is missing from my screen. Yeah. The CV slide
Mansi,
is not
please
there on the
flash the
screen.
slide. Hello, sir. Dr. Surya
Dr.
has just
Hussain,
joined.
yeah, let me begin now. Dr. Hussain is a consultant rehabilitation physician at hospital at Malaysia. She completed her postgraduate study in the University Malaysia and pursued clinical fellowship in neurorehabilitation in Canada. She is actively involved in the 16 to 19 editions of Evidence-Based Review of Stroke Rehabilitation, EBR-SR. She also co-authored book chapters in the stroke recovery and rehabilitation, ischemic stroke therapeutics. She is the medical representative for Asia-Oceania Society for Neurorehab and heads the Malaysian Association of Rehabilitation Physicians on stroke and neurorehabilitation. She now heads the Neurological Rehabilitation Unit Hospital at Malaysia and holds special interest in stroke rehabilitation and rehabilitation of neuropathy and neurodegenerative disorders. It's my pleasure to welcome Dr. Hussain for the talk.
Thank you very much, Madam Chairman. I will proceed with sharing my screen, and thank you again for the opportunity to be here. These are the nodal points of this lecture. First, so I will just stop sharing for a while and get back to the presentation. Just give me a minute. These are the nodal points. These are the nodal points of this lecture. First, we will take a quick glance at GBS. Then we'll go in depth and look at all the GBS variants. And then we'll move on to know the mimics, chameleons, contrast, and overlaps of GBS. Finally, we will look at the potential diagnostic challenges, especially the new rehab setting. And then we'll move on to the end. Let's have a quick glance at Guillain-Barré syndrome. It is an inflammatory disease of the peripheral nervous system. It's monophasic in nature, but some 2 to 5% of the unlucky ones may have recurrent GBS. It's usually preceded with an antecedent infection and can present with either URTI or AGA symptoms. And there is involvement of anti-ganglioside antibodies, and diagnosis is largely based on clinical features and supported by serological and electrodiagnostic investigations. What happens at the cellular level in Guillain-Barré syndrome? This illustrates the immunopathogenesis for both AIDP and Alman and Amsan. In AIDP, the antigens are on the myelin sheath, and when antibody binds, complement activation will occur, forming membrane attack complex. And this will cause nerve injury by the fact that the macrophage will sit on the myelin and invade the myelin and can cause myelin invasion, therefore resulting in demyelination. In Aman and Amsan, the antigens targeted are placed at the nodal ring veil, and again, complement activation will occur, forming membrane attack complex. This will be followed by macrophage trying to seep in and invade the nodes via the periaxonal space, and then finally scavenging on the injured axons. And this causes axonal involvement that you see in Aman and Amsan. GBS is the leading global cause of acute flaccid paralysis. And the annual global incidence can range anywhere between 1 to 3 per 100,000 persons. The lifetime risk of GBS in the general population is rather low, of 0.1%. And males seems to be more unlucky than females because GBS occur more frequently in males. Anyone can have GBS. It happens to just about anybody, but the incidence does increase with age. Let's look at the worldwide GBS incidence and subtypes. In AOCNR, let's look at the incidence in Japan. So it's 0.4 up to 3.25 in Bangladesh. And then subtypes commonly seen in East and Southeast Asia, EIDP and Miller-Fisher syndrome. Whereas in Bangladesh and North China, Arman was commonly seen. Looking at Oceania in Australia, the incidence is 1.35 per 100,000, and the common GBS subtype is AIDP. So cumulatively in Oceania, the more common subtypes identified are AIDP, Arman, and also middle Fisher syndrome. In comparison, the other parts of the world, particularly in North America, Europe, and also the Middle East, the most common GBS subtype seen are AIDP. With Guillain-Barré syndrome, some individuals experience antecedent infection just prior, several weeks perhaps, from the time of onset of the weakness. When the time of onset occurs, the weakness will become worse until it reaches a clinical nadir, and this is a very important point, as this is the lowest point ever, or is the worst presentation that the patient may experience before they bounce back again and become better, and finally experience the recovery at a later time. So the clinical nadir is the worst point ever, and usually will occur within 4 weeks. Most of patients with GBS will reach clinical nadir within the first 2 weeks, and 85% will reach the nadir within 3 weeks. Progression of symptoms beyond that point, and definitely more than 4 weeks after, bring the diagnosis of GBS under question. With GBS, the clinical improvement is usually more extensive in the first year, but this can continue for even up to 3 to 5 years after onset, and 60 to 80% of patients with GBS are found to be able to ambulate independently 6 months after disease onset. The classical features of Guillain-Barré syndrome, as we know, include ascending flaccid bilateral limb weakness with decreased or totally absent deep tendon reflex, and with a raised CSF protein concentrations but without pleocytosis. And these are the same clinical features outlined in the Brighton criteria to determine the level of diagnostic certainty for Guillain-Barré syndrome. But the thing is that we know that there are clinically distinctive variants of GBS, and atypical cases of GBS actually exist. And these cases may not rank high on the diagnostic certainty based on current existing Brighton criteria. GBS can present with typical symptoms or atypical symptoms. Atypical symptoms include pure motor symptoms, weakness in only the legs, or asymmetrical weakness, prominent sensory signs, respiratory failure disproportionate to limb weakness, or autonomic involvement. And this will present as variants or chameleons of Guillain-Barré syndrome. The atypical GBS symptoms can also have their own differential diagnosis, and the differential diagnosis to atypical GBS symptoms are the mimics of Guillain-Barré syndrome. Having said that, the differential diagnosis of even those with typical GBS symptoms can only pose as mimics, and this includes involvement with the spinal nerve, myasthenia gravis, transverse myelitis, multiple mononeuropathy, among other differential diagnoses. There are several GBS atypical presentations which form GBS variants, and these include facial weakness, which can be bilateral, ataxia, ptosis, hypersomnolence, asymmetrical weakness of the extremities, and even presence of deep tendon reflexes. Previous series have shown that the reflexes may even appear brisk in up to 10% of patients with Guillain-Barré syndrome. Therefore, neurophysiological classification using demyelination versus axonal involvement may not fully describe the spectrum of GBS presentations. And classification based on regional or topographic pattern was found to be more useful. This is a graphic representation of the pattern of symptoms typically observed in the different clinical variants of Guillain-Barré syndrome, and include the distribution of motor symptoms, sensory symptoms, whether there's decreased conscious level, and also ataxia. The presentation can be localized to specific regions of the body, and the patterns differ between variants of Guillain syndrome, and we'll go through these variants one by one. The most common variant is classic sensory motor Guillain syndrome, and they account for 30 to 85% of all GBS cases worldwide, and they present in the classic manner with rapidly progressive symmetrical weakness and sensory signs, with absent or reduced tender reflexes, and they usually reach generally the worst point ever within 2 weeks, and may also have respiratory compromise. Second variant is pure motor and accounts for 5 to 70% of GBS cases. And they only present with motor weakness without any sensory signs and can involve upper and lower extremity and also the faces as well. The third variant is the paraplegic Guillain syndrome, and this is between 5 to 10% of GBS cases. The paresis is restricted only to the lower extremities and involve motor and sensory signs, just like a paraplegic. The next variant is pharyngeal cervical brachial Guillain syndrome. This is rather rare, with less than 5% of GBS cases, and they typically present with weakness of the pharyngeal, cervical, and brachial muscles, but without any lower limb weakness. And the motor symptoms and sensory symptoms are present in these patients. This lady was referred to as 5 weeks after onset of weakness, and she has significant oropharyngeal dysplegia and had to be on nasogastric feeding. She also had significant cervical weakness. There was absence of anti-gravity muscles over the proximal upper extremity. Several weeks later, she had a bit of power and could lift the hand off the table. And this was her doing some therapy, but this was just how much she could actually abduct the shoulder. But she had intact lower limb strength and was able to climb up and down stairs and able to walk as usual. And lower extremity strength were only mildly affected. So what she had was a pharyngeal cervical brachial dyspnea variant of Guillain-Barré syndrome. Bilateral facial palsy with paresthesia is another variant which is uncommon and accounts for less than 5% of all cases of Guillain-Barré syndrome, and they present with bilateral facial weakness, paresthesia over the extremities, and reduced reflexes. This lady presented with bilateral facial weakness, and she could not close the mouth, neither could she close the eyes because of the significant facial palsy. She also has reduced reflexes and was referred as bilateral weakness with paresthesia by the attending neurologist prior to referring her for rehabilitation. Even more common is pure sensory Guillain syndrome, and this is less than 1% of the percentage of GBS cases. And how did it present? Patient can either present as acute subacute sensory neuropathy, only sensory but without any other deficits. So it's a pure sensory impairment. Miller-Fisher syndrome is a principal variant of Guillain syndrome and accounts for 5 to 25% of all cases of GBS. And classically, they present with ophthalmoplegia, ataxia, and reflexia. Those are the triad. Incomplete forms with isolated ataxia or ophthalmoplegia may also occur, and this can form the form thrust. Miller-Fisher syndrome can overlap with classical sensory motor Guillain-Barré syndrome in an estimated 15% of patients. This gentleman was referred for neurorehabilitation for significant risk of fall due to ataxia and concurrent diplopia caused by ophthalmoplegia. When he presented, he had significant ptosis of both the eyes, more so over the right, and very prominent ophthalmoplegia, which caused the visual disturbance. He is unsteady, significant ataxia was there. If you notice, he had to have a hand to hold it from behind as he tends to fall forward because of the unsteadiness. And this is classic Miller-Fisher syndrome. Bickerstaff brainstem encephalitis is somewhat unique, and it accounts for less than 5% of cases of GBS, present with ophthalmoplegia, ataxia, and reflexia, not unlike the Miller-Fisher syndrome, but they do have pyramidal tract signs and impact consciousness. And it was often seen to be overlapping with sensorimotor Guillain-Barré syndrome. The GBS chameleons are actual GBS conditions presenting with atypical or under-recognized GBS presentations masquerading as non-GBS medical conditions. And the common chameleons or atypical presentations include paraplegic GBS, bifacial weakness with paresthesia, acute ataxic neuropathy, acute ophthalmoplesis, and acute ptosis. The acute ataxic neuropathy, acute ophthalmoplesis, and acute ptosis are examples of form thrust of Miller-Fisher syndrome, and this implies an incomplete manifestation of Miller-Fisher and does not fulfill all the Miller-Fisher triad. In other words, form thrust is an atypical and incomplete manifestation of a disease or syndrome, and it does not fulfill all the diagnostic criteria. The GBS mimics are conditions which resemble GBS but is not a GBS. And this case series looks at the clinical presentations and the clinical features atypical for Guillain-Barré syndrome and also the final diagnosis. So some of the atypical clinical features described are recurrent weakness with encephalopathy, gaze-evoked nystagmus, asymmetric weakness, patchy sensory loss, systemic malignancy, relapsing, remitting, and progression of weakness over 4 weeks, which is the usual weeks of the nadir. And the final diagnosis includes chronic encephalopathy, vasculitic neuropathy, acute intermittent porphyria, chronic inflammatory demyelinating polyneuropathy, and even acute onset of chronic inflammatory demyelinating neuropathy, which is one of the common GBS mimics. These cases illustrates how GBS mimics can occur. The first case involves a 43-year-old man with presentation of tetraparesis, partial ptosis, somnolence, and worsening respiratory profile, and the emergency was needing intubation. Initial CT scan was normal, and there was no albumin cytology dissociation in CSF, and the anti-ganglioside Q1 antibody test was negative. MRI just showed all parietal infarct. He was treated as GBS Bickerstaff brainstem encephalitis with IVIG. But then when he was brought to us for the first neurorehab consult, he was noted to have nystagmus with abnormal breathing, requiring re-evaluation of diagnosis. And true enough, eventual subsequent MRI, which was arranged, showed large pontine and cervicomedullary infarct. So the second case involved a 60-year-old man with progressive symmetrical sensory loss, limb weakness, areflexia, and autonomic dysfunction. NCS was suggestive of demyelinating polyneuropathy. 4 weeks later, after treatment with IVIG, he developed worsening weakness, and this was thought to be because of treatment-related fluctuation after IVIG. He showed good functional recovery with intensive rehab as inpatient. A repeated NCS at 8 weeks showed progressive demyelination. And because of this, based on the electrodiagnostic findings with progressive demyelination, at the timeline of the disease, which was more than 8 weeks, diagnosis was revised to acute onset of chronic inflammatory demyelinating polyneuropathy. So these are examples of how GBS mimics can present to us in neurorehab setting. As illustrated in previous case, classic sensory motor GBS are often mistaken for acute onset of CIDP, and the clue would be progressive features and symptoms on physical examination and also NCS findings, and the clue would be the nadir extends beyond 8 weeks. The Miller-Fisher and pharyngocervical variants of GBS are frequently mistaken for brainstem stroke, botulism, or myasthenia gravis. And in cases whereby because brainstem encephalitis was often diagnosed as Wernicke's encephalopathy, and those are the common GBS mimics. Apart from the GBS chameleons and the incomplete form, there can be overlaps between the different variants of GBS. Overlap of Miller-Fisher syndrome have been reported with pharyngocervical variant of GBS. The significant overlap between clinical and serological profiles of the patients supports the view that MFS and PCB actually forms a continuous spectrum of Guillain-Barré syndrome. Besides this, there can also be an overlap of Miller-Fisher syndrome with classical Sensory-motor GBS. And again, features can be quite bizarre and unique. And this is the unique clinical features of Guillain-Barré syndrome. In the face of pandemic, diagnosing Guillain-Barré syndrome becomes even more tricky as the presentations can be rather heterogeneous. So this is a case series of 5 patients with Guillain-Barré syndrome after the onset of COVID-19. And we shall look at patient number 1, 2, and 5. The first patient developed flaccid areflexic tetraplegia, evolving to a facial weakness, and finally respiratory failure at day 6 of presentation. This is rather classical of a classic sensory-motor Guillain-Barré syndrome. The second patient had facial diplegia and generalized areflexia, evolving to lower limb paresthesia, but with an added ataxia. So this is rather suggestive of bilateral facial possible paresthesia with an added sign of ataxia. The fifth patient developed facial weakness with flaccid areflexic paraplegia at day 2 and 3, and finally respiratory failure. So he was also respiratory compromised, and therefore this seems to be like overlapping of bilateral facial possible paresthesia, paraplegic, and also classic sensory-motor, which is the norm of patients developing Guillain-Barré syndrome, especially with COVID-19. There are many clinical challenges which lie ahead. The differential diagnosis of Guillain-Barré syndrome is truly broad and is very highly dependent on the clinical features of the individual patient. Therefore, the phenotype recognition and topographic features of GBS variants, supported by electrodiagnostic study and serological investigation, will permit more precise diagnosis and also assist in outcome prognostication. But we do know that in low-resource areas with incomplete diagnostic facilities, patients may not be well investigated. Especially now in the face of a pandemic, GBS and COVID-19 will also pose a potential diagnostic challenge due to the various clinical manifestations. The accurate diagnosis of GBS requires deep understanding of the GBS variants and potential GBS mimics, chameleons, first, so we do not miss any important diagnosis. And due to the spectrum of very heterogeneous clinical presentations, many other neurological conditions are often mistaken for GBS, especially during the early acute stage and prior to transfer for intensive neuro rehab. So because of our unique position as neuro rehab professionals, we're likely to encounter GBS mimics, chameleons, and fanfrust in our neuro rehabilitation setting. And identifying the accurate diagnosis is truly necessary to allow us to prognosticate and propose a good structured rehabilitation plan inconsistent with the underlying disease process and expected recovery pattern.
Thank you, Dr. Hassan.
With the GBS variant,
I think your time is up.
Mimics, chameleons, fanfrust, and overlaps of GBS do exist. It is make us realize that potential diagnostic challenges actually lie ahead. And in our position as neuro-rehab professionals, because of the disease manifestation can actually occur at any time during our care, let's all be very vigilant and provide the best care for our patients. Thank you for your full attention and participation.
Thank you so much for such nice and elaborative talk on Guillain-Barré syndrome. Thank you so much.
Thank you.
We shall have
Thank
the
you for
queries at the
participation.
end of the session. Okay. The next speaker is from India, Dr. Satish Khadilkar, who requires no introduction in the field of neurology and especially in neuromuscular disorders. Today, he shall be going to talk on newer avenues in the treatment of neuromuscular disorders. Dr. Satish Khadilkar, sir.
Thank you very much. And firstly, let me congratulate Dr. Nirmal Surya and the organizers for this beautiful meeting. And I must also thank the chairpersons, Dr. Bhavana Sharma and Dr. Sita Jayalakshmi, for chairing this session so ably. The topic that has been given to me is newer therapies in neuromuscular disease, and I am told that the audience is mixed. So I will touch upon two main areas, Duchenne muscular dystrophy and spinomuscular atrophy. And then we will also touch upon some others if we have the time. So firstly, let us start with the Duchenne muscular dystrophy, because it is the most common disease seen in the clinic. And of late, in most of the countries, rehabilitative measures and phenotypic expressions and genotypic expressions have been worked out. And as you know, this presents in children. It produces progressive muscle weakness at very young age with lordosis, calf hypertrophy, and ankle contractures. And as you can see in this figure, all the 3 points are seen very well. There are ankle contractures, there's calf hypertrophy, there's lordosis, and there's also little hypertrophy of the deltoid and the scapular muscles. Now, the genetics of this disease is such that it's a very large gene. In fact, one of the largest genes known to man, with 79 exons and multiple hotspots. And the problems are usually deletions. Some of them are duplications, and some others are point mutations. Now, a lot of work on these 79 exon gene went through before therapies were looked at. And here is a slide that shows, the top panel shows you the dystrophin gene with its 79 exons. The middle panel shows you that there is a deletion. But I want you to focus on the ends here, where my arrowhead is, the end here, and the end here. They are both fitting. So it's a large deletion, but the two remaining portions can join. So the reading frame, even though truncated, is still readable. That's called in-frame mutation. And such an in-frame mutation leads to the milder form, the Becker muscular dystrophy. And the lower panel shows you a smaller deletion actually, but if you see the end points, the edges don't match. And therefore, the reading frame gets disturbed, the so-called out-of-frame mutation. So this fact was understood, that an in-frame mutation produces a milder disease and an out-of-frame mutation produces a more severe disease. So attempts were being made to look at how can we correct this. Now, if you look at what are the available therapies at this point in time in Duchenne muscular dystrophy, of course, we must discuss a little bit about corticosteroid. It's not a new therapy, but it's something that's available to most of us. And in a setting of many Asian countries and underdeveloped and developing countries, it is very important to realize infections are around. And when you put somebody on steroids, the weight gain, tuberculosis, and other problems of osteoporosis do come up. Then there are cell-based strategies, transplantation of healthy myoblasts, where the issues are in delivery, rejections, viability, and then gene-based therapies, where you send in functional copy of a DMD gene through an adenovirus vector. And the problems are because gene, the delivery is poor and you need to cut it into mini dystrophin genes. And the viral vector can initiate an immune response and produce problems for you. So the fourth strategy, the exon skipping, is the one that has been utilized maximum. Medicine is already in the market. It's called etiplirsin, which works on a single exon deletion, exon 51. Now, top panel shows you that in the dystrophin gene, 49 is okay, 50 is missing, 51, 52 are okay. So this is a Duchenne DNA with deleted exon 50. Now the mRNA is processed with the out-of-frame mutation, as I told you, the frame shift hypothesis. So 49, 51, 52 produce nothing. So it's a no protein and a severe disease. Now an antisense oligonucleotide covers the 51. So it converts only 50 to a 50-51 deletion in reality. So now 49 comes in contact with 52, which turns itself into an in-frame mutation. And the mRNA is processed where the reading frame is not disturbed. So a truncated functional protein results and the disease becomes milder. So this is the principle of antisense oligonucleotides, that it will mask some exons so that the reading frame can be re-established. So etiplirsin has come in the market for a while, and it's approved by the FDA in September 2016. And it's also available in some countries, though the cost is a factor. It's given as intravenous weekly infusions of 30 mg per kg and 50 mg per kg for 24 weeks. And the outcome measures have been 6-minute walk test and dystrophin in the muscle. Now, since in a lecture like this, we can't discuss them, but just to say that the endpoint is one of the stumbling blocks for many things to know whether the drugs are working or not. Many trials available by now, and even though it works and it's approved and is available, there are some issues that dystrophin expression is inconsistent. It's not a dose-dependent benefit that you see, and the amount of dystrophin increase, whether it clinically improves patients or not, is an issue. And one good point is that the lung function improves. Right. So etiplirsin is in the market, and there's still some issues about how to improvise what is in the etiplirsin. So I think this is one review that I would recommend all of you. Etiplirsin, Drug Design, Development and Therapy by Lim in Drug Development and Therapy 2017. Right. The second drug is ataluren. Ataluren works in patients of Duchenne muscular dystrophy with a nonsense mutation. So this particular drug targets the premature stop codon and has been approved by the European Union for about 5 years from now. The advantage is that it's an oral therapy. And this is how it works. You can see here the normal protein where my arrow mark is. And this is a patient where the premature stop codon has given rise to an incomplete protein. And ataluren has facilitated translation at the premature stop codon, and therefore the gene product has improved. So this works by a different mechanism, facilitates translation of the protein by the process of working on the premature stop codon. Besides these two, there are lots of agents in development, like exon 45 is being worked upon, and very recently, medicines for exon 45 have been approved. Then there are, you can see there at the bottom of the slide, there are so many other agents that are available or are in the making to become available. And the last part of the slide is the stem cell therapy. So let's go to stem cell therapy. And I think everybody is interested because stem cell therapy is around and is being dispensed and dished out to patients. At this point in time, I must say that there is no recommendation for stem cell therapy in Duchenne muscular dystrophy. But what is the principle? In Duchenne, there is a dystrophin deficiency, then sarcolemma breaks during contraction relaxation cycle, then there is a myofiber necrosis and regeneration, then regeneration capacity gets exhausted, and there is fibrosis and fat infiltration. So, objective of therapy in the various stages of DMD, early you restore dystrophin expression, late you generate new muscle, which is beyond gene therapy. Once the muscle is gone, gene therapy is not going to work. So this is where people believe that the stem cell transplantation may work. And what should the stem cells do? They should incorporate their nuclei into the myofiber of the receiver, what is called the gene complementation. Then they should have the capacity to form new functional myofibers by fusion. And thirdly, the capacity to originate a pool of precursor cells which keep on adding to these stem cells. And this is a cartoon which shows the same thing: incorporation, fusion, and the pool. At this point in time, I don't think there is any stem cell experiment that has really succeeded that much. And I would just allude to a local experiment that we did in the city of Mumbai, where we took out mesenchymal stem cells from fat cells in the stomach, adipose-derived stem cells. And by moving them through 3 passages, we could actually create these cells that were myoblasts converted into dystrophin-expressing fibers. As you can see here, the green and the blue are the dystrophin-expressing. However, once you put them into the body rejects them. So we can create myoblasts that produce dystrophin in the lab. If we create in Bombay, we create them anywhere in the world, but body doesn't take them. So at this point in time, there are crucial challenges that remain in the therapeutic application of stem cell transplantation. Gene complementation method need to be refined for them to be effective. And in late cases, strategies to form new myofibers need to become more effective than what they are now. So at this point in time, stem cell therapy is a dream. It has not yet become a reality. And I think at this point in it is something that you wonder about, but you do not actually prescribe. Then we go to, from Duchenne muscular dystrophy, we'll go to spinal muscular atrophy. And spinal muscular atrophy is an autosomal recessive disease where young children are affected severely with weakness and areflexia and respiratory difficulty, chewing, swallowing difficulty, and they gradually sort of go down and perish. The SMN gene, 85% of all SMAs are due to the SMN gene, and you've got SMN1 and 2. And splicing leads to the protein product, and exon 7 is deleted in these patients, and it's usually in the SMN1. So depending on how many copies of SMN2 are available, delivery of SMN can be produced. So it is again an antisense oligonucleotide which modifies splicing of the SMN2 gene, and the medicine is called nusinersen. There are 2 other medicines available after nusinersen, and it's an intrathecal therapy, and it does improve various functions in children. Ventilator dependence, gastric feedings, then things become improved. Adverse effects are respiratory infection and changes on the blood. So nusinersen is another medicine which has really come as a boon to patients with spinal muscular atrophy. The problem with atalurin, nusinersen, and the etiplirsen is the cost. They're so expensive that they really cannot be used by the masses. Then just to remind you that there is myozyme for Pompe's disease, myotonic disease, mexiletine, acetazolamide, pyridostigmine, lots of other drugs. Facioscapulohumeral muscular dystrophy, some drugs in the pipeline. Congenital myasthenic syndromes, a lot of drugs. And this slide shows you the various drugs available, pyridostigmine and ephedrine and salbutamol and quinidine and fluoxetine. You just have to use them carefully. And then there are metabolic myopathies like Cory's disease, McArdle disease, carnitine palmitoyl acetyltransferase, and lipid metabolism problems, where you have some options available for each one of them. For the want of time in this lecture, I cannot go through the details of them. And lastly, we come to the mitochondrial myopathies. And we usually give these mitochondrial cocktails, and patients do improve, though the evidence is limited. These are the drugs you can use in mitochondrial myopathy. So GNE myopathy is another myopathy that is common in India, where the sialic acid is at fault and is being looked at as a method to improvise patients. Though experimental animals have become better, patients have actually not gotten better. But that's some hope. So I think in this short lecture, I've taken you through two important diseases, Duchenne muscular dystrophy and spinal muscular atrophy, and told you about the antisense oligonucleotides, which have really changed the outlook of those in whom we can use them. And then I've taken you through some of the other conditions where therapies are developing. And I think I'm closing now, 3 minutes or 4 minutes in advance. Thank you very much for your attention. And I'm keeping this 3-4 minutes for questions if the chairpersons will kindly allow, because I have to go for another assignment which I couldn't avoid. Thank you very much again, and congratulations on this meeting.
Thank you, Dr. Khadilkar, for such excellent lecture. At least we are aware of recent advances in the management of neuromuscular disorders. Thanks a lot.
Thank you.
The next speaker is Dr. Yadav. And may I invite Dr. Yadav for his talk?
Yes, ma'am, I'm there.
Yeah, welcome, Dr. Yadav.
Thank you. Thank you so
I would
much,
like to
ma'am.
have the introductory slide for the speaker. May I have the introduction of the speaker on the screen?
Bhavesh, can you put the introduction of Dr. Shivlal Yadav? If you don't have slide, I will introduce. Professor Yadav is professor and head Department of Physical Medical Rehabilitation at All India Institute of Medical Sciences. He has been very closely associated with IFNR and has been a very close friend of myself. He has been working on various aspects, and today he's been here as part of the faculty. So may I request Professor Yadav to please speak on the managing chronic fatigue.
Thank you, Dr. Nirma Surya, for inviting me and for your kind words. Am I audible?
Yes,
yes, you are.
Okay. How I can share my slides, share my screen?
Yes, share your screen.
I put the share the screen, then what I'm supposed to do now? Can somebody tell me like how
Once
to go
you
about?
share the screen, keep your PPT open just from your computer, share that presentation.
Okay. PPT had opened and I have to go to it. Okay. I think it was coming.
Click on the share the screen first. Yeah, there you are.
Can you see my slides now?
No.
It says just stop sharing. I don't know why.
Reshare it, please.
It comes, then it goes off again.
Oh.
Is it there now?
No.
Yeah, you are sharing the screen, but which screen?
No,
you
we are
sharing?
seeing your Zoom screen, sir. Actually, you double click your PPT once you.
Okay.
After clicking the share button, please double click the PPT.
Oh, sure, sure. Okay, I'll do that. That is there. It comes and it goes off. I don't know what is the reason for this.
What you can do, Dr. Yadav, is you email me your presentation. I will share it from my side. Meanwhile, we can go on to the Dr. Kushtuma's lecture, which is a recorded lecture. So you
Okay,
send me
please.
your email. I will be able to share it from.
Oh, okay, right. Thank you.
So is there anybody from Bhavesh team is here? I don't see they are responding at all.
Mansi is there.
Mansi, can you start the Kushtuma's presentation?
Yeah. Then the next lecture is on predicting the outcome in neurological disorders using electrophysiological studies by Dr. Mansukhani from the Department of Clinical Neurophysiology. She has special interest in electromyelography. She is affiliated to the Bombay Hospital and KM Hospital. So can we have the lecture, please?
You see?
I must convey that it is indeed a great honor to be a part of this prestigious meeting, and I take this opportunity to thank Dr. Nirmal Surya and his team for making me a part of AOCNR. Rehabilitation is the mainstay for therapy in neuromuscular disorders. Let me begin with a short introduction of electrophysiological studies. It is basically diagnostic medicine for neuromuscular disease, and it's a combination of tests that assess the function of the nervous tissue being examined. What is important here to remember is that it is to be treated as an extension and not a replacement of the clinical exam. Its main utility is in localizing the site of the lesion, the extent, its pathophysiology, how severe is the lesion. Sometimes it helps with the prognosis, and it's useful for detecting early reinnervation following trauma. So basically, it consists of a series of tests that are done sequentially, but they are analyzed collectively by a physician trained in electrodiagnostic medicine, and they are always reported correlating with clinical features. So electrodiagnosis or electrophysiological studies have multiple names. They are called nerve conduction and electromyography studies, electroneuromyography, which is a preferred terminology, electroneurodiagnosis, or sometimes just electrodiagnosis. Here I shall be using the short form EDX. So how do we measure outcomes in a diagnostic field? A patient would measure outcome by his symptom resolution following any method of treatment, whereas an electrodiagnostician perceives outcomes as an accurate diagnosis because that would then lead to adequate treatment. There is a paper by AANEM which gives guidelines on how to study outcomes in electrodiagnostic medicine with reference to physiological, financial, functional, and perceptual outcomes. What I am going to do today is I am using a case-based presentation using commonly encountered cases in our electrodiagnostic lab to help understand how exactly electrodiagnosis helps in predicting outcomes. Beginning with the first
Hi, there you are. Acha, Kiranagar. Okay. Okay. So far, so good. Yeah. Yeah, yeah. 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 ID. What's happening?
paresthesia. The referral for her study was, is this carpal tunnel or is there an underlying radiculopathy? Since two earlier nerve conduction studies had been reported normal. Her electrodiagnostic study report shows that routine studies for carpal tunnel syndrome and cervical radiculopathy are normal. However, since she has positive symptoms of paresthesia, the sensitive comparative tests were done which were abnormal on that side, consistent with carpal tunnel and minimal nerve involvement. And you can see here, I'm sorry, this is not right, this is left. You can see here that there is slowing in the median nerve fibers as compared to the ulnar nerve fibers when recording an orthodromic sensory nerve action potential from the ring finger, which has dual innervation. So how has this helped us? First of all, the diagnosis was established. Second, there is an early involvement of the nerve, which has prognostic and treatment implications. Let's look at case 4. Here is a 62-year-old gentleman who developed an insidious onset painless right foot drop over 3 months. He was on treatment for many years for episodes of back pain, but he never complained of paresthesia. The MRI showed a disc bulge at the level of the L5 nerve root on the right side, and the reason for reference was the orthopedic surgeon wanted to know whether there was any radiculopathy on the right side at L5 level. This picture is just to show that in all patients with foot drop, we stimulate at the knee and record from the tibialis anterior muscle because that is very important in a case of foot drop, as it gives us the amplitude from the tibialis anterior muscle. And you can see in this patient when we are stimulating that there is no dorsiflexion, there's only plantar flexion because the response is traveling by volume conduction to the tibial nerve. Now, what are the report that we got in him? We found that there was widespread denervation, not only affecting the lumbar but also the cervical and thoracic segments, placing this lesion at the anterior horn cell level and hence much more than a radiculopathy. A motor unit number estimation was done from the ADM and TA muscles for recording for comparison later on. And this is a trace showing the Munichs, which is the technique we have used for recording the number of motor units. So what is the outcome implication here? One, we have diagnosed MND. That has a very grave prognosis for the patient. It's not a good outcome for the patient, but looking at it from the diagnostic point of view, a lumbar surgery has been avoided, patient has been adequately counseled, follow-up is possible with Munichs when the patient is being placed on some kind of treatment. Looking at outcomes for radiculopathies, there are two papers here, both of which suggest that a positive electrodiagnostic test is a better indicator for long-term pain relief to both conservative epidural nerve blocks and post-operative outcomes for patients, which means that if you have a positive EDX test, the outcome to treatment is much better. Let's look at case 5. This is a 21-year-old gentleman who was involved in a motorcycle accident. He had polytrauma, and along with that he had a complete right brachial plexopathy. You can see he has stuck the right hand into his pocket to prevent it from moving around like a flail arm. Now the part of the role of the electrodiagnostician here is to localize the site of the lesion along the plexus and to assess the severity of the lesion. So what we found was that he had complete right brachial plexopathy affecting C5 to T1 fibers with a mixture of pre and post ganglionic levels. We also studied the fibers of the right spinal accessory nerve, which showed normal function. It's important to remember that complete refers to function and not anatomical discontinuity, and C5 fibers do not have a representative sensory nerve action potential. Hence, it's not always possible to place the lesion at pre or post ganglionic levels. So how do the outcomes help us? First of all, we have a diagnosis of the site and the type of the lesion, which allows the surgeon to plan his procedures. The patient can be counseled regarding prognosis, in which case he is not going to get good distal hand function and he will have to undergo multiple surgeries. The spinal accessory nerve shows normal function, hence it could be used as a donor. It gives an indication to the surgeon. And because we have a pre-op study, a post-operative follow-up is possible to assess recovery. The caveat is the study must be done at an appropriate time. In the case of a brachial plexopathy, we should wait for around 3 weeks because that's the time it takes for the nerve to degenerate. And if studies are done before that, you may assess the severity, but you may not be able to assess the site of the lesion. So adequate time must be followed. There are multiple studies done, all using electrodiagnosis in making operative decisions for both adult and birth brachial plexopathies. Robinson et al. Have used the electrodiagnostic parameters to judge what reflects as good prognosis and what reflects as poor prognosis, and he has these 5 criteria which can be very useful when you are studying nerves with trauma. Let's look at case 6. This is a 26-year-old gentleman. He traveled to a hill station and he developed a right facial weakness. This recovered partially on oral steroids. And then he was sent for an electrodiagnostic assessment of a Bell's palsy. This picture is just showing how we stimulate the nerve to record the motor response from the orbicularis oculi muscle. His report showed that the lesion was partial. It was axon degenerative type of lesion, and there was already ongoing reinnervation, but with synkinesis. Synkinesis just implies that every time he closes his eyes, we are able to pick up motor unit potentials from the orbicularis oris muscle, suggesting the fibers meant for the oculi have now innervated the oris. So the outcomes here would be that he has a mild axon loss, so he doesn't require any immediate surgical intervention, but he will have some synkinesis which may require treatment with botulinum toxin. As time progresses, he should be aware of this phenomenon. Case 7. This is a 36-year-old gentleman who had an episode of upper respiratory tract infection, and 12 days later he developed paresthesia in both feet and hands simultaneously. He had mild difficulty in getting out of bed, which progressed. He was unable to balance, and then on day 5 was admitted with significant weakness and absent reflexes. The referral was for a Guillain-Barré syndrome. You can see here there is marked temporal dispersion, there is slowing of conduction, the duration is increased, and we find that these findings of multifocal demyelination are compatible with an AIDP, taking history into account. Point to note is that the distal CMAP amplitudes, that's the motor amplitudes, are diffusely attenuated, and hence we would suggest a follow-up study to assess axon loss, if any, because that would help to determine the prognosis for recovery. So let's see how the outcomes are judged here by electrodiagnosis. First of all, electrodiagnosis forms an integral part of diagnosis and prognosis in GBS. Multiple criteria have been formulated to detect demyelination. And important part is you must know how is it possible to miss the diagnosis. If it's very early GBS, less than 5 days, you could have normal findings and maybe you need to see more nerves, or you have to look for subtle mild findings. If there are atypical variants, those must be kept in mind. If you do restricted testing, you will again miss the diagnosis. History is required to differentiate acute CIDP from AIDP, history and clinical features, and reverse conduction failure may add to the confusion if only one study is performed, so you might need to follow up. As far as prognosis in GBS goes, a poorer outcome is depicted by a low mean compound muscle action potential amplitude. Let's look at case 8. He's a 55-year-old gentleman. He noticed mild numbness in his feet 3 months back, and over the next 2 months he developed weakness in the feet, unsteadiness. He noticed numbness in the fingertips and started dropping objects from his hand, and he was sent to assess for a peripheral neuropathy. Now, as you look at the traces, you can see that there is a change in the configuration at stimulating at the elbow, and there is a conduction block when you stimulate in the neck region. Similarly, there were conduction blocks in the nerves of the lower limbs. We found that this was again a multifocal motor more than sensory, predominantly demyelinating peripheral neuropathy. But taking the history into consideration, it's likely to be a chronic inflammatory demyelinating polyradicular neuropathy. So the outcomes here, diagnosis related. Electrodiagnosis is included as a criteria for the diagnosis of CIDP. There are multiple criteria. Diagnosis may be missed if there's mild demyelination or atypical presentation, or criteria are not applied, or the study is inadequate. You may diagnose it if you examine a patient who has a severe axon loss, or patients who have mimics where clinical criteria are not applied, especially inherited neuropathies. As far as treatment related go, the utility of electrodiagnosis is restricted because though you may get very low distal amplitudes, it is not a contraindication to giving treatment. And Dick and al. Found that there is an ongoing need for diagnostic and therapeutic biomarkers. So there is no nerve conduction prognostic predictors for treatment in CIDP. However, they have found that patients who have more than 4 new demyelinating features are more likely to get a relapse after ceasing of treatment. In laryngeal dystonia, quantification of the EMG signal is very useful to predict favorable voice outcomes. This is a paper by Nandedkar et al. Which has defined it very nicely. So the take-home points are, electrodiagnosis has a positive impact on patient health. It changed the clinical diagnosis in 52% of patients examined in this study in muscle and nerve in 2018. It altered the management in 63%. The caveat are that the study should be done adequately and there must be clinical correlation. So I hope that I have been able to convey a bird's eye view of electrodiagnosis in neuromuscular disorders and its utility in predicting outcomes. If you have any further queries, I suggest you remember your friendly neighborhood electrophysiologist. I thank you for your attention.
Okay, thank
So
you.
if
So,
you allow me to share,
yes, sir.
I will share Professor Yadav's presentation, please.
Hello, everybody.
Professor Yadav, there you are.
Yes. Thank you,
I'm
Dr.
your
Nirmal.
driver now. You can tell me. I will move that forward.
This can't be done by myself, right?
No.
All right. Thank you very much. So, thank you, Dr. Nirmal, for helping me out and giving me this opportunity to make the presentation on managing chronic fatigue. So, whenever any patient walks into our clinic and he says, "Doctor, I'm feeling so tired," you must not ignore this, because if it was a casual, those words would have never been a cheap complaint. So that way, it's very important to understand that what patient is talking to you while he's just entering to your OPD. In any medical setup, like where neurologists or rehab physicians are there, they come across with many neurological disorder and neuromuscular weakness, and chronic fatigue is generally seen in this population, this subset of a population. And during next 20 minutes, I'm going to talk about like what fatigue is and what is the prevalence of it, like what are the causes, what are the diagnostic criteria, and what are the approaches, treatment approaches for pharmacological and the non-pharmacological in treating the chronic fatigue. So there is no definition exists, exact definition exists for chronic fatigue. It is just a perception which is subjective in nature. So for clinical use, fatigue is best defined as a difficulty in initiation or in sustaining voluntary activities. And it may be acute fatigue when it's lasting between 1 and 6 months, and chronic fatigue when it is lasting over the 6 months. Next, please. As I've said previously, the chronic fatigue is a typical symptom of a neurological disease, and chronic fatigue is reported more than 20% of people seen in primary care setup. And this is two types. One is central and the peripheral. Next slide, please. Peripheral fatigue is mainly involving muscle and the neuromuscular junction. Like if it is at the neuromuscular junction, then like in various myasthenic syndromes, if it is muscle involvement, then it is like a metabolic myopathy. Next, please. On the other hand, the central fatigue, it could be idiopathic, which is commonly known as chronic fatigue syndrome or myalgic encephalomyelitis. And this could be contributed with other disorders such as cerebral vasculitis, various channelopathies, developmental disorders, dysautonomic states, granulomatous disorders. Next, please. Other conditions like hypothalamic and pituitary disease, intracranial infections, post-Guillain-Barré syndromes, post-infective fatigue states such as poliomyelitis, Lyme disease, Q fever, etc. Next, please. The chronic fatigue syndrome, it is a different entity which is characterized by intense permanent fatigue of unknown cause, and it limits the patient's functional capacity, producing various degrees of disability. These are the diagnostic criteria. At least there should be presence of 3 symptoms for more than 6 months, which is having the intensity moderate to severe at least 50% of the time. The 3 main symptoms include fatigue, which is a noticeable decrease or impairment in patient's ability to engage in various activities. The post-exertion malaise, patient experience worsening symptoms and functions after exposure to physical cognitive stress. And third one is the unfreshening sleep. Patient feel that they are tired after the night sleep. Along with these criteria, one additional below mentioned symptom is also very important while we diagnose the chronic fatigue syndrome, which is cognitive impairment and the orthostatic intolerance. Next, please. It could be attributed because of genetic reasons, could be because of the various infections, previous trauma could precipitate the CFS, and systemic inflammation and mitochondrial abnormality could also lead to the chronic fatigue syndrome. Next, please. Other causes are like hypothalamic pituitary adrenal axis dysfunction, neuroendocrine dysregulation, central neuron sensitization, sleep dysfunction, autonomic dysfunction, and alteration in serotonin transmission could also lead to the chronic fatigue syndrome because of the various diseases. Next, please. Now we come to the approach, like how we are going to diagnose about the chronic fatigue in general. The history and examination part is very important, where they need look at the any motor weakness or abnormal neurological sign. It could be one or it could be both. Then if these are presented, if it is there, next please. This could be either increased muscle tone, exaggerated reflex, cognitive impairment. In the other hand, if it is there, then early neurological evaluation is indicated, might contribute to other diseases like multiple sclerosis, cerebrovascular disease, Parkinson's, motor neuron disease, etc. If there is a weakness or low tone or poor reflexes, then one need to go for these blood studies. And after doing all these blood investigations, if there is abnormal results, then one has to take appropriate action accordingly. If there is a normal result, then one need to consider for assessment of electrophysiology. And at the same time, if with high creatine kinase, with or without high creatine kinase, then one need to consider muscle biopsy or forearm ischemic exercise test. And at the same time, with the neurologist referral. Next, please. If you don't get all these, either sizable weakness or the neurological deficit, so there could be the history of weakness or episodes of fatigue. In that case, if weakness is there, then one need to consider for electrolyte disorders, hypoglycemia, neuromuscular junction disorders, etc. If there is a fatigue, then one also need to look into the orthostatic intolerance, hyperventilation, anxiety, depression. And for these, to know about these things, one need to go for the screening assessment by performing certain blood tests, electrophysiological investigations, and blood pressure in both the supine and the prone position, the sitting and the standing position. Review the results and check the history, and then one need to monitor the progress. Next, please. There are 3 key steps in evaluation for the fatigue syndrome. One need to rule out prior any organic diseases there in existence. One need to treat the comorbid condition, and also, so there is a only thing that we need to understand is that CF is only diagnosed based on the consensus criteria. There is no specific test available for the chronic fatigue syndrome. Next, please. The treatment option for peripheral fatigue is a specific treatment, and for central fatigue, there is a non-pharmacological and pharmacological treatment options, which we'll discuss later on. Next, please. Dr. Nirmal, next. These are the examples of peripheral fatigue where like autoimmune myasthenia gravis, which could generalize the symptomatic treatment like anticholinesterase, definitive is thymectomy, and there is a drug management is also there like immunosuppressants. In other diseases like Lambert-Eaton myasthenic syndrome, the symptomatic treatment has to be given according to the deficits. In polymyositis, muscular dystrophy, metabolic myopathy, mitochondrial disorders, supportive and the enzyme therapy can be given. Next, please. Wherein in central fatigue, one need the plan should to improve the symptoms, function, and quality of life. There has to do some preventive measures for worsening of the symptoms. One need to help patient cope up with the emotional impact and grief resulting from the development of a complex, debilitating illness. There is also need for prevention of the development of depression and potential suicidal tendency by managing physical and psychological symptoms. Next, please. So in non-pharmacological management, there is an energy conservation exercise program. There is a graded exercise therapy. There are two schools of thought that they said that they improved, but other studies say that it's a contraindicated and can be harmful in these patients. Whereas another study with the multidisciplinary intervention which combined group with cognitive behavioral therapy and the graded exercise therapy with pharmacological treatment, there were 3 groups. At 12 months after the completion, they found that GAT was slightly inferior to usual medical care alone, had not improved fatigue or health-related quality of life, and resulted in worsening of the physical function and bodily pain scores. The other non-pharmacological intervention activities and the pacing. Pacing is the most effective and safe and acceptable and preferred form of the activity management, which can be the group of like walking and taking break or the rest in between the activities. And at the same time, if there is any task that need to be broken into the multiple steps. Next, please. Then next, sleep hygiene is very important because sleep wake routine has to be logged, and one need to tell or advise about avoid watching TV or computer devices before going to the bed at least 1 hour before. There has to be use of the blue light blocking glasses and intake of caffeine containing beverages to be reduced down. One need to advise for meditate, relax and wind down before the bedtime, going to the bedtime, and also to put in the blackout curtains to have the enough darkness in the room so that the melatonin could be secreted and the good sleep could be induced. Next, please. There is a controversy again for cognitive behavioral therapy. Earlier in 90s and 2000, they says the CBT has shown quite good benefits in the CFS, but most recent CBT trials have failed to show consistent benefits in patients with chronic fatigue syndrome. Whereas the adolescent with chronic fatigue syndrome who received internet-based CBT reported improvement in fatigue, physical function, and school attendance as well. Next, please. The another trial, PACE trial, which is pacing, graded activity, and cognitive behavioral therapy evaluation, which were done over the period of 5 years from year 2005 to 10. And they found that both CPT and the GAT, when given appropriately as supplements by specialist medical care, are more effective in improving both fatigue and physical functioning in people with chronic fatigue syndrome. But it was later criticized because of the design flaws in this study. So exercises in another part for the management, non-pharmacological management of the chronic fatigue. that found that it is the evidence rate was 1. Later on, NICE guidelines says that it is not longer recommended, and this has to be tailor-made because one size never fits to all for managing the symptoms in the chronic fatigue. Next, please. Then we come to the pharmacological management. A systemic review of pharmacological management identified 20 odd therapies from 26 studies, whereas in 2020, a systemic review showed 8 interventions with statistical significance. Next, please. Among the pharmacological management, dextroamphetamine, which induces the release of dopamine and noradrenaline, is found to be effective in a small randomized controlled trial, but they said the larger trials are required before they comment on the benefit of the dextroamphetamine. The another molecule, nefajodone, which is selective serotonin reuptake inhibitor, found to be helping to improve mood, improving fatigue and the sleep disturbances. Next, please. The next, others are like antidepressant, both selective serotonin reuptake inhibitor, such as duloxetine, other drug like mirtazapine, they find beneficial both in the fatigue and the global clinical impression in the group who have been receiving CBT and followed by the mirtazapine. Another molecule is valganciclovir. This is an antiviral which help to improve the self-rated improvement in physical and cognitive functioning for chronic fatigue patient who had positive HHV6 and EBV serologies. Another molecule is the monoclonal antibody rituximab that was in one open label study found that helped to symptom elevation and improved quality of life in chronic fatigue patients. Next, please. Others are like interferon. There is no clear evidence. The hormones therapy, inconclusive results. The staphylococcal toxoid vaccine found in patients with the fibromyalgia or chronic fatigue syndrome causes a serological response to several staphylococcal antigens, particularly certain extracellular toxins and the enzyme which is related to the clinical outcome of the treatment. The dietary intervention like mitochondrial protective diets like calorie restrictions, fasting diets and ketogenic diet which is high fat and low carb reported to be beneficial in such patients. And the fasting result in metabolic switch to ketosis result in production of ketones such as beta hydroxybutyrate which can also upgrade the expression of brain derived neurotropic factor and thereby promote mitochondrial biogenesis and synaptic plasticity and cellular stress resistance. So how does it help into the managing the chronic fatigue? Next, please. Well, the others are like probiotic intervention. They help to reduce down the cytokine levels. Lactobacillus casei strain found in CFS patient over 8 weeks reduce anxiety scores. Another evidence that shows that usefulness of probiotics in CFS and fibromyalgia syndromes patients is limited. So there are controversy. There's some studies say it is beneficial and their evidence are there. Others say that it is have limited use into the chronic fatigue syndrome. Next, please. The other therapy used is recently like fecal microbiota transplantation. The gut-brain axis is postulated in the pathophysiology of many psychiatric disorders with that evidence that leaky gut may be linked with the chronic fatigue syndrome may act as a possible treatment option. With that, they had shown that 70% response rate had been reported with benefit maintained for 15 to 20 years in uncontrolled, but the study design was not very robust. Next, please. Then other things are available like complementary and the alternative medicines, nutraceuticals like acetyl carnitine, which facilitate movement of acetyl coenzyme A into the mitochondria by providing antioxidant, neuromodulatory, and neuroprotective effects, may benefit both cognitive status and physical function. And the same way, the essential fatty acids may be a risk factor for poor cardiovascular health and pro-inflammatory status in CFS could be complemented by the prescription of essential fatty acids, supplement of the essential fatty acids. Another is like use of magnesium, vitamin B12, which is high dose along with the folic acid may be safe and effective for the fatigue or also for the chronic fatigue syndrome symptoms. Next, please. Antioxidants, there is good group of vitamins and minerals that help to protect the cell from oxidative stress damage and improve mitochondrial function. And with these, one study found that symptoms of the chronic fatigue syndrome and quality of life improved by prescribing these multivitamins and minerals as a supplement. Then coenzyme Q plus and nicotinamide adenine dinucleotide hydrogen is linked to produce the CFS. So prescription with these increase the cellular ATP production by mitochondrial oxidase phosphorylation. Their supplementation could help improve fatigue and other symptoms in chronic fatigue syndrome. So I conclude that chronic fatigue substantially impairs the quality of life of a person. Hence, effective rehabilitative approaches are essential to minimize the disability. And currently, the management for chronic fatigue is mainly symptomatic and rehabilitative, and some cases, including specific medication, is needed. Thank you very much. Thank you for your kind attention.
Shita Lakshmi, kindly conclude because we don't have much time. If you have some comments, please say.
Thank you, sir. Thank you for this very interesting lecture. So today we had a very interesting neuromuscular symposium where we had understood about GB syndrome, the newer issues, and especially Dr. Kadikal's talk on newer therapies in the neuromuscular disorders to the electrophysiology in neuromuscular disorders and also management of chronic fatigue syndrome from very excellent lectures. Do you have any questions from the audience?
No. No, we don't have.
No, don't have. Okay. So I want to ask Shivalal Yadav sir only that means how do we apply this diagnosis of chronic fatigue syndrome in our busy OPD practice, sir? Most of the time we think they are having depression and possibly we treat.
Yeah, I think for that way, it's a very new term for me also, because it's very difficult to diagnose because it's only history, which is very important, until we ruled out other causes, probably we cannot label that the patient is suffering from chronic fatigue.
So what is your basic evaluation, at least for us as practitioners, not to miss out it?
No, if somebody is complaining that they feel always, there is a fatigue, and if you had probably ruled out every disease, which probably could lead to, by investigative procedures or after advising the investigation, if he doesn't come across with any, test positive, then probably we could label it as the, but again, there is a overlapping, the stress could also lead to the, the chronic fatigue. And sometimes, disappointment and the other, anger and other causes or lack of sleep, they are also contributing to the chronic fatigue syndrome, So that way it is a very misnomer and it's difficult to diagnose sometimes and it's difficult to understand also.
Yes, sir.
That's the limitation with chronic fatigue.
Agrees. Yeah. Most of the time we diagnose as depression and then give them some antidepressants or fluoxetine and somehow they may get better. Yeah.
Yeah, they do respond very well. Yeah.
Yes, sir. Thank you, sir. So I think we just crossed 3:30 and we thank all the speakers for the wonderful lectures. And myself and Dr. Bhavana thank Dr. Nirmal Surya sir for giving this opportunity. Thank you, sir. Thank you, and we
Thank
close
you.
the session.
Thank
Thank you very much. Yeah, over to Sonal.
Thank you so much, sir. Thank you so much,
Thank you,
ma'am.
Sita. Thanks
I
for coming and
thank
be part of us. Thank you so much.
Thank you, sir.
on behalf of AOCNR, we thank you all. Thanks for joining us today.
Thank you.
So we have next exciting session on IT and neuro rehabilitation. So please stay connected with us, and we will be starting at 4. Thank you so much.
Battery 90%. Connected to JoyKeys MacBook Air and Joy C iPad Mini 4.
Good afternoon, Prabhat sir.
Good afternoon.
How are you?
I'm fine, thank you. I just tested my.
Nice to see you here. Thank you. We have a session at 4. You want to check your slides and your talk?
Yeah, I was just going to check that. Yeah, thank you.
Yes, sir. You can do that. Bhavesh sir, can you please send me the CVs in the order so that next 2 sessions we don't have any glitches?
Is the slide changing?
Yes, sir. It's going smooth.
Okay,
Disclaimer. Yes.
Thank you.
So by 4:10, I think your talk is at 4:15. Yes.
Yeah, 4:20 something. Yeah.
4 sharp, we will be starting a session, sir.
Okay, sure. Thank you.
So it's working well.
Yeah, switch off my.
Bhavesh sir, can you just put the session details slide and we can join back at 4 only. Mansi? Professor Kurana, hi. Thanks.
Anji, hi. How are you doing?
Hi, sir. Good afternoon.
Good afternoon. How are you? All
I'm
good?
good, sir. Thank you. Just a minute.
You're welcome. We're starting at 4.
Yes, Dheeraj.
Hi, sir. कैसे हैं?
बस busy.
आज वो इंडिया और समर स्कूल भी चल रहा था, स्ट्रोक समर स्कूल. मेरा सुबह हो गया. मेरा पहला.
I gave a talk yesterday.
Yeah, I saw that. I couldn't attend yesterday. But आज मैंने सुबह पहला ही था मेरा काम खत्म. Session was good in the morning. सारा वो thrombolysis भी था. How do I do it?
I hope Biplab is supposed to join.
Biplab वो ना, he called me up. He has a case coiling कर रहा था, एक SH का patient आया था कह रहा था. So he may come in and go. That's what he said.
So we still have 8 minutes to start. So you are there as chair. Dr. Biplab is as co-chair.
Yes, sure.
Good afternoon, Dr. Nirmal Surya, and good afternoon, Dr. Kurana.
Good afternoon.
How are you, Pranjan?
I am fine, thank you.
Great to see you again.
Thanks so much.
I'll just join in 5 minutes.
Mansi, can we have slides? It's just 5 minutes we have. Another co-chair slide next, Dr. Kurana. Next slide. And the third and fourth. It's wrong slide, Mansi. Can you please check it?
Hi, Dr. Surya, sir. Hi, ma'am. Hi, sir.
Hello, Shavik. Good evening.
Ma'am. Yeah.
Good afternoon, Savik. This is Professor Prabhat Ranjan.
Yes, hi, sir. So I believe we met at IFNR Con last time.
Right. No, unless it's a physical meeting, we don't have that memory of online meetings are not as last thing.
Yes, sir.
Yeah, it's 4 p.m.
Yes, ma'am. May I start?
No, wait.
Okay.
Please.
I think 2 speakers haven't joined.
First speaker is there with us. Co-chair is not there. So maybe, sir, we can start now. Mansi, could I please request
So
you
we
to
can start
flash the
because
slide of session?
Biplab may not be joining because of his.
Okay, sir.
He's tied up with a case.
We can still just introduce and thank him. Mansi, can you please flash the slide? Good evening, all. Here we go with the evening session, symposium on IT and neurorehabilitation and the artificial intelligence. We have very exciting young talent in Indian scenario, how Professor Ranjan, Mr. Shavik and Dr. Lakshmi Narasimhan sir and Akshay Sancheti, who will be enlightening us regarding the current scenario on teleneurology, teleneurorehabilitation AI. So I welcome all the delegates, all the faculty. We have esteemed chair, Dr. Khurana with us. Could I have a slide, please? Mansi?
Tumawag ako kanina kasi nag-usap na kami ni Sir Winnie.
Professor Khurana, slide,
Napadala niya na
please.
daw eh.
Professor Khurana,
Hindi
slide.
mabuti.
Yes. Welcome, Professor Khurana. Professor Dheeraj Khurana is a well-known stroke neurologist. He is known for his innovative work in teleneurology. He is a IN chair of SIG subsection teleneurology. He is a professor at PGIMR Chandigarh. His area of interest is acute stroke, MS and neurosonology. He has many awards to his credit. We welcome you. May I have Dr. Surya sir with session? So Dr. Khurana can start the session then.
Ma'am, sorry to interrupt. Akshay is there as attendee. He's waiting to join.
Yeah, please, I'll take him inside. Yes.
Sure.
Professor Khurana, sir, welcome to you. You can take the session ahead as a chair and introduce the speaker.
So Dr. Sanjeev will be joining as a panelist now.
May I have slides
sorry,
of speakers?
Yeah. Thank you, Sonal, for the introduction. And thank you, Professor Surya, for inviting me to this session, this interesting session in the AOCNR. We have an exciting row of speakers and very exciting topics of discussion. And as we all know, we've been pushed towards technology during the pandemic time. And whether this is a curse or a blessing in disguise, I think it is more of a blessing, since this is one thing we were missing initially. And since we've started getting acquainted to technology and the wonders of technology, we have to mix it up with our usual ways of practice. And to talk about that, all about technology and AI, artificial intelligence, machine learning, things we were actually just discussing behind the scenes, thinking that would they ever come into clinical or life scenarios, it has already happened. There are areas of neurology where AI is being rapidly used, mainly in the area of imaging. And today, we are going to have some very interesting talks by experts in the area of various technology areas of neurorehabilitation. So with this, I will introduce the first speaker, Dr. Shobik Das. So can I have the slide, please? My co-chair, Dr. Biplab Das, couldn't join. That's a hazards of being a neurointerventionist. A case comes at the last minute as he's in the angio suite. I wish technology could, give a solution to that he could be sitting outside the angio suite and still managing the case. So we look forward to such technologies. So Dr. Shobik Das, he is currently associated with Monastic. He's a project lead, and he's a Intel software innovator and a former Intel student ambassador. He's got multiple patents. The most famous patents are the novel emotional recognition model for the visually impaired, machine learning model for detecting respiratory problems using voice recognition, and a lot of other achievements. Mainly, he's been speaker at the Intel Global Development Fest 19, and he was a runner-up at the Intel SA and Software Innovators, and the finalist at the TCS national level IT quiz. So, Mr. Shobik Das, he's going to be talking today on the future of AI in neurorehabilitation, a topic we are all. Shobik, you can start. Oh, Mr. Shobik, are you there? Yes, you can start your talk.
Sure, sir. A very warm welcome. Thank you for giving me an opportunity to present. Before we begin, let me start with my introduction. Hi, I'm Sobek Das. I'm a computer engineering graduate, and I'm really passionate about technology. I keep thinking how we can leverage technology to solve real life problems. We would be talking about artificial intelligence and some of its applications in healthcare. Then we will move to some of the state of the art current trends and clinical applications of AI in neurorehabilitation. Post that we will be discussing challenges of implementing AI in Indian scenario. And finally, we will conclude where the future of AI in this domain is heading to. uh, Artificial intelligence. When we think of artificial intelligence, we generally tend to think of transformers in sci-fi movies, some of the world's most powerful yet automated bots trying to take each other down, fighting against each other. Uh, all those seem good, but it's all hypothetical. In reality, artificial intelligence is the art of leveraging computers and machines to mimic the decision making and problem solving capabilities of human mind. We know that humans can think, they are intelligent. Sometimes they are a bit too prodigious, while at the same time machines, they do not possess any intellectual capability, they cannot think, but what they can do is they are computationally super efficient. And when we combine both of them together as a team, what we get is the very crux of artificial intelligence. And yeah, we would be getting to the stage of transformers very soon. So AI is more than just a buzzword. There is not a field which has practically not being affected by artificial intelligence. If we start naming, of course, healthcare, travel and logistics, entertainment and gaming, if we even start to list down, all the fields one by one, still we might end up falling short. Be it investors, innovators, scientists, community members, or anyone who may or may not even be directly or indirectly connected to technology. This has in a way certainly AI has certainly changed the way people go about their profession. Artificial intelligence in medical diagnosis is used in medical decision making, management, automation, workflows, administration, and much more. It can be used to diagnose cancer, triage critical findings in medical imaging, flag acute abnormalities, provide radiologists help with prioritizing life-threatening diseases, predict stroke outcomes, and help with the management of chronic diseases. One of the groundbreaking examples is by Harvard Medical School. We know that the diagnosis of a deadly blood disease is hard. AI-powered microscopes can scan and find harmful bacteria faster than humans with close to similar accuracy. AI can assist in structure-based drug discovery by predicting the 3D protein structure because the design is in accordance with the chemical environment of the target protein site, thus helping to predict the effect of a compound on the target even before the synthesis or production of the compound takes place. This can help save lots of funds, potentially billions of dollars, since 9 out of 10 candidate therapies we know fail in either phase 1 regulatory in either regulatory approvals or phase 1 clinical trials. For example, researchers at a biotechnology company, Berg, have modeled a method in which they could detect previously unknown cancer mechanisms using tests on more than 1,000 healthy and cancerous human cells. They modeled diseased human cells by varying the levels of sugar and oxygen the cells were exposed to, and then tracked their lipid, metabolite, enzyme, and protein profiles. The group uses artificial intelligence to generate and analyze immense amounts of biological and patients' data and our outcomes data from patients, thus highlighting the key differences between diseased and healthy cell samples. A study published in Harvard Business Review portrays how Pastelides and their team used electronic health records and machine learning to predict hospitalizations and due to diabetes and heart diseases. Using this method, they could predict hospitalizations about a year in advance with up to 82% accuracy. That is really exceptional. Even today, CMS identifies chronic care management as a critical factor in primary health care. The reason why artificial intelligence, we believe, can revolutionize healthcare is at its fundamental level. AI can detect infinite small changes in standard forms of audio, video, or any other processes, which humans generally, in a way, naturally find it hard to do so. When we look at healthcare with regards to how AI can create an impact on the same, we realize that preventive and personalized healthcare are the two pillars. A team from MIT, designed a deep learning algorithm which could detect and screen early stage melanoma, a type of malignant tumor, which is responsible for more than 70% of the worldwide skin cancer related deaths. This published in Science magazine. The ambition of personalized healthcare is to design and optimize the pathway of diagnosis, therapeutic intervention, and prognosis using large, multidimensional biological data sets that can vary individual variability in genes, function, and the environment. They offer clinicians the opportunity to more carefully tailor early stage interventions, be it treatment or preventive in nature, to each individual patient. AI also has been investors' favorite portfolio since quite some time now, with robot assisted surgery and virtual nursing assistants being the best bet. Cumulative funding is highest for research and development catalysts, along with population health management, and which mostly accounts for drug discovery, among others. Let us walk through some of the technologies used in connection with neurorehabilitation with regards to artificial intelligence. These are a part of how the future looks like. Robotics and kinematics, along with artificial devices, can be used to improve activities such as muscle control and mobility therapeutically. Machine learning is used in speech therapy and in tasks linked with cognition. Virtual and augmented reality is used in ADLs as well as pain and stress management. It can enable users to go to a new place. It doesn't matter if it's virtual or temporary. More than one technology can be used and more than one or the other tasks, which is interesting to keep in mind. The goal is at all times is to improve neurorehabilitation using AI, in which the machine adapts the robotic training strategy to patients' special needs and train motor or other tasks, and thereby improving its strategy over time. That's the very crux of AI, in which the learning agent adapts itself over time and improves itself. Let us see some of the interesting examples of machine learning applied in neurorehabilitation. It is hard to make out some of the subtle changes needed in speech therapy on a patient-to-patient basis. Dr. Julie and team from USA came up with a solution in which adaptive machine learning algorithms were used, which were tailored to a different patients and based on their genes, behavior, social parameters, among others. Machine learning can thus be used to provide patient-centric approach in neurorehabilitation. Stroke patients need proper and timely intervention to improve upon different aspects of their lives. To provide accurate neurorehabilitation, first, the stroke severity needs to be assessed, as we know. Anuradha and team from Sri Lanka came up with a solution in which data from Glasgow scale and electroencephalogram can be combined with reinforcement learning to improve neurorehabilitation. Some of the neurorehabilitation activities are costly and they have to be done in a clinical environment. Dr. Yuri Almeida and team from Portugal came up with a solution in which long-term cognitive neurorehabilitation therapy can be provided at home through remote patient monitoring capabilities. Machine learning can help in providing personalized therapies and solutions for each patient. Let's walk through some of the fascinating examples of robotics and kinematics in neurorehabilitation. We know that the activities and functions associated with hand sensory motor impairments is a challenge. Luca Randazzo and team came up with a solution of wearable robotic exoskeleton in which to some extent the activities can be restored and repaired. To, Devices such as these can be used in sensory motor recovery. Detailed analysis of motor behavior is hard. Ahmed Arak and team found automating 3D kinematics of human movements to identify patterns leads to detailed understanding of motor patterns. As robotics and kinematics can better help in understanding the patterns of whether or not there is improvement during neurorehabilitation, accurate therapies can be given. Machine learning can thus provide accurate therapies and knowing the patterns of degradation or improvement in patients. We know that the neuro rehab of chronic stroke patients is a challenge. Lots of parameters need to be considered again at all times to ensure that this gets done. Ursula Peter from Hungary came up with a solution in which robot-mediated therapy can be given for ADL tasks in the upper limbs of patients. ADL with robot-mediated therapy can improve motor and functional abilities of patients with stroke. Now let's walk through some of the riveting examples of virtual and augmented reality in neurorehabilitation. Some of the dangerous tasks are hard to achieve in neurorehabilitation. Let's say activities such as climbing on stairs is hard for a stroke patient who is barely able to maintain his or her balance. Through virtual reality in which we can move our head in VR headset, there is a way in which we can navigate the virtual environment by moving our head slowly. The patient can move their head and navigate to the environment they like and create a mind map of how to gradually get into the activity. Virtual reality can help in this hard to accomplish tasks. Pain and stress management in patients suffering from neurological disorders can be really challenging. Angela Lee and team from USA came up with Project Heaven, which can help users roam in nature or in any environment they like. The users are free to navigate in the environment they like and prefer. These kinds of tours help extensively in diverting the patient's minds and taking them to a new world, which is completely different from the real world, even if it's temporary. So all in all, technologies revolving around artificial intelligence do help a lot in making neurorehabilitation simple and straightforward. All seems good, but along with the opportunities, challenges present themselves. Electronic health records, while massively useful, especially in the use of AI, need to exist right from the very beginning to create high impact. One of the ways to achieve this is to map each user to unique ID and then keep user and patient records digitally right from the very beginning. Although artificial intelligence can certainly provide groundbreaking solutions, it is hard to provide low-cost, affordable solutions that can be used by all income age groups across the line. Even if the data is there, it needs to be there in regional and local languages to work well. In a country with massive diversity, such as India, this needs to be considered. There are several local languages in India, as we know, and this challenge can be tackled by localization and then moving to globalization and not the other way around. Studies have proved that patients with inadequate literacy receive less preventive care, have more health related problems, have a poorer control of their chronic illnesses, and are hospitalized more frequently than other patients. Literacy seems to show a direct relationship with regards to health decisions that one seems to take in their lifetime. Certain laws and regulations need to be considered when it comes to AI. Privacy and security needs to be maintained at all times at a very high priority. One of the ways to achieve this is to keep the data encrypted, confidential, and private at all times. Medical responses should be monitored efficiently and accurately, abiding by these rules. Coming to the future of how the future in coming to the point of how the future of AI in neurorehabilitation looks like, it is evident that with regards to assisted therapies, there is clearly a good lots of hope. The future in all ways looks bright. Among the initiatives by the government trying to bridge the gap between rural urban areas by developing more equitable healthcare infrastructure between both and converting primary healthcare centers into community healthcare centers are the major ones. As per Analytics India magazine, India government has recently launched Startup India Fund scheme with a corpus of 945 crore rupees, in which qualified startups through eligible incubators would be able to apply in the next 4 years. We are certainly at a time wherein we can witness the power of artificial intelligence unfold before our eyes and drive healthcare forward in a way no other technological revolution could ever come close before. Thank you.
Thank you, Mr. Das, for an exciting journey into the future with AI. And as you rightly mentioned, there are exciting times to come, and AI is bound to take up a lot of role in neurorehabilitation. So we can have the discussion at the end and questions at the end. So now we go to the next talk, and our speaker is Professor Prabhat Ranjan. Can I have the slide, please? So what I understand is Professor Ranjan, a highly accomplished scientist, speaker, and he is the Vice Chancellor of the department.
Can I start? The voice stopped. Your voice broke.
Sonal?
Dr. Krona, should I start?
I wanted to give the full introduction. Just a second.
Yes, sir. Mansi, can we have a slide, please? Mansi? Yes, it's there. Sorry.
Thank you. So Professor Ranjan, he is an alumnus of the IIT KGP, Delhi University, and the University of California at Berkeley, where he completed his PhD. Currently the Vice Chancellor of D.Y. Patil University, Pune, and former head of TIFAC, India's technology think tank. I'm sure everyone's heard of it. And his interests range from highly arcane areas like nuclear fusion, moon mission, wildlife tracking, assistive technology, and the BCI, the brain-computer interface. A highly interesting and a complicated set of interests, I would say. And I will invite Professor Ranjan now to talk on the role of brain-computer interface in neurorehabilitation.
Thank you. Thank you, Dr. Krona. Let me share my screen. So as mentioned, the title of my talk today is Role of Brain-Computer Interface in Neurorehabilitation. Before I start, I would like to put a disclaimer. I'm a scientist with basic background in nuclear fusion. I'm also happy to inform the audience that for the first time in the country, outside one national lab, I have started a nuclear fusion program in country with investment from private investors from Silicon Valley. Nuclear fusion is the toughest challenge of the century, technological challenge. In fact, it was the toughest challenge of the last century. We could not solve it. Now it is the toughest challenge of this century. So I'm happy to be able to inform you that the first time in the country we started this work as a private entity. But to just tell you, I'm not an expert of neuroscience. I'm not a medical doctor, healthcare professionals. So keep that in mind. Of course, this area of work requires a lot of interdisciplinary expertise, and so I bring some expertise from my side. Most of the work that I'm going to be reporting was done from 2008 to 2013, so more than 10 years ago. Started at Dhirubhai Ambani Institute of ICT in Gandhinagar. But when I was heading India's technology think tank in Delhi, I didn't have time to work on these, although I tried to do some amount of that, but it was not at Education Institute, so it was difficult. Now that I'm back to Education Institute, I have started this work in my university again, and I'm happy to collaborate with many of you who are willing in this field. The way I got into this area was that through a student project, we developed a hand gesture-based environment control system to help persons with restricted finger movement. Then as we started to see that we could make change in the quality of life of people, we started to find other users coming forward with different needs. Then we worked out a plan to use any ability, focus on the ability of the person and improve their quality of life with the use of technology. For example, this is a device by which through a gesture you can control things around you, like television, air conditioner, music systems, and so on, computers. You can see a girl using Kajal, another girl, Parvati, using the same device. Both of them have cerebral palsy. We made another device to make it a little easier for those who cannot move around because you need to have remote control pointing towards the device. We made a device which allowed them to control things for up to 4 equipments in the room. You can see Parth using this, Sumit and Rohit in Delhi trying this out, watching cricket match. We also developed touch screen-based apps to provide facility to those who could not, were non-verbal. You see with awards and funds for some of these. So my focus has been on counting the ability and not the disability. Focus on what the person can do rather than what the person cannot do. Based on this, on the left side of this table, what you see is the ability of a person. For example, can the person move a hand or a leg? Can the person move a head? Can the person speak? Or can he capture his eye movements or eye blinks or facial expressions or even conscious thought or muscle movement? And then, of course, touch screen-based technology also came in. The right side, what you see is the different technologies that we used. The green means we have done those things given to users. Yellow means that it was done in the lab, not given to users. And white means it still needs to be done. So my focus of today's talk will be on the BCI part. You see that covers 3 areas: eye movements or eye blink, facial expression, and some cases conscious thoughts as well. These are the green ones. What we do is to take from user the input based on their ability, and then allow them to control various things like light, fan, television, computer, being able to speak, operating wheelchair, and other things like simple electrical machinery and so on. I'll not go into those details. So let me come to this particular area, which we named as Brain CPAL when we started. As you are aware that interpretation of EEG waves is a complex task, and most of the work was done offline by recording waves and doing analysis later. But over the last 10 to 12 years, the development of embedded systems and more powerful processors became possible to carry out real-time analysis of these signals. This combined with wireless communication led to development of neuro headsets, which did not require you to be wired, and you could move around and still you could be monitored. These systems measure the EEG waves and partially process the signal before they transmit it through the wireless communication to the computer for more sophisticated analysis. Initial use of this started to come into games market, and games market being very large, these headsets started to become very cheap. And this made it possible for a person like me to take advantage of these to help persons with disability at a much lower cost and for wider uses. So what happened due to this is that the probing of brain has come out of labs and hospitals into hands of persons like me who are not into the medical labs or hospitals. So for example, you can see some of the examples. These devices started to flood the market. I got hands on, I saw one device in 2010, 2011, I could procure it. But you can see the way it is being used. For example, there's the artistic EEG helmet, which responds to the brain waves in a way that it creates a relaxing loop. Similarly, you can see a 3D printed helmet responds to brain waves in ways that an artist can imagine. It is not for medical intervention by any means. Let me come to my own work on brain-computer interface. It was on July 1st, 2011, 10 years ago, that I first demonstrated that through my use of facial expressions, I can control things like light, fan, and so on. So for example, through my smile or blink of my eyes, I could control things. This was demonstrated. Two of these are my engineers, and one of them is my student. I was demonstrating in my office in Gandhinagar. The first user, after effort, we tried to find users, was a gentleman, Mr. Suresh, who was Ahmedabad MBA. He had a brainstem stroke in 1999 at the age of 32. He lost his hand and leg movement, and he didn't have voice. He can hear and see. So he went into what is referred to the locked-in condition. He could only communicate through blink of his eyes. So on March 13th and 14th of 2012, we provided him with this device, which his wife told me that had changed his life, because he started to use computers, write blogs that he continues to do till today. I don't think I'll be able to show the video properly, so I'll just tell that what we are doing is that we actually capture the head movement, and then that head movement is translated into mouse cursor movement. So left, right movement of head, up, down movement of head leads to cursor movement. And then we give him soft keyboard, and then with blink of eyes, we map it to left mouse click. Using this, he can type on the computer. The first time he started using this on 13th March 2012, about 9 years ago, was to type his wife's name. Then we demonstrated to him how he could control a light bulb using his blink of his eyes. I don't know if you can see this, but there's a light that is glowing, and you can see smile on his face. And then he again puts it off, and then again puts it on. In fact, he bursts into laughter like a child at the end of this. Then we also made a device. We gifted him on his birthday on 6th April 2012, which will allow him to speak through this device. There are other examples that I can't go into details. This is Charu Khandal in June 2012 in Koklaben Hospital in Mumbai. Unfortunately, she is no more. Another gentleman from at Koklaben Hospital, this gentleman at Hyderabad, this boy at Patna, this boy at Mumbai. So many of these users tried it, and some of them use it. Of course, during the last 10 years, we've lost a few of them as well. So the device that we used initially was Emotive, a company called Emotive Epoch, which has 14 electrodes, along with 2-axis gyro sensors to measure head movements. And this was completely wireless. At that time, it cost about $300 to purchase. What we do is to capture three kinds of things. One is facial expressions, other is emotions, and third is certain cognitive conscious thoughts, for which we need to train the device. Up to 4 conscious thoughts we need to train for each individual. Other ones need slight adjustment, but mostly it's generic. It can be recognized much more easily. We also try to use this to see if we can get a person in vegetative state to communicate. Of course, it is not really vegetative state. It is really minimally conscious state, but many times medical professionals misjudge them to be in vegetative state. So we try to see if a person who is identified to be in vegetative state, but actually in the minimal conscious state, can we get them to communicate? We tried with few people. What we tried to do in this case was that we captured that in real time. We captured the 3D activity in the brain, and then link it to. We ask them to imagine certain scenes, and we link those to scenes. If they can imagine those and there's a correlation, then we can link, say, scene 1 and scene 2, yes and no, and allow them to communicate through yes and no. I've not been successful. Now I'm restarting this work. As I said, that I could not do this kind of work in my daily assignment. There are certain limitations of this, and we're trying to solve those. For example, the computer needs to be in the range of wireless range of the headset. Battery has a 12 hours of operation time. There's to be requirement of wet contact. Now, dry contact based systems have also come, but they have less number of electrodes. Based on this, I also started to focus on learning disability. I'll not go into details of these, but we have used brainwave entrainment and neurofeedback to help children with ADHD, ADD, and so on, Down syndromes, and also to adults in other cases like insomnia, depression, and so on. At D.Y. Patil International University, what we are doing right now is to use brain-computer interface to identify multiple intelligence among children and use this to improve their learning process and career choices. And then we are also using this to identify concentration levels and use neuroplasticity to improve ADHD and other conditions to help children learn much better. Work around the globe, as I mentioned, the use of BCI is basically to provide a channel for communication and to make it possible to control environment for persons with severe and multiple physical disabilities. It can be used, I showed you some examples like computer cursors, virtual keyboards, augmentative and alternative access systems, prosthetic devices, wheelchairs, entertainment and gaming purposes. This was something that I mentioned made the neuro headset cheaper, internet browsing, painting, and so on. And it has been used for people with ALS, multiple sclerosis, brainstem, stroke. I give an example. Muscular dystrophy. I had a gentleman in Delhi who is no more, acquired brain injury, cerebral palsy. I have a few examples of that. So many of these conditions, we can use these. Basically, what happens is this, that you acquire the signal, there's a processing of signal being done on the device. And in this process, you actually suppress artifacts, extract features, and classify the signals. And then it's connected to the device interface, depending on what is the application. For example, it could be lighting up a bulb or a wheelchair or a computer. And then sometimes there's a feedback system also that is there to perform certain tasks. And then we can classify BCI into 3 categories: invasive, non-invasive, and hybrid, which is a mix of these two. Mostly what I have done is non-invasive, because invasive, I cannot do it unless I'm partnering with a medical college. In the invasive thing, most of you are aware, so I'm not going into details of these, but there are a few companies that have come into picture. There's a company called BrainGate, which has been around for some time. There's a company which has recently got FDA approval for human trials, Synchron. They have a stent road implant, and Neuralink, Elon Musk's company, is in news, but the other ones have been earlier. The Synchron has got permission more recently. For example, BrainGate, you can see this gentleman in 2017 was able to reach with his paralyzed arm and hand in a clinical trial in 2017. He could grasp a cup of coffee, hold a fork to feed himself, and bring his hand to his face to scratch his nose. These things could be done about 4 years ago. Similarly, as I mentioned, that FDA has cleared Synchron's brain-computer interface device for human trials. This is invasive. Both of these I'm talking about are invasive devices. This device takes around 2 hours to implant using a minimally invasive procedure. The device is implanted through a blood vessel at the bottom of the neck and then maneuvered into the brain. This device could be available within 3 to 5 years for customers to buy and for medical colleges to utilize these. This gentleman, Graham, is the first one who tried this out. He received this device. He suffers from ALS. Another second gentleman, he is also using this to successfully control his computer. So more and more of this example is going to be growing there. I will not go into non-invasive BCI, but that's what I have used. But there are different ways we can use this. And of course, there's hybrid BCI. So I'll stop by talk at this point by saying that both invasive and non-invasive along with hybrid is playing very important role in neurorehabilitation. According to some estimates, they may become more pervasive than pacemakers that we are familiar with. So BCI along with other sensors can provide economic solutions for ASC, environmental control, wheelchair operation, and many other examples that I've showed. Indian researchers should focus on this area, and we should have collaboration with academia and medical systems to make this possible. Thank you so very much for listening to me patiently.
So much, Professor Ranjan, for engrossing and providing insights into what AI is already doing. I would say of the has been made on locked-in butterfly, which the locked-in state of famous personality was the editor of Elle magazine, the French magazine, and I think this can be made into a movie. How Mr. Suresh is working well with.
Right. He writes his blogs regularly for last 8 years.
I think I got cut off. Sorry. So we'll have the discussion at the end, and we go on to the next lecture. This is by Mr. Akshay Sancheti. Can I have his slides, please? His introduction, please. Right. So, Mr. Akshay Sancheti, hello, am I audible? So he's currently works at Quantify Analytics, and he has evaluated the business of machine learning and AI technologies in clients' businesses, conducted qualitative, quantitative research in the domain of machine learning, has worked with data scientists to gather, analyze information, and formulate test hypotheses. He's affiliated with the Bombay Hospital and Medical Research Center, Saifi Hospital, Mumbai, and the Northcote Police Hospital, Nagpur, Mumbai. And he has been the chairman of Surya Neuro Trust, Mumbai, founder, trustee, and chairman. I think this is been,
I'm sorry, this is a wrong CV slide.
I get so, yes. Yeah. The profession, this is Dr. Surya's slide. His experience. Anyways, we'll move on to the lecture of Akshay Sancheti, and he will be working on technology.
Akshay, can I have...
Mr. Akshay.
Can I ask you to introduce yourself, please? I'm sorry for that. And
yeah, sure.
With the talk. Sorry.
No worries. I think I have a slide about me in my presentation. So let me get started with that. Can I present my screen?
Just start sharing your screen now.
Yes, thank you. All right. So hello everyone, and thank you for giving us an opportunity to present. I am Akshay, and I'll be talking about Monastic, which is a platform connecting technology to neuro rehabilitation. Before I begin, let me introduce myself. I am Akshay. I'm a graduate from BITS Pilani, and I'm working with some of the strategy consulting firms with some of the leading strategy consulting firms, and I've extensive experience working in the healthcare domain. I'm also a co-founder at Monastic, and I'm leading and advising the business and marketing team at Monastic. So in today's talk, we will be talking about what is Monastic. I'll be explaining what we do, how we started with it, and I will also be explaining some of our innovative products. And through the lenses of these products, I'll be talking about how we are bridging the gap between technology and neuro rehabilitation. So as Soubik mentioned in his previous talk, there are a lot of challenges in implementing technology in neuro rehabilitation, especially in India. So there can be challenges with respect to medical health records. Then there is affordability. India being a diverse country, it is a boon for us, but it is also a challenge in terms of implementing technology because of availability of data in regional languages to train artificial intelligence models. Then there is a challenge of literacy in a developing country like India. And lastly, there is lack of regulation, law, and privacy concerns in country like India. Through Monastic, which is our platform, we are trying to address some of these challenges and create innovative products which can tackle some of these challenges. So what is Monastic? Monastic is a platform aimed at bridging the gap between neurology and technology. So we engage with neurologists, neuropsychologists, psychiatrists, SLPs, and other neurorehabilitation professionals to understand the needs and problems within the ecosystem of neurology. So once we have understood these problems, we work along with these professionals to create technology solutions to these challenges. Now, some of these technology solutions can be simple in form of taking the existing infrastructure or existing therapy online, or it can be artificial intelligence to create very innovative technological solutions. Now, how it all started. So they say necessity is the mother of all invention, and I think Manastik is actually true in that sense. So my friend and co-founder at Manastik, Soubik Das, is a caregiver himself, and I too have dementia patients in my family. So Soubik and I have seen the struggle in managing dementia patient at a first hand. So when we discussed about this, we realized that some of this struggle can be mitigated. And through that idea, we interacted with doctors, we met with a couple of neuro rehab professionals, and we realized indeed be a solution to some of these. That idea and thought in mind, Manastik was created. From that on, we built our team. So we have a very strong team consisting of technology folks, business, neuro rehabs, SPs, so on and so. So we are incubated by IIM Kolkata and Department of Science and Technology. So this is our team. Pushkaraj and I are leading the business side of it. Soubik is from the, and Miss Sonal Chitnis is a neuro SLP, and she's a mentor to Manastik. Now I'll be talking about some of our interesting products. This is our product portfolio. Some of them already developed in the development stage. Hello, can you hear me? So first, I'll be talking about AOCNR2021 Application, which is an AI-enabled online app that provides feedback to neuro rehab and tracks movement. Next, I'll be talking about communication online exercises that of dementia and also helps in neuro rehabilitation. So let me start with the first product. So AI-based neuro rehabilitation application. So this application is being built in collaboration with IFNR, and this is an AI-enabled application, AI-enabled neuro rehabilitation tool that demonstrates exercises to patients and uses computer vision to identify errors, thus providing an active feedback to the patients. Furthermore, it also helps therapists by providing measurable analytical insights about the movements of the human body. So now I would, on the right, you can see I have the demonstration of the application. Some of the things before I start to look at in this is that a patient has been asked to move his left arm. A few things to notice is that the machine recognizes the movements. As you can see, it has tracked all the angles, and it can say whether the arm is stretched or folded. And it is able to detect the motion, and it is able to provide active feedback. So if the user raises his wrong arm, a message is prompted that he's doing it incorrectly. If the movement is incorrect, then similarly incorrect movement message is prompted. If he's standing in a crooked fashion, then similarly that particular message is prompted. So I will play this video.
Fold your left arm.
The patient is given this thing to fold his left arm.
Wrong hand.
So if he folds his right arm, then a message of wrong hand is prompted. And if you can see the color changes to folded, it's in red. Similarly, if he's moving his right arm, a correct message is prompted. As you can see, the machine is able to track all the angles in real time. It is also able to track all the finger joints. And the machine is, so whenever the arm is folded, it says folded. So machine is able to detect that it is folded, no matter the plane. So even if it is straight or in an oblique fashion, the machine is still able to detect when the arm is straight and when it is folded. Now you can see the patient will attempt to be slightly crooked, and the machine is able to identify it that he is not standing correctly, and he is able to prompt the person to stand correctly.
Stand straight.
So a message to stand straight is prompted, and all the hip angles are turned to red. So when the patient stands correctly, automatically standing correctly message is prompted. And as you can see, this is possible from all the different angles: front facing, side facing, oblique, back. The machine is able to detect all the joints from all possible angles.
Standing correctly.
So that was the demonstration. Now in this demonstration, we asked the patient to move his left arm, but we can also ask him to do other neurorehabilitation exercises, and we could be able to track all the movements of all the joints. Now from a therapist standpoint, so not only this application provides feedback, active feedback to the patient, but also from a therapist standpoint, it measures impactable insights, analytical insights into the motion. So as you can see here, I have an illustration of the left elbow angle with respect to time. As you can see that it is being able, so the machine is able to track the angle over a period of time. It can show insights like the minimum, max angle, min angle. It can also show the wavelength between the angles. So you can see over here that earlier the motion was rapid, and later on it became slightly slower, and gradually the angle between the arm of the motion also reduced. So some of the unique features of this application is that it uses computer vision to track angles, velocity, moments, and repetitions to identify error and provide live feedback to the patient. Not only that, but it also provides measurable and analytical insights to therapists, ranging from motion analysis, error analysis, and so on and so forth. So the application for this are endless. In terms of challenges that we are addressing, so I mentioned the challenges in the beginning. We are addressing accessibility. So this application will be hosted on mobile phones and laptops. So it will be accessible to the general patient, and we will be addressing affordability. The second product that I would like to talk about is an online communication board for aphasia patients. So this online communication board was built by Manastik Association of India. This communication board offers patients with aphasia a tool to communicate in regional languages. So as you can see on the right, I have the snap from the application that we are building. Unique feature of this application is that this communication board is available in various regional languages. And other thing is that it has simplistic design and a nested structure, which provide ease of navigation to the patients. So by nested structure, I mean if a user presses one icon, he is prompted to choose from a variety of icons. So for example, let's say if I have to communicate that I have to go somewhere, I can press I have to go, and then I'll be given an option to choose from a hospital or a clinic or a theater, so on and so forth. The third product that we have built is online exercises in regional languages for aphasia patients. So this is built in collaboration with Dr. Bhatnagar and Ms. Sonal Chitnis from Aphasia and Stroke Association of India. This application lets SLPs effectively administer neurorehabilitation exercises to aphasia patients online. So, and on the right, you can see some of the snaps from the application. So there are a variety of exercises from which the SLPs can choose and administer on their patients. Not only that, but the data is also recorded and is tracked, so the SLPs can effectively know if the exercises are actually making an impact on the performance of the patient or not. Some of the unique features of this application that we have built are that these exercises again are built in various regional languages, of course, to promote accessibility and break that barrier of diversity in India. SLPs can track measurable aspects like time taken to answer, closeness of the answer, and overall performance over time. So when we implement artificial intelligence solutions in the background, we can track some of these softer aspects which generally SLPs tend to kind of miss out. So these aspects can be tracked, and the performance over time can also be measured. So it gives a very, very measurable aspect to these tests. And as the exercises can be administered online, it connects SLPs with remote patients. So again, the connectivity issue, because most of the patients fall in rural domain, it becomes very difficult, especially in times of COVID. It becomes very difficult for them to come to the clinic. So this online app can be administered in an online fashion. Lastly, I would like to talk about the ecosystem for dementia. So as I mentioned, that Soubik and I both have dementia patients in our family, and we have seen the struggle firsthand. So this prompted us the idea to build this application. This application provides a one-stop online ecosystem for healthcare professionals, caregivers, and dementia patients. So it provides features like dementia screening and tracking, neuro rehabilitation exercises, and lifestyle management tools. So on the right, you can see some of the snaps from this application. We have different icons wherein a patient can take cognitive tests, doctor administered cognitive tests. Then there is a feature to record user history so that the summarized report of the history can be generated and shared with the doctor easily. There are lifestyle management features for caregivers, and along with discussion forums, blogs, and so on and so forth. On the right, you can also see that we are attempting to digitize the HMSC test with guidance from doctors from NEMATS. So we have created this HMSC test, which is an test can be administered by the doctors in an online fashion. So unique features of this application is that it provides a one-stop solution to manage dementia. As the tool can be used online, it connects healthcare professionals with remote patients. And lastly, this is built in guidance with neuropsychologists from NEMATS. To give you an overview of this application, the primary aim of this application is to enable doctors with an online tool to help with neurological evaluation and cognitive testing for people suffering from dementia. So these tests can be used as a screening tool or as a tool to track the progression of dementia. Along with that, as the main feature, we also provide additional features like summarized report creation, creating a one-stop solution for dementia patients, wherein patients can stay connected with the doctors, caregivers can stay connected with the patients, and thus create an ecosystem for dementia patients. Third, we also provide caregiver lifestyle management features, wherein we answer different questions for the caregivers, so on and so forth. And lastly, this assessment of cognitive, so the data from the assessment of dementia screening and tracking could actually help in neuro rehabilitation exercises. So from the data, we can pinpoint the location where there is degradation, and we can suggest neuro rehabilitation exercises in form of brain engaging games and puzzles. So that is the whole ecosystem in a nutshell. With this, I would like to conclude, and I would like to say that we are making an attempt to incorporate technology in neuro rehabilitation, and in a way trying to provide holistic care for the patients and attempting to take the care from hospital to home. Thank you.
Thanks so much, Akshay, for that, cruising us through this interesting array of applications, which I am quite sure are going to be very useful for the neurological patients suffering from disorders like aphasia and dementia. And this is a need of the hour. In fact, like we were discussing earlier, the pandemic has prompted the use of technology into for utilization in the area of neuro rehabilitation. But I think the fruits are really there to On to the final of the session, and by none other than my friend and colleague, Professor Dr. Lakshmi Narasimhan Ranganathan. He needs no introduction, but I would like to introduce him as he's the director and professor of neurology at the Madras Medical College, and he's been closely associated with various areas of technology in neuro rehabilitation, and also he's the executive member of the Indian Academy of Neurology, and regularly is in charge of the CME of the Indian Academy of Neurology. He's an excellent academician and a great teacher, and we look forward to listening to him on digital devices in cyberspace. Lakshmi.
Thank you. Thank you, sir. Am I audible?
Yes, please go ahead.
Okay. So I now move on to, so thanks for the opportunity by the IFNR, and thanks to Professor Nirmal Surya and his team for this wonderful conference where we get to know the interface between so many lovely talks, and I'm really delighted that he has done this, because the most important thing is the connect between the technologists and the neurologists, which is very, very essential in every field. Like all my previous speakers have really excelled and stimulated me to get into it. So I move on to the digital devices in the cyberspace as is my talk. And the neuromodulation, if you look at, the major things are neuromodulating devices, sensory substitution devices, wearable sensors, and virtual reality. The digital devices, if you really take them, are these four, and then in the neuromodulation, it's a result in modulation of the neurons causing alteration in the excitability of the cortex and neuroplasticity. It brings about the change in the network behavior, then improves structural and functional efficiency of the neuron process, and remapping of the cortical map following the insult. So essentially, we try to modulate the network. There are two kinds of modulation, invasive and non-invasive. The invasive ones are the deep brain stimulation, epidural motor cortex stimulation, epidural motor cortex, the sensory cortex stimulation. The non-invasive ones are transcranial magnetic stimulation, transcranial direct current stimulation, and pad associated stimulation. And essentially, the invasive ones are more therapeutic, and the non-invasive ones are more rehabilitative. So, the neuro rehabilitation one, I chose the non-invasive one, where the basic principle is stimulational and conformational. Non-invasive neuromodulation is based on the correction of interhemispheric imbalance following an insult in one hemisphere. This is accomplished by either stimulating the injured cortex or inhibiting the healthy cortex and resuming the balance between the two hemispheres. And if you look at this, stimulation of the instillational one is by high frequency TMS, anodal direct stimulation, or pair associated stimulation with an interstimulus interval of 25 milliseconds. Whereas the inhibitory one is the low frequency TMS, cathodal direct CGS, and pair association with the interstimulus interval of 10 milliseconds. So then in the transcranial magnetic stimulation, repetitive TMS is a very safe, painless technique based on the application of magnetic waves to the scalp via coil in the repeated pulse mode. So this is what it exactly does, and then they're modulated. This results in neuromodulation. This consists of applying a series of same intensity magnetic stimulation given for a given frequency ranging from 1 to 50 stimuli to a targeted cortical area. It modulates the cortical excitability by suppressing or facilitating the cortical process for a variable period after the end of the stimulation. Low frequency RTMS is 1 Hz, and it decreases the excitability, and high frequency RTMS 3 Hz enhances the excitability. This is the basic principle of RTMS, and has a lot of positive effect on motor recovery in stroke, especially with subcortical stroke, and low frequency RTMS, the unaffected hemisphere may also be beneficial than a high frequency RTMS over the affected. As I also already told you about the instillational and the conformational stimulation. And the effect of low frequency RTMS on aphasia stroke patients, the meta-analysis of randomized control trial, and has proven that 90% resting motor threshold that targets the triangular part of the right inferior frontal gyrus has a positive effect in language recovery in patients with associated following stroke. Studies suggest that the sessions of RTMS may improve some of the cognitive symptoms after a stroke and visual spatial negative. In the spinal cord, high frequency RTMS applied over the primary motor cortex will increase the excitability and increase corticospinal inhibitor in stroke, thereby reduces the spinal excitability and limb significant improvement low excitability motor score and walking reduces spasticity. And transcranial direct electrical stimulation, applying a galvanic current, constant continuous current at low intensity 1 to 2 milliamps via two large non-metallic electrodes and wetted by a saline solution. Transcranial current stimulation for improving activities. A lot of evidences to show moderate quality of the effectiveness of TDS versus control, improving the activities of daily living following stroke. Improved naming after transcranial direct stimulation has been shown, and long-term effects of transcranial direct stimulation on with anodal TGF together with specific language training over a regular period of time has resulted improvement in the language performance. The dual TCDS over the bilateral posterior parietal cortex effective method for treatment of unilateral neglect. So, to cut short, all the various aspects of stroke can be enabled by either by a transcranial magnetic stimulation or by a direct current stimulation, anodal or cathodal. So then coming to the paired associative stimulation, an electrical peripheral stimulus applies to the median nerve at an intensity of 300% of the perception threshold, and the magnetic cortical stimulation of PMS applied to the cortical motor area of the hand to induce lasting reversible specific brain plasticity. Time interval between the two stimuli is fundamental. What is doing is we are trying to see both the paired stimulation, one on the cortex and the other on the peripheral. At the time interval, if it is interstimulus interval is 25 milliseconds, it facilitates, and if it is 10 milliseconds, it is inhibitory. So you can decide on what kind of function you want to do by combining the cortex and the peripheral. It's called paired associative stimulation, which has really proved very good in subcortical infarct and proposed as an early add-on therapy to optimize in training-induced spasticity process. And spike timing dependent processing of residual corticospinal motor neuronal synapses provides the mechanism to improve the motor function after spinal cord injury. So coming to the sensory substitution devices, growing body of evidence because I have been canonic view of sensory specific brain. Brain is task oriented and sense modality independent. What I'm trying to say is, if you look at the case, if you give digital signals to the optic nerve to the spiral ganglion of the sound, automatically it homes to the visual area. So listening to the sound echoes activated by the visual rather than auditory cortex in blind echolocation experts happen. Braille words in a congenitally blind individual, you can see that they localize in the visual word forming area. Sensory substitution devices have been best studied in the visual domain. Invasive, non-invasive sensory substitution devices. Invasive approaches where retinal processing using a signal processor to convert camera captured visual information into patterned electrical stimulation directly on the retina and useful intact eye and the damaged visual system. And the rest of the visual system past the ganglion, especially in retinitis pigmentosa, where the ganglion is the bypass the layer, we take the therapy as a main therapeutic approach. And miniaturization of this component, especially the process, is enabled whether these should shrink on process size devices, smartphones. Wireless revolution enabled the device to be mobile and less obsessive. And there's a very interesting program which I downloaded and saw called Voice SSC. What happens is the pre-existing smartphone or laptop and earphone, following a brief training, blind individuals are able to perform tasks relevant to the understanding the traits of the object. So various traits of the object are converted into the auditory mode. For example, the area is, the surface is rough. It is converted into a particular code in the audition and then given in the form. So each attribute of the visual area is converted into an auditory component and then fed into them. And when he's asked to describe the object in front of him, he's able to fairly do a good score. In fact, we tried with a couple of our patients who lost their eye, and the depth perception fairly a good one, quite interesting. And It's obstacle avoidance, depth perception, motion detection, reaching, object recognition, or the various modalities where it can proceed. Combining an SST with retinal processing, such a system will include a camera consistently capturing the images of the surroundings and a processing unit. Unit converts the visual information to auditory SST representation, then neural stimulation conveyed by the processor approach. SST will serve as sensory interpreter, providing an explanatory input to the visual signal. And this signals can be given either visual to neural, anywhere auditory or even tactile. The image is grabbed and then converted into tactile stimulus and given it homes to the visual area. So the combination of the processes with SSD. Then wearables. Wearables are inertial measurement units, potentiometer. A lot of the things my previous speakers have said, I don't want to go into them. But just to say that inertial measurement unit measures the movement of the limbs. Linear movements are measured along the linear accelerometers and angular acceleration using gyroscope. Potentiometers measure the angular displacement and detect the movement of range of the joint, and surface EMG, as we know that the contraction they measure in the various contractions of the muscle. And the cyberspace, the presence and the consciousness, these are the two things, and various inputs are given by this. And just take you. So just to show you, this is a simulation one where I don't know whether you were able to hear the sound. I'm not sure, but anyway, we can simulate the vestibular apparatus even without any movement. You are sitting on a chair and you are immersed into a environment where your vestibular, and this is used in the rehabilitation of the vestibular. So head-mounted display, omnidirectional treadmill, body engaged, facial source. So the presence and the consciousness, scanners for gesture-based interaction, body engagement, and the haptic input from the sensory vest. You wear a sensory vest which can give a haptic input to the body and it's close to the brain. So the immersive or non-immersive, this is, for example, this is a desktop immersion where I immerse you into an environment of nature, and or I can immerse you into a beach area. And acute, what we are trying to do is, with all this various attachments and using the VR, we are able to immerse the patient into variable environments which the patient is fond of. So ultimately, the exoskeleton haptic feedback, you can see the exoskeleton, you move the thing and the exoskeleton, you can always play the. So this is the omnidirectional treadmill. So virtual reality in neurology has been successful. Psychotherapy for the management of anxiety and phobias, where I keep immersing you into the area where suddenly, you're flooding the patient of the phobia into the environment through, or you can do a graded controlled exposure of this compared to cognitive behavioral therapy. So as I told you previously, these VRs are very useful in gait, arm rehabilitation, cognitive and pain management. And coming to the pain management, where in the gait and balance, neuroplasticity and motor learning, the popularity of virtual reality is growing, and especially in Parkinson's, home-based virtual reality training is conventional, is an add-on tool. The conventional balance training in Parkinson's, you can see from the home-based, how does a home-based balance training looks like, where the patient stands and then tries to do the various kinds of things which will improve his balance. Control group was trained with the licensed physical therapist. The original group was exposed to the home base. After the experiment, they did all the tests and the outcome was fairly good. So the same balance and gait training can be used in various aspects of this. And various studies to show that, so I don't want to. The home-based VR is superior to the conventional training. 10 sessions for stroke and 14 sessions for 3D. Weight shifting, treadmill VR, obstacle negotiation, dual tasking, and various protocols are used. You can see a non-immersive virtual reality component treadmill to reduce the fall in risk in older individuals. So, virtual reality in arm rehabilitation principle is again the same thing, neuroplasticity, motor learning, task-specific, interactive, game-based rehabilitation for sports. You can see the patient, if you have to play games, the games can be an underwater fire game or a goalkeeper game or a big hunter game or a roller coaster game. You can see that even for lumbar radiculopathy, for the disc, various movements of the disc, the sensor mat is kept and you are asked to move the hip in a particular direction, which relieves the for example, L1 root pain. You keep moving the hip in such a fashion which is linked to a computer camera to a football game. So you keep moving the ball, negotiate the ball. The exercise is literally moving the hip in a direction where the L1 root pain gets relieved. But you are immersed in the environment where you are trying to score a goal. It can be even they are giving even avatars where you are part of the Manchester United or a Liverpool team where you try to score a match where you are getting treated for an L1 root pain. And Rehab Master invention is effective in patients with chronic stroke, and Rehab Master plus occupational therapy has greater improvement in the in various index assist methods. The virtual mirror, which I just want to, so this is the virtual mirror modulation of movements achieved by combining the two methods. The actual movement and the amplified limb movements, you keep looking at the targets and then combining this movement, amplifying the amount of movement that you expect the patient, it works on the biofeedback principle. Then virtual reality in cognitive, I was impressed with the work of my previous speaker, Manasik. Can a patient with dementia be capable of using VR? What is VR suitable for persons with dementia? Exploring the VR possibilities of the patient with dementia, where he is asked to his familiar environment where he is allowed to navigate in the virtual space. Cognitive training on stroke patients via virtual reality-based serious games. There are so many games available on VR. Results suggest that there is a beneficial role of this approach in memory and attention functions and pain management. This is one important thing which I want to say. As I already told you, how we can immerse you in the pain. During the acute pain, when pain and pleasure come, they have the same circuit. So in an acute pain, when I immerse you in a pleasurable environment, your pain scale gets reduced. Even I have shown in creating one to a group of neurologists here, acute migraine, I have immersed them into using a VRML environment which we created and shown them the pain score. From a score of 9, it has come to 2 even without any medication. So what I am trying to tell you is this immersion is going to be one minute. I'm sorry about this. Yes. You can see the pain gated theory where you immerse the patient in pain and then it goes up. So pleasure and pain, as I told you, complete the same pathway. You immerse them in the pleasure and the pain goes away using the various, it's been proved by the time and again when you immerse them by functional MRI experiments that they all get improved. And safe environment, patient enjoy the session, good compliance, increased confidence to the patient, motivated, cost less severity, and the virtual reality is going to be the future. So last slide, there's a new technology called the sonoception technology, where the proprioception from the muscles, the interoception impulses from the heart, the vestibular impulse, the interoception from the stomach, all this internal world to the wearer, decide the experience of what the wearer feels. Sonoception plus VR, a new dimension, the psychosomatic experience called sonoception, they are going to rule the world in future. Thank you so much for your attention. I'm sorry for the hang up in the middle. Thank you.
Thank you, Lakshmi. And we have come to the end of the session. Do we have any questions? I don't see here any in the chat box. Have any questions been posted to any of the speakers? If not, I could ask some. Maybe
you can go ahead with questions.
Okay. And has my co-chair joined? I could see his name here in the. If Dr. Biplav is here, please Biplav join us.
Yeah, sir. Hi, sir.
If you're around.
So good evening, everyone.
Hi, Biplab. Please join. So welcome my co-chair.
Hi, Dr.
Biplab,
Biplab.
maybe
Yeah,
you can.
so,
And
yeah.
before we
I'm
go
not
ahead,
able to join.
I would.
I cannot start my video.
Okay, okay. Go ahead without the video. You can. So, Biplab, if he's, are you available to be with us for some time?
Yes, sir.
So
Yes, sir.
before we
I'm
go ahead,
here.
yeah.
Right, sir. Right. So,
So
I'm sorry. Actually,
right. So
good evening to
we've
everyone. So this is I was occupied in an emergency case.
So we finished the 4 lectures
sir.
and now we're at the discussion
Yeah.
part. I think before we go on to the discussion, we could also apprise the faculty about the NATI. So since this is all topic on technology, on AI and machine learning, you could tell something about NATI and what are the aims of NATI and the plans that we have for the future.
Dheeraj, precisely that is the
future.
reason. Dheeraj, precisely that is the reason I thought that both of you should share this session, because we are developing certain things. Professor Prabhat Ranjan has been pioneer in developing artificial intelligence and technology, and it would be wonderful if we work together on one project each.
Absolutely.
So that we come out with 3 or 4 concrete projects over a period of 1 or 2 years. I think that is what my aim is, to get together. Lakshmi is there, Nata is there, and then IFNR is there, and then I and telemedicine is there. We work together to come out with such extraordinary things.
And actually, those were the thoughts coming to my mind when I was listening to all the amazing technologies which are being showcased in the various lectures. It's definitely a very I would say an interesting path ahead. Yeah, go ahead, Biplab.
Oh, sir, please go ahead. So there is some signal issues here. So can you hear me?
Yes.
Yeah. You tell us about NATI maybe, and apprise everyone of NATI.
Well, so thank you very much, sir. And I'm really sorry that I couldn't join in time. This is because one stroke patient came. A stroke as usual, this is an emergency thing. So this patient had, just to give a summary, small things. So she had a SH actually. So we had to take this patient for coiling. Anyway, so that's different. So it was wonderful to listening to Lakshmi sir, and others might be, so many interesting things which has come up. So as Nirmal sir and Professor was talking about NATI. So just to give you a short, descriptions regarding how the concept came up. It was a concept before even the pandemic, right? So we had a conference, national level conference in Guwahati for more of a stroke and other things, and that's how we this one to reach to people to all over this in subcontinent through tele sort of things, where we find that there is a lots of gap, especially reaching to people who are not in metros or some other where the facilities are limited, like the rural area. So we want to reach to those not only patients and establishments where we can connect with them in terms of not only stroke as a whole neuroscience, which includes Parkinson's disease, dementia, and others. And we want to work in that direction so that tele-neurology as a whole, so we can work and develop some programs, develop some gadgets, develop some which are AI based. And as you said, AI is the future of this is everybody agrees for the same. So as you said, so we are really looking for some collaborations where we can work for not only stroke patients, especially patients who are having aphasia, where we can work to help them, because the patients who once they are being discharged from hospital, they have they have lots of problem communicating with the medical staff. This is not this is maybe because of pandemic situations, or even without that also. And we really see there is a significant potential where this will work. I mean, the AI and then tele-neurology. So that is how we come up with NATI. And I'm sure, I mean, you might having some concept or something so to work on this field. Dr. Khurana, sir.
Yeah, so we actually had great presentations by all these speakers, and they were showing the applications of AI brain-computer interface and how they were actually being put into use. It's no longer a dream, it's a reality which is already being used in patients. So NATAI, as Biplav was telling us all about, is the Neuroscience Academy of Telecare and Artificial Intelligence, and we all invite, it's open for membership, and the details are soon going to be on the web, and we will soon, of course, contact definitely each and every person who's connected with AI and deep learning, and we hope to build up a strong network as well as solutions for patients. So going on to the discussion, I don't know if there are any questions which have come up. So one question I have for Lakshmi is, anything, or any of the speakers can tell me, do we have anything for visual rehabilitation in nano or posterior or PCA territory strokes? Effective rehabilitation.
Not in
Lakshmi?
Indian scenario, but I don't know.
Yeah, tell me.
Lakshmi sir.
If anyone who probably, apprises us.
So if you could
we
go
do
to
have
the
anything.
Moss Rehab Center, University of Pittsburgh, they would love to connect with people and get it into validation in different languages. There's a virtual reality rehab, what they want, and the reality, virtual reality for the RHD, for the PCA, and lot of posterior cortical variant they had actually been working on. So that one can actually look at Moss Rehab Center.
Hi, Dheeraj, Abhishek here. Hi, Dheeraj, Abhishek here.
Yeah, hi, Abhishek.
Hi. There's
Abhishek.
no remediation approach right now, but for compensation, something called as eye tracking devices now. So Tobai is a Swedish company, which has office in India also, and they have a system for alternative communication. Only if you have eye movements, even in people with pontine strokes and those who have locked-in syndrome, even those can communicate with eye tracking system. It's possible now, but it's more of compensation, not remediation approach.
What about happening? I was going to like you have loss.
And even I think Professor Ranjan
cortical loss.
Also used some devices long back with the head movement to track. So a lot of technology is available now at low cost in India.
Abhishek sir, can we begin the session?
Yeah, time to move to next session.
More questions, we can end the session.
Yes, sir. We can take quick one question because we have MND session to be started in next 5-10 minutes.
Is there any question which has been posted by anyone? I don't see any questions.
No, there are no questions.
No, question answered.
Okay. Okay. Then I think maybe Sonal, you can take over and we can finish the session.
Because invite for the next session, please. Thank you, Dheeraj, and thank you, Biplav, for joining it, and thank you all the speakers. Sonal, on stage.
Thank you.
Yes, sir. Thank you so much, all participants, delegates, and faculty. Now we need to move ahead to the next session, which is neuron disease. Could I have all the faculty and the chairperson, please? Mansi, could you please flash the session details? Yes. So good evening, all. We have a last session of the today's second day AOCNR, and we have chairpersons with us, Dr. Arindam and Dr. Rahul Kulkarni, sir. I welcome chairpersons of Symposium M&D.
Hi, Sonal. Good evening. My
Hello,
best
sir.
wishes to Dr. Surya. Is a
Could I have chairperson's slide, please?
de facto mentor for me. So it's good to see him.
Mansi, next slide, please.
Dr. Palande.
Hello.
Good evening.
Good evening.
Has my co-chair, Dr. Dheeraj, joined?
Dr. Rahul Kulkarni, sir.
Dr. Rahul Kulkarni.
No, sir. I'm in just
He'll
contact
join.
me.
He said he's joining. He's in the stroke summer school. He's coming.
Right.
We will just introduce you and you can take it ahead, sir.
Sure.
Mansi, could you please flash Dr. Arindam's slide? So we have 4 enlightening discussion sessions with us, speakers with us to discuss about MND and the neurorehabilitation. I welcome Dr. Arindam Ghosh. Slide, please.
Thank you so much.
Next slide. Next slide. Could I request Surya sir to please introduce Dr. Arindam and he can take the session ahead.
Okay, so Arindam Ghosh is a neurologist, very young, dynamic, from Kolkata, and as I know him, he is the most dynamic neurologist at this age, and he has been very active in various activities being held in Kolkata. So I welcome Arindam, and he's here because I requested him, and he loves me so much. Thank you, Arindam. Welcome to
My pleasure, sir.
IFNR.
My pleasure. All right. My best regards to Dr. Surya, Dr. Palande, and the entire team at the 4th Asia Oceanic Congress on Neurorehabilitation. I know Dr. Surya has kind of revolutionized the field of neurorehabilitation in India. It's an often neglected field, but I think perhaps the most important field of neurology, because once your acute therapeutic options are done with, I think it's rehabilitation that makes a great difference to the lives of patients and people and their family members. And on that accord, motor neuron diseases are an inexorable set of diseases which relentlessly progress once they have been diagnosed. They affect the lower motor neurons, the upper motor neurons, and very often a combination of both. But whatever the underlying pathophysiology and the areas of the body that they affect, the classical picture is that there is an inexorable, relentless progress of death of motor neurons. And typically, we find that many of these patients find it difficult to chew, to swallow, to speak, to have full functional skills of their limbs and their truncal muscles, and they progress quite rapidly. So particularly in motor neuron diseases where therapeutic options are limited, neurorehabilitation is of utmost importance to make life dignified for the patients for whatever number of years they have left with them, also to alleviate some of the chronic problems that their caregivers suffer from. Without further ado, with that brief introduction, I'd like to welcome 4 of the eminent speakers who will be speaking at this particular session from this nation as well as abroad from Malaysia. Without further ado, could we ask Dr. Latif to, would you have her slide, please? She's going to be the first speaker for this evening, this session. Dr. Latif is a master's degree holder in rehabilitative medicine. She's a fellow, she's got a fellowship in neuromodulation from Howard University. She's a consultant rehabilitative physician from Malaysia. And she will be speaking today on rehabilitation of motor neuron diseases, the disease issues and outcomes. She's been outstanding professor and faculty of medicine at the University of Malaya, and she's got several trainees under her whom she's trained over the years. She's the National Motor Neuron Disease Medical Advisor since 2015. She's got multiple publications. In particular, she's written a chapter on the motor neuron diseases in the clinical handbook. That's quite a recommended book if people are interested in neurorehabilitation. And she's an esteemed speaker who's spoken at various conferences and workshops. We welcome Dr. Lydia Abdul Latif. Dr. Latif, if you could enlighten us. Dr. Latif, please.
Greetings from Kuala Lumpur, Malaysia. Namaste, and thank you to those who are tuning in, and my sincere gratitude to the organizing committee of the AOCNR 2021 for rising to the occasion in organizing this virtual conference in this unprecedented time. And my sincere thanks to Dr. Nimar Surya for the kind invitation for me to be the faculty in this auspicious meeting. So today, I'm Dr. Lydia Abdul Latif, and for this symposium, I will be sharing with you on rehabilitation of motor neuron disease, the issues and outcome. For your information, I'm actually recording this in the hospital, so hence I still need to put on my mask. Okay, so this lecture also goes to the PELS and CALS. As we know, PELS and CALS are the two common terms referring to people living with ALS and carers for people living with ALS. So these lectures are dedicated to them. Just a short disclosure, I have no conflict of interest, and all the illustration based from my patients from University Malaya as well as Regen, and may not all be of PELS. And there will be videos, but this is not intended for promotion. So I'm Dr. Lydia Abdul Latif. I am a consultant rehab physician as well as the chief medical officer of Regen Rehab Hospital. This is the first private rehab hospital for Malaysia. And I also serve as a medical advisor for rehabilitation for Motor Neuron Disease Association Malaysia. Okay, so in University Malaya, we have always tried to push forward the agenda for motor neuron disease because of its low awareness. Hence, in year 2012, we set up a multidisciplinary clinic together with our colleagues from neurology and palliative medicine, together with us in rehabilitation, to provide easy access for our PELS and CAL to access healthcare facilities. So this is aligned with what is being practiced in the more higher income countries. So when we talk about motor neuron disease care, we are looking at three major aspects of management. The first, neurology, rehabilitation medicine, and palliative medicine. Neurology will be involved in the diagnosis, looking at the investigation, and looking at the criteria of the diagnosis, because we know that making a diagnosis of motor neuron disease is not easy, and sometimes this may delay the diagnosis of the patient. Rehabilitation will look into the aspect of impairment, disability, and provide a comprehensive functional assessment and rehabilitation intervention. Palliative team will look into the advanced care planning. They will suggest the suitable non-invasive ventilation, discuss on end of life, as well as provide bereavement support. So for today's lecture, I will briefly introduce a little bit on the disease, describe the process and components of rehabilitation, and then we look at the case illustration of various stages of motor neuron disease. So we know that motor neuron disease is a devastating neurological condition. It is a rapid progressive paralysis leading to death in most within 5 years. Patients who was previously normal will lose functional ability to walk or use their arm, to speak and swallow, and to breathe. So at any time, there are estimated about 2,000 PALs in Malaysia. And in the clinic, we see about 600 new diagnoses per year. This is more common in males, and the youngest onset is in early 20s. So these are two personalities who had MND. The first one is the famous footballer in Malaysia, the late Super Mok. And the second one is, I need no introduction, is the late Stephen Hawking. So if we look at the different types of motor neuron disease, ALS is the most common adult onset of motor neuron disease, and it has got the median survival of 3 to 5 years. The second type is predominantly upper motor neuron, which is known as the primary lateral sclerosis. And many patients eventually will develop changes of lower motor neuron involvement, and about 77% of them will actually go into ALS. So for those who remain with PLS, their median survival would be 20 years. The third type is predominantly the lower motor neuron. So this is also, it has got variable evolution to ALS, and the median survival is around 5 years. And the last type is the progressive bulbar palsy. This type is the one that presents with early onset of speech and swallowing difficulty. Hence, their survival is so much shorter, which is 2 to 3 years. So this is actually a paper that our team published looking at the natural history and clinical features of ALS in Malaysia. So we had around 144 patients who had attended the multidisciplinary team clinic. So in this paper, in this cohort, as I mentioned, there are a lot more male compared to female, and majority are in the middle age group, that is between 46 to 65 age group. You can see about 57.6%. And if you look at the ethnicity, predominantly we are seeing a lot more Chinese, but this is also because we are in a very urban setup. And the type, of course, the classic ALS dominates the most common, as what we have mentioned, the different type. Okay, sorry, just going back to this. And if you can see the average ALS functioning rating scale, the average score for this cohort of patients is 37, all right? So rehabilitation is a process of assisting patients to maximize function and improve quality of life after certain health condition. So in ALS, although there is no curative treatment, rehabilitation is important and is required at certain stages of the disease process. So if we look at the rehabilitation management, like I said, we focus on managing the impairment and disability. We reduce complication due to immobility, bedridden, such as preventing contractures, lung infection. We must try to improve as much function as possible. Rehab is very goal-directed and individualized, even though they may have the same diagnosis, but their treatment is completely different. So it all depends on the disease impact and the natural history. So because the progression of ALS makes prescribing rehabilitation intervention challenging because of the rapidly changing clinical impairment and functional status. So here we look at what are the common rehabilitation issues faced by our ALS patient. The top 5 is weakness, followed by dysphagia, dyspnea, pain, weight loss, and speech issue or dysarthria. So many of these symptoms can be addressed by appropriate rehabilitation intervention. For example, fatigue, we can prescribe energy conservation, muscle stiffness, doing stretching exercise, muscle cramp, also similar stretching exercise, and pain, depending on what is the source of the pain. So this is just a simple these are just the simple symptoms that I'm going to elaborate further in this slide. So this is another study that we did looking at the disability profile and the factors that affect functional outcome. And we use the International Classification Functioning Disability and Health. So similarly, we noted that the top impairment is weakness, and this is followed by weight loss, fatigue, and emotional disturbances as well as cramp. When we look at their activity limitation, so it is affected in all domain, mobility, doing domestic chores, attending to their self-care, as well as communication. So this is the activity limitation of the MND patient. So we have got this staging system that look at the level of disability. We divide it into 6 stages. Stage 1, right up to stage 6. Stage 1 till stage 3, they are still able to ambulate. Stage 1, they have only mild weakness, they are fully independent, and they can still ambulate. Stage 3, their symptoms are progressively becoming worse, but they're still ambulatory. Whereas the remaining stages, stage 4, stage 5, stage 6, they are no longer ambulatory and they are already becoming dependent on their carer. So this staging is used to provide appropriate management plan, okay, based on the stage approach, right? So as you can see, it can be preventative, compensatory, or restorative approach that we can take in providing the rehabilitation intervention. But apart from the stage or the severity of the disease itself, the other important factors to consider when we want to provide appropriate rehabilitation management, we need to look at what is the patient's goal. We need to look at the psychosocial factors, social and financial resources. How rapid is the disease course and progression? What is the expected life span or life expectancy of that patient? We want to also see how the CALS is coping, whether they need any form of education, training, and support. And we also need to know when to refer to appropriate healthcare professional. So we work as a team. We have got rehabilitation team, and I know in this symposium, following this talk, we will have talks by the various team member, which is very good, right? So usually the team is led by the rehabilitation physician, followed by the physiotherapists, occupational therapists, speech therapists, rehab nurses, dietitian, psychologists, case coordinator, and the patient is always the center of the care. And we strive to provide the best evidence-based rehabilitation intervention for our patient. So, in a nutshell, rehabilitation management would involve rehabilitation prescription of intervention. We look into providing suitable adaptive equipment, prescribing orthosis, look into the needs of patients, the PALS activities of daily living, wheelchair prescription, as well as environmental modification. So let's look at this from the various cases that I will be sharing. So this is the first case, okay? This patient, his main problem was frequent fall, unsteady walking, and feeling weak over the lower limb. Okay, so let's see his pattern of walking. Okay, so you can see that he has got the problem with right foot drop, which is high stepping, and his left side has got poor swing face, right? Poor swing face, and with no heel strike and quite a flat foot. Yeah. Okay. So prescribing a suitable orthosis. Let's see him using an orthosis. Definitely, it has improved his high stepping gait. Yeah, it improved a little bit, but because he also has involvement of the left side, so there is still rehab intervention that needs to be done, which is strengthening, gait training. Yeah. So apart, prescribing orthosis is important. Yeah. This is another type of neck orthosis that we frequently have got to prescribe, especially when their head control is becoming weaker. So this is called the headmaster collar or headmaster orthosis, right? So this is one of the patient using the headmaster collar to help to support the head. Okay. Next, we look at this gentleman. He has got more impairment. He was complaining of increasing gait difficulty and problems with his transfer. He's beginning to get stiffness of the leg, discomfort, back pain. His speech was becoming effortful and slower. He's already starting to have difficulty with his swallowing. He's already having a reduced weight and overall deterioration in his function. So this is a framework that is adapted from the UK motor neuron disease for physical therapy intervention in looking at the source and intervention of pain in people with ALS. So like the gentleman that I shared, we need to find what is the cause of the pain. So it can be due to muscle cramp, it can be due to spasticity or spasm. It can even be due to musculoskeletal condition. So the management would depend on the cause of the pain. So we need to identify the cause of the pain, right?
Dr.
So
Latif,
using
sorry to
electrotherapy,
intervene. Dr. Latif, I'm sorry to intervene.
wax treatment.
We'd be happy
Okay.
if you could
Therefore, the
wind
question
up
we
for want
ask
of time.
is exercise.
Dr. Latif, sorry to intervene. We'd be happy if you could wind up for want of time. Has she gone offline? Sonal, could you hear me? Can you hear me, Sonal?
Yes, sir.
As Dr. Latif.
Could I request?
Yeah, I think we're running a little short on time.
Yeah. Can you please wind up your talk quickly and flash take home
The
slide?
next speaker, Dr. Mansi Jagtap, to be ready for the next talk. Mavish, if you could share the slides.
Thank you.
Okay. Dr. Mansi Jagtap is an associate professor of the Bharati Vidyapeeth University in Pune. I will not go through a list of wonderful work that she's done and her accomplishments. She's already an accomplished person. Dr. Mansi, for want of time, if you could go straight on to your lecture, please. Bhavesh, if you could share Dr. Jagtap's slides, please. May I also request all panelists to stick to their designated time. Dr. Mansi,
the organizers of AOCNR 2021. for inviting me as a resource person to this esteemed panel. I will be speaking on speech and swallowing disorders in MND through this presentation. We already know that motor neuron disease is a progressive condition that causes degeneration of upper and lower motor neurons. Now, depending on the site of involvement, it could either involve the limbs, the bulbar region, that is the head neck region, or it could be a generalized involvement, or it could involve only the upper motor neurons, the lower motor neurons in isolation, or both these motor neurons can be involved together. When we typically speak about bulbar affection, we see that the patients have problems in oromotor functions, speech, swallowing, and head control. And 1/4 of the patients report that they have bulbar onset when the diagnosis of MND was made. Now, even research shows that majority of the patients with MND have the first site of onset as spinal region, whereas only 20 to 25% of these patients reveal that bulbar area was the first site of lesion for them on diagnosis. However, as the disease progresses, we see that this can spread or it could progress to other regions as well. In a study done by us on 62 MND patients, it was revealed that around 75% of these patients had spinal or the limb onset as the first site of lesion. However, when we carried out speech and swallowing assessment at 1.5 year mean after the diagnosis, we saw that bulbar signs and symptoms were present in 62% of these patients, which again validates the above point. Looking at the table here, we see that dysarthria and dysphagia, that is impaired swallowing and speech, is commonly seen in most of the variants of motor neuron disease, and hence it is important that a speech language pathologist is involved in a diagnosis and management of this condition. Typical bulbar characteristics we see in these patients are oromotor dysfunction, siloria, that is increased salivation, poor speech, and poor swallowing, that is dysarthria and dysphagia. And all this can have a correlated effect on the quality of life of the patient and their caregivers. Now, the oromotor dysfunction, dysarthria, and dysphagia depends on the stages of MND. In early stages, we see a very minimal involvement, whereas as the disease progresses to mid and end stages, we see that there is significant weakness, there is reduced range of motion, there is reduced elevation and lateralization, whereas when we look at the end stage patients, there is no useful movement and the muscles of the oromotor areas are completely atrophied. Similarly, when we talk about dysarthria, we see a typical flaccid spastic type of dysarthria, since this involves the lower and the upper motor neurons. And in early stages, we typically see that the patients report that their voice sounds very low or it sounds very hypernasal. They feel a lot of strain while talking, and there is a slow rate of speech, which they purposely try to make in order to be more articulate and more clear. As this disease progresses to mid stages, the number of speech deviances or speech abnormalities increases, making the articulation, the production of voice, that is phonation, very, very difficult. And that makes the speech sound very robotic and very monotonous. In end-stage ALS patients, MND patients, we see that there is loss of useful and meaningful speech, and there are also audible inspirations that we see in end-stage patients. Looking at the swallowing abnormalities, in early stages, we do not see too much of a swallowing problem. There could be mild salivation, or there could be mild leak from the lips of the liquid. However, we see a significant oral and pharyngeal involvement more in the middle stages. The signs of aspiration are more gross and more evident from the middle stages till the end stage patients. And in the end stages, where the patient is not able to maintain nutrition, or the patient has severe aspiration with non-productive cough, that is when we need to refer them for a enteral feeding. So with respect to assessment, we can carry out speech assessment using a cranial nerve examination. We can also use protocols like the French's dysarthria assessment and speech intelligibility index to understand the functionality of speech. With respect to swallowing, a clinical swallow assessment and tools like Manipal Manual of Swallowing Assessment and MAN Assessment of Swallowing Ability give us valuable information about the swallowing status of the patient. And instrumental assessments like modified barium swallow and fiber optic endoscopic evaluation of swallow helps us to understand the amount of aspiration or risk of aspiration in these patients. Quality of life assessment is an important area which should not be neglected. For this, we can use the ICF model, that is the International Classification of Functioning, Disability and Health model. Or we also have questionnaires to record dysphagia and dysarthria related quality of life among patients and their caregivers, available in some Indian languages. Now, management of speech and swallowing depends on the stage of disease. And now we are turning more towards the proactive management, which means that we can initiate some amount of speech and swallowing intervention before the active signs of bulbar involvement starts showing in these patients. And these are aimed at the best possible outcome, that is to maintain the communication and to achieve safe swallow and maintain nutrition in patients with MND. Looking at the communication in early and mid stages, SLPs can work on individual subsystems like working on voice production, working on articulation using exaggerated consonants. We can also work on prosody like using inflections, use of slow rate of speech using metronome or paceboards. Oromotor exercises to improve strength and range of motion can also be given in these stages. However, in the end stages where no meaningful speech is available, it is the best to introduce and to use an alternate mode of communication, which could be in form of a communication board. Even some patients prefer using writing as a mode of communication. We also have a lot of apps available like the Jello software or text-to-speech app or synthetic speech to communicate better in daily life. And it is also important that an augmentative and alternative mode of communication is introduced early on so that we also work on the listeners and train caregivers for the same. With respect to swallowing in the early and the mid stages, we need to use postural modifications like the commonly used chin tuck posture to reduce amount of aspiration. Maneuvers to protect airways like supraglottic swallow or effortful swallow for better pharyngeal clearance can be given to these patients. And we can modify the consistencies and appliances for these patients as well. However, in the end stages where there is severe aspiration and a very weak cough, enteral feeding is mandatory in order to avoid aspiration pneumonitis and malnutrition. So to sum up, speech language pathologists play a vital role in detailed assessment of speech and swallowing function. There has to be regular follow-up to identify signs of bulbar involvement and also to track the progression in the bulbar region. Timely management of bulbar symptoms is very, very important so that we can prevent progression of these conditions. Decision making at every stage of MND is very important because as we have seen that initially we may not see very active signs of swallowing impairment. However, once the patient starts aspirating, we need to take some decisions whether this patient requires enteral feeding or not. Palliative care needs to be focused on and we have to take family into consideration. So family support and education is extremely important and a part of intervention as well. Thank you very much for your patient listening. I will be open to any question now.
Thank you, Dr. Bansi, for that very lucid lecture. Such a wonderful honor to listen to you speak so much detail about speech and swallowing therapy and its applications in MND. If I could now invite Dr. Deepa Sundareswaran, a renowned occupational therapist from Thrissur. If you could have your slides ready. Ravesh, could you give us a slide on Dr. Deepa, please? Dr. Deepa is Principal and Head, College of Occupational Therapy from Thrissur. Dr. Deepa, without further taking away time from your lecture, we'd like you to address this august audience, please. Dr. Deepa.
Can you see my slides?
Yes.
Can you see my slide? Am I audible?
Yes. Yes, Dr. Deepa, you're audible and we can see your slides.
Okay, all right. Okay, so respected chairpersons, the organizing members, and all the members of AOCNR, my warm pranams to everyone. Definitely, it's a delightful moment as India has won a gold as well. So this is. Okay, mainly I'm going to talk about occupational therapy in motor neuron disease, and I've specifically included adjusting and adapting to rapidly changing functions because this is very common in motor neuron disease where we see the functioning abilities of the person changes as the disease progresses. So, and this always I focus on this because that noble thoughts come to us from all and every direction in the universe as we are deliberating on a lot of things. So that we have a lot of things, newer ideas coming in. So one of the main things as an occupational therapist we need to decide is some decisions we need to take with regard to the choice and the timing of intervention. Firstly, we need to liaise with the other therapists in different settings, particularly to avoid repeat assessments. Secondly, again, with other professions and disciplines, we need to liaise with them and coordinate the visits with other professions where possible, and also signpost the person, the family, and the carers to other relevant services, which I feel is very, very important, especially for when we are dealing with a person with motor neuron disease. And what exactly an occupational therapist can do? Mainly, we can have the optimization of meaningful activities of daily living and what is actually important to that person. And then maintaining of social leisure activities for as long as possible. And main will be the modification of the home environment, then raising awareness, posture and positioning aspects would be considered, fatigue management and conservation of energy, psychological strategies, and avoiding undesired hospital admissions, and primarily use of adaptive equipment, including potential future needs, and then facilitating a meaning and quality of life and well-being, and also to provide support around the physical, emotional, and spiritual issues, and ultimately providing a positive approach to death, because we know definitely it's palliative and death, we need to prepare them for that as well. So these are the things which would be focusing on. So one of the challenges for an occupational therapist would be, we know the progression of motor neuron disease requires very flexible, responsive, and ongoing occupational therapy input. Secondly, there might be a limited time to adjust to the functional changes. By the time you achieve a functional change, you might find another change in the person. So that we need to be aware of that. So there will be a lot of deficits depending upon the phenotype and the onset of location. Then the individual reactions to diagnosis may differ, and there would be larger challenges in terms of funding for equipment and the support in a timely manner that could be there. And it requires a lot of huge psychological adjustments for a neuropalliative diagnosis for individual as well as for their significant others. So with these challenges in mind, I think an occupational therapist would take on. So I have just put up what an occupational therapist would do as a OT process. Here, I would mainly emphasize on the fact of re-evaluation, because we need to re-evaluate them because the disease progresses. What function they had initially may not be the similar function they have at a later time. So we need to re-evaluate them. So based on that, we need to review the goals and have a very intervention should be focused on the goals that we have done. So when we come to adaptations and equipments, we need to anticipate what equipments and adaptations may help the person. So definitely for this, a lot of creative solutions would definitely help in this. So I'll just give an example. For example, the barriers, the adaptations that you make may change the look of the entire home, so that it might bring the person, okay, I'm having a disability, and this is what probably initial phase, what can be done is maybe just have a small ramp with whatever they have, not having too much of modifications there, so that the person will be able to function, it will enhance independence, and because of the adaptation that is made. So, and also they meant the other barrier could be they will have a resistance to living on a single level of the home. So we need to probably can have a stair lift there. So make sure safety measures have been taken for, so those things we do. So we need to be extremely careful when we are suggesting adaptations to a person with motor neuron disease, because that is very essential. These are the few things I just put in, many would be aware of it. the splints that can be made to make them as independent as possible, depending on what functional aspect that we are focusing on. And this is another one, like upper limb management is, we have to make sure the upper limbs are supported very well, shoulder care and all the functions are being taken care of. So definitely we know that electronic assistive technology is really increasing now. So everybody, we need to keep up with the pace of the electronic assistive technology as well. So few things is the main is, what is the process for identifying the electronic assistive technology? So there is no magic single solution to it. First, we need to know what do they want to do, what are their goals for using EAT, and what are the ways to assess the access options. How can they access it? What combination of the hardware and the software is required to achieve this goal? Where do they want to use, like for mounting and positioning? And everything happens with the trial and practice. So when they're able to access it easily, and it leads to better functional outcomes. So these are some of the things, and this picture towards the right, you can see is made by in our institute, because everybody cannot afford our high-tech equipment. It's a simple stand for holding the multi-purpose mobile holder, which is really actually very useful. It can be 360 degrees, it can be turned around, and it can be positioned and used. So again, in the bed, we have where a person can easily access this. Again, depending in the later stages when they want to use it. So when we want to provide an assistive technology, we need to introduce an assistive technology equipment, educate the person about what exactly is the equipment all about. So definitely we all are aware there are a huge variety of aids and equipments which are available. So we need to be very careful in choosing what actually the person requires. So, and in the bed, we can have an alarm, electric bed, discussions of care and sensitivity, so a scanning bed controller can be placed very easily, so this is not very costly too, so this can be very useful for the person. And carer alert, definitely a carer needs to be alert all the time. So how do they know? So make these pictures you can see over the remote doorbells with switch adaptations are excellent. It's low object, low budget, and especially those with dysarthria, they can alert the carer with use of this. This is actually very useful. We have actually installed this. So, and these are the personal alarm options that they want to have, whether they want a 3G, 4G, or 5G, and how they want to do just simple press and you get the alarm, and it's just very useful again. Bed mobility, again, depend on the level of the need. We need to consider a lot of options there, rails and bars, or low friction slide sheets, or a static or a powered pillow lift, and the raising a bed to allow clearance of mobile hoist. So this also helps in from sitting to standing transfers for a person. And next, another important aspect where occupational therapist focuses on communication, mainly in terms of eating, positioning, wrist, standoff, head and neck supports, switches and pointers, mobile arm supports, table to access the communication aids, equipment to support computer use for communication, and the environmental controls. So posture for eating, the occupational therapists need to focus on the appropriate and adequate posture while eating. We need to consider what type of chair, where the table would be in relation to the chair, and the distance between the plate and the mouth, how far they have to lift foot to reach the mouth, and upright posture need to be ensured all the time. And equipment, whenever it is appropriate to the individuals. So initial stages, it might not require equipment use, but later in the middle and the later stages, definitely we need. These are a few of the modifications which can be very handy, like keep warm plates, arm supports, electronic feeders. The cups can be modified. Again, it depends on the cultural background the person is from. And the plate guard can be used, non-slip mats, height adjustable table, head and neck support, and the drinking aids. Again, the drinking aids could be modified. So these are simple modifications which are shown in the pictures at different types of non-skid saying in the house, whichever variety which suits the particular individual, considering the home situation. So we do a detailed home evaluation, and based on the home evaluation, consider the necessary adaptations for them. So we need to work to manage short-term and the long-term needs. Home modifications may afford prolonged independence and safety at home. Most probably we can consider non-permanent adaptations, I would say, because if you invest so much on permanent adaptations, that may not be helpful because the disease is going to progress and we may have to redo it all over again. That's the reason why your said is non-permanent. And these are some of the pictures where you can see the modifications which are actually done there with the mat there. So again, a non-skid mat where it is placed here, so to facilitate independence for a person. So, and the vehicles also, we ensure that it should be wheelchair accessible. So I'm not going much into the details of that. Depending on the vehicle the person is going to travel, it has to be modified accordingly. Again, definitely energy conservation need to be taken care of because they will fatigue very quickly. So we teach focus on task simplification, pacing, avoid peaks and troughs of energy and exhaustion. So we can introduce the aids and equipments to reduce effort on the muscles during transfers and walking. So it's adapt the task, especially when they want to sit down or use long handle aids, and encourage definitely effective resting. So these are some of the simple things while they're lying down, like to make a cut at the cushion where they can just rest a ear, or different well-co-adapted things which would be easier for them.
Dr. Deepa, if I could request you to wrap up over the next minute.
Yeah, it's just okay. This is something ultimately it's the tips for OT practice would be we need to be more proactive, smart and strategic use of funds that is we get, and we still need to have a close to perfect solutions, and we need to be creative and not prescriptive. This is what I always said as occupational therapists. And they definitely, we all are aware that people with MND require regular long-term input and support. So ultimately, we are going to educate them, enable them, and empower them to lead a better life in the society. So this is what the ability to adapt to change can make such a difference to a person. So this is from a person living with motor neuron disease. So with this, I end my talk. Any questions are welcome, and thank you.
Thank you, Dr. Deepa, for that rather crisp lecture on how an occupational therapist would make a great difference in the lives of people afflicted with MND. If I could now invite Dr. Suvarna Ganvir to...
I also welcome our co-chair, Dr. Rahul Kulkarni. He is working in Dinanath Mangeshkar Hospital. He's my HOD, and he's done immense work in neurorehabilitation of MND and stroke. He's profoundly scholar neurologist. Welcome, sir. And yes, you can proceed, sir.
Dr. Kulkarni, welcome on board. Could I, Dr. Suvarna Ganvir.
Mansi, can I have Dr. Suvarna's slide, please? Thank you.
For want of time, I'll keep this rather short. Dr. Suvarna Ganvir is professor and head the Department of Neurophysiotherapy at Ahmed Nagar. She's got several years of experience of teaching postgraduate and PhD students. She's got a list of accomplishments, which you can all quite see. I don't really want to take away time from Dr. Ganvir's lecture. So Dr. Ganvir, could you start your lecture, please?
Dr. Suvarna, could we have her slides, please? Dr. Suvarna, are you there?
I don't see Dr. Suvarna. Has she exited the site?
I'll just check it, sir. May I request you both chairs to please take 1 or 2 questions for previous speakers till Dr. Suvarna joins, so we stick to time and we finish on time. Thank you.
I can't see any set of questions that have been asked in the panel.
If you could please take it few questions from your side?
Yes,
Thank
from
you.
my end. Okay. Dr. Deepa, if I may ask you first.
Yes, sir.
Okay. What is, in your opinion, the most difficult challenges that an occupational therapist faces in India in dealing with patients with MND?
One thing what I feel is, is the rapidity with which the disease progresses. What is like, we would have planned, assessed, and we would have decided on a particular adaptive aid or something for a person. By the time we do, and then the disease would have progressed. And we need to do, that's the reason why I emphasize on re-evaluation, we need to do it. And especially in India, because most of the equipments or adaptations suggested in the West doesn't really suit us, considering the place they are in. Sometimes we need to consider the terrain, it's a plain terrain, or the terrain, the homes is not the same. They might be living in a hut, or so that's the reason I in the talk I mentioned the home evaluation is very important. Whatever is available in the home, I think the modifications need to be done based on that. So that is what I've actually seen here, so rather than those who can afford, and those depending on the home evaluation, yes, we can suggest depending on the affordability factor of the family.
Do you feel it is difficult to train a lot of the caregivers in helping the patients with occupational therapy, because they are equally important, isn't it?
Yes.
An occupational therapist will help the patient understand how to go about his daily chores. It is also equally important to train the caregivers. So how do you go about that?
So with the caregivers, what I do was most importantly, when a person comes in India, usually they are always accompanied by a caregiver. So when they come in the first initial assessment itself, it's like, they're also taken into the decision making and planning for the treatment, educating about occupational therapy and the disease, what we are going to do. In that way, if we do that, I think the acceptance is also much better. If we open the family at the initial stage and we tell them this is what we're going to have, and also helps them to set realistic goals. Because when they come, they come with an idea as the person will be completely all right. So when we in the process, we involve them, I think it really helps. And none of the slides I had to rush through, but then the cognitive changes actually interferes a lot in therapy, if you could see. So making the family members aware of because they have impulsivity, they might be talking irrelevantly, they might be very stubborn, that is being taken as a real behavioral problem, rather than is it because of the cognitive change they have or they're deliberately doing. That is some things I've found the family members have expressed. So where we need to focus on that as well, that when we focus on that, teach them the appropriate communication strategies, I think that has really helped the families.
Dr. Mansi, if I could ask you a question. We do know that there are three phases of swallowing difficulties in patients afflicted with MND: the aspiration or the penetration phase, the oral phase, and the pharyngeal phase. There was an interesting meta-analysis about 4 or 5 years ago, which looked at lack of instrumentation and instrumental objective evaluation of these swallowing phase difficulties, particularly with respect to the aspiration phase and the oral phase. Do we use instruments here? Often in your practice, do you use instrumentation for an objective evaluation of these swallowing difficulties?
Thank you so much, sir, for that question. Yes, we do use both these instrumental assessment, which are the gold standards. So modified barium swallow as well as flexible endoscopic evaluation of swallow. And in some cases, we also would like to use a manometer to understand the esophageal phase of swallowing. And yes, my center has both these instrumental assessments. So we do carry out a clinical swallow assessment, and depending on the criteria, we carry out both these assessments. And I think that helps us to take a very important decision, that is whether the patient is fit to continue with oral feeding or whether the patient is going to require some amount of enteral feeding, depending on the residue, as well as the quantification of aspiration that we do use some scales to make, like the penetration aspiration scale. We also have the yield residue scale, which helps us understand what is the efficiency and safety for swallow. And these both can be used with respect to the instrumental assessments.
Thank you. Also, as a speech therapist, you do understand that communication sometimes is a real problem with these patients, particularly towards the end of their ailments. Do you find that the use of assistive augmentative communicative devices, AACs, particularly the high-end ones, which modulate eye gaze and help communicate through those eye gaze movements, easy to use here in India? Do we use it often here in India?
With respect to the augmentative and the aided appliances, I have tried ETRAN, which a patient can make at home. And I think cost is one thing which many of our patients and carers are not able to afford. So we do go for what is the best possible appliances which would fit into the budget. And some of my patients have also used pointers with pictures. So yes, I think in the end stages where communication is extremely difficult, it plays a very important role to for better communication and facilitate the same. Yes.
Thank you for that answer.
Thanks.
I'm trying, Sonal, is Dr. Suvarna, have you been able to connect to Dr. Suvarna?
I'm trying to connect, sir. In case we don't get connected in next 5 minutes, we can wind up the session. Any other question
I think we are
or
already
comment?
at 6:30, which is our session time, closing time.
Yes, sir. So any
if you can't get through to, I can't see any questions in the chat box. No, I can't see any questions in the chat box.
Anybody in the panel and from the participants in the Zoom, if you have any question for the OT, PT and the speech speakers still yet, or even the speakers can break one single question. Co-chair, Dr. Kulkarni, do you have any comment or a remark? Good evening, sir.
Good evening, Sonal.
Yes, sir. Can we have your remarks?
First, was designing a guideline considering the Indian practice in mind.
Nirmal sir, I think we are running short on time. We are at exactly 6:30. Should we wrap up?
So you finished? All the speaker finished?
No, Dr. Suvarna has left the site and we have not been able to connect with her.
Suvarna was supposed to speak, no?
Yes, she was supposed to deliver the last lecture. That's why we finished the question answers first.
So if no, then we can have one comment from Dr. Kulkarni as a co-chair and from you.
Yes, we'd like Dr. Kulkarni to
then, sir.
Probably make a comment and then we can wrap up.
Yes, we can wrap up.
Why Suvarna was there? Where she went away?
I think she lost the connection, sir. She has some technical difficulties.
Oh, you should have asked for the presentation from her. Anyway, if she's not there, you carry on. I thought one more speaker is there.
Yes, sir.
You were on silent. Sorry.
Sorry, sir. Yes, we can conclude.
Any closing comments from your end, sir?
Rahul Kulkarni has joined, so let's hear from Rahul.
My suggestion, I mean, we know that these are the disorders where it's not just a neurologist job, considering that this is a neurology. But then, we require help of OTPT as well as SLPs in managing these kind of disorders, especially the chronic neurological conditions like motor neuron disease, Parkinson, and even strokes. These are the ones where I think you people really play a big role. Our job is probably just seeing a patient for 5 to 10 minutes, but it is you who really work on patient. And we know that having a good team really would prolong the life of patient, as well as it will definitely give a good quality of life to the patient. And we have seen this in 20th number of patients where people like Sonal are working with our patients. So, it's definitely good to have teams. And I'm sure considering the kind of resources that we have in our country, we should have our own protocols. And depending on our own protocol, we must manage our own patients. So, the timing of maybe tubes or maybe tracheostomy or whatever, it's all individualistic decision. And each team should have his own protocol. And probably as a neurologist, when we see these kind of patients, it is not just that we see what is his condition or her condition today, but probably eventually over next 5 to 6 months, what is going to happen. And that's how we devise a plan. We shouldn't be looking for a very long period, because We don't know what eventual turns the life may take, but at least for near future, we must decide our own plan. And having a good team definitely helps us. And thanks to Dr. Surya that, he's building these kind of teams and getting a good protocols developed in India. It definitely has helped our patients. Thank you.
Thank you, Kulkarni sir, for those suggestions, those points. I'd like to thank all our speakers for taking time off from their schedules and enlightening us about the role physiotherapists, occupational therapists, speech and swallowing therapists have to do in motor neuron diseases. I'd like to thank Dr. Nirmal Surya and congratulate him once again on organizing this wonderfully well. Sonal, thank you for all the backup. And unfortunately, we could not hear Dr. Suvarna today because of technical reasons, but I'd like to extend my speakers for being so crisp and lucid in elaborating the various roles each one has to play in motor neuron diseases. Thank you very much. It's been a pleasure chairing this session.
For the benefit of others, what we will do is we'll have a recorded talk and we'll post it on the website.
Yes, sir, for sure, sir. We'll do that.
Thank you.
On behalf of AOCNR, I thank each and everyone in this MND session who have participated. It was really interactive session. I really thank Dr. Arindam to make this session very interesting with a lot of input. I thank Dr. Mansi, Dr. Lydia, and Dr. Deepa for great insightful talks you have given. And we hereby conclude the symposium session today. Thank you so much. Thank you so much all.
Thank you.
Thank you so much.
Thank you so much, Dr. Kulkarni.
Thank you.
All of you.
Thanks
Thank you very much.
Thank you. Please claim your CRE credits and MMC points. We have claim your credits hit button. We see you tomorrow. Thank you so much all. Stay safe.